Recording in progress.
Please allow my video to start. Devendra bhai.
1 second, sir. संतोष भाई, सर को होस्ट बनाइए या को होस्ट बनाइए.
This is Dr. Ashish here, and I'm still not able to enable my video. Please do the needful.
Yes, sir. Yes, sir. The technical team is working on that. Sorry for the glitches. That is this being the first session. We are facing some technical issues, but the technical team is will
I agree,
soon.
Dr. Santwan, but technical team should have sorted out it before
Agree,
starting
sir. Agree,
because
sir.
the timelines are very crucial. We are judging
Yes,
students
sir.
on
Yes, sir.
timelines.
Absolutely right, sir. Absolutely right, sir. And as a gynecologist, we do understand and we take care. We understand the importance of timeline like nobody else.
Absolutely, the
Really,
technical team
really very
needs to
sorry for
understand.
this glitch, but we are trying our best from our side, sir. ભાઈ હોલ ભીનું કરો યાર નથી થયું હા વિડીયો નથી ચાલતો હજી સેશન જ નથી ચાલુ થયું 10:09 ને 12 થઈ ગઈ યાર સર નથી હજી થયું હો સર હજી નથી થયું હો સર વિડીયો ચાલુ જ નથી થતો અને પહેલા લોકો કહે છે બીજી વાર જોઈન કરો આ કરો તે કરો એ રીતે ક્યારના અમે 20 મિનિટથી લાગેલા છે પ્લીઝ થેન્ક યુ સર જી સર હેલો યસ તમે તો સર સરસ દેખાવ છો બ્લુ શર્ટમાં બસ સર હવે શરૂ થયું થેન્ક યુ સર yes good morning everyone so sorry for the delay for the technical glitches Now I think we are ready for the session. I invite you all and welcome you all for this wonderful, one of its kind conference of SOCOC for the poster and the paper presentation. So we have with us, I would like to thank Dr. Alpesh Gandhi sir and the entire team of the SOCOC committee, Parth Bhai, Hetal ma'am, Akshay sir, everyone to give me this opportunity to coordinate this session. And I also like to welcome the judges for this session, Dr. Ashish Shah sir, Dr. Dipal Shah ma'am, and Dr. Dipal ma'am. So I think we are ready to start our uh, first presentation. The first presentation is the first presentation. I think the presenter is Dr. Priyam Jain.
Yes,
Dr.
sir.
Priyam, are
Sir,
you
but
there?
I can. Yes, sir, I'm here, but I can't start my video. Is it a technical issue or is it?
Okay, let me allow you. Devendra Bhai, please allow everyone to see their video, please. Dr. Priyam Jain is there. Good morning, Dr. Ashish sir, Dr. Dipal ma'am, Dr. Deepa ma'am.
Dr. Santul, we are still not able to start our video, so technical team must look into the matter first.
Yes, ma'am. Yes, ma'am. I'm
Sincerely
asking
request
them.
technical team to sort it out.
Devendra Bhai,
Yes,
please
sir.
allow
On it. On it. Yes, sir. Please, Magistrate team.
now everyone to start their video, please. And Dr. Priyam is also there.
Um,
Dr. Priyam, good morning. I can see you.
yes, sir. So should I share my screen?
Yes, please.
Can we please wait because I want to have an introductory remarks for all the students and then we should start. That's a tradition for any scientific program that we do with the students.
Yes, sir. Yes, sir. We'll do
Okay.
that, sir. I'm just waiting for everyone to connect and start their video.
Dr. Shantun, I'm still not able to start my video.
Yes, ma'am. Yes, ma'am. I think apart from me and Dr. Priyam, nobody is able to start their video.
Okay, no problem.
That's why we are waiting for everyone to start their video. And as suggested by Dr. Ashish sir, we'll start with the introduction of everyone and then we'll go ahead. Devendra Bhai,
Hello,
yes,
Dr.
hello.
Priyam. Hello. Good morning, Dr. Priyam. We are not able to hear you. please unmute yourself. Message karo, sir.
Sorry, sir. Sorry, sir.
Okay.
Yes, sir.
Now you can present your thing. Just share your PPT, and so that
Yes, sir.
judge can see and you can present yourself, right?
Yes, sir.
Before Dr. Priyam proceeds, I understand that there are technical issues, and I hope that by the end of Priyam's presentation, we are ready with the solution of the problem. Let's have some ground rules understood by all the students who are presenting here. So to begin with, we are so happy to see that SOGOG has taken an initiative to have an exclusive conference on research for the students, and I really congratulate entire team of SOGOG for the same. Here with me, I have Dr. Deepa, who is also professor at GMS Gotri, and we both are thankful to SOGOG for the same. The rules for the students, you have 6 minutes to present and 2 minutes for question answer. You should be keeping your video on throughout your presentation and question answer session. And you will try to remain restricted to your timeline of 6 minutes for presentation. And try to include the scientific content more than the generalized introductory content. So with that, we can begin with Dr. Priyam. Thank you.
Yes, sir.
I'm going to stop watching.
So you can see my screen now. So you can see my screen now.
Yes, your screen is visible now.
Yes, Dr.
You can
Priyam, your
proceed.
screen is visible.
Good morning, sir. Good morning, respected panelists. Today, myself, Dr. Priyam Jain. I'm a second year resident of Obstetrics and Gynec Department of MP Shah Medical College. I studied on the topic of outcome of multiple season section in tertiary.
Hello.
Hello.
Yes, please, Dr. Priyam, go ahead. Hello, Dr. Priyam.
Yes, sir. Yes, sir. Wait a minute.
પછી ઘરે આવીને પછી કરાવી.
Sir,
So
I
yeah,
think
my
doc,
screen is not sharing. Matlab, I can see my.
wait a second. I can share your presentation. Okay. You able to see my screen?
I can see your screen, sir.
Okay. Now you can start.
Yes,
Okay.
sir. Good morning, all. Myself, Dr. Priyam Jain. I'm a second year resident at the Obs and Gynec Department in MP Shah Medical College. I studied on the topic of outcome of multiple season sections in tertiary care center It was a prospective observational study. My aim is to evaluate the maternal and neonatal outcomes in women with multiple previous CS sections delivered at tertiary care hospital. So you can proceed to next slide. Background of study. Cesarean rates are increasing globally. Repeated seizure sections are significant portion of deliveries. Multiple cesarean section increases maternal and fetal complications. Early identification of risk factors and improves the maternal and neonatal outcomes. Objective of the studies to study the demographic characteristics to assess the intraoperative complication, assess the postoperative complications, evaluate the neonatal outcomes, and identify the factors associated with adverse outcomes. Methodology of the study. It is a prospective observational study. At the Department of the Obstetrics and Gynecology Department of the Jamnagar. Duration of the study was for 1 year from May 2025 to 2026. Around 100 women I took with more than 2 previous years in history. Inclusion criteria include singleton pregnancy, previous 2 or more LSCS, gestation age at the inclusion is 28 weeks. Exclusion criteria measure fetal anomalies, uterine rupture, and admission or refusal to participate. Demographic profile. As the most of the females are around 28 plus minus 4 years, around mean age of us 28 years. In 20 to 25 years of age, there are 28 females were included. 26 to 30 years of age, 49 females were there, and more than 30 years, there 23 females were there. Mean gestational age around 38 plus minus 2 weeks. Mean parity is around 3 or plus minus 1. Number of cases that are included in the study. 70 were for the more than 22 CS. 24 cases were of the more than 3 CS, and 4 cases were more than 4 CS. Indication for the CS in the present pregnancy. Most common indication was previous CS, previous 2 CS, then was car tenderness, then fetal distress, then sperm, then malpresentation, then placenta previa. Intraoperative complications according to number of previous CS. As the increase the CS, as the number of the CS increases, the complication further increases. For example, as the dance additions were more common in as the dance additions were more common in previous 2 CS. Total, there were 34% cases which have the dance the maternal mortality in around 28 and have the live birth. National admission.
Dr. Priyam.
Hello, sir. You can hear me?
Yeah, please go ahead.
Yes, sir. Neural outcome around 98% were the live births, and ICU admission were 15%. Low birth weight around 18%, and Apgar less than 7 at the 5 minutes around 7%. Parental mortality around 2% in post-operative patients. Comparison with other studies, silver NM study around there were in my present study the addition were less compared to other studies, where PPA is more and the placenta accretor syndrome was similar to the previous studies. Key findings of my studies: maternal morbidity increases with the increasing number of years, that is 16%. Dance addition were most common complication, it is 34%. Blood transfusion needed was 18%. Postpartum hemorrhage was 16%, placenta access syndrome incidence was 3%, and neonatal outcome remained satisfactory. That is, NICU admission was 15%, low birth weight was 18%, and parental mortality was 2%. Conclusion of the study: multiple repeated cesarean section is associated with increased number of maternal morbidity. That is, number of thence addition one more compared to in the previous 1 CS. Risk risk increases with the each successive cesarean. Planned delivery at tertiary care center significantly improves the maternal and neonatal outcome. Proper antenatal counseling and multidisciplinary arrangements are normal. Recommendation: encourage a safe trial for the labor after the cesarean when appropriate. Early diagnosis of placenta access syndrome through ultrasonography and early diagnosis. Blood transfusion preparedness for multiple each and every CS patient, previous CS patient. Senior operation involved in each and every case, and standing referral system for the early detection of the previous CSS. Limitation: it was a single sample study. Multiple sample size were moderate sample size was there, and no long-term maternal follow-up were there. Thank you, sir.
यार હજી વિડિયો શરૂ નતો થતા અને ઓલા દેવેન્દ્રભાઈ ફોન નતો પડતા.
I would like to see your poster, Dr. Priyam.
Yes, sir. But
You cannot share. No?
sir, but I can't share. I can share. Sir, wait a minute. Screen. I can't share my screen.
The technical team, if you have Dr. Priyam's poster, can you please display it on the screen?
Yes, sir. 1 second. This is poster. You can. It is visible.
So this is a PPT that I was asked to show. I have poster also. I have posted it also.
So you can share your screen.
Share. I can share. Wait a minute, sir.
Yeah.
Share screen option is not available. For screening, I can send for image. Wait,
try.
sir. Screen.
You can
Yes,
share
sir, I
now.
can start. So yes, sir, I can share now.
Dr. Priyam, since you have presented your scientific study as a poster,
Yes,
can
sir.
you please tell us which statistical analysis you carry out to come to a conclusion that you have just mentioned?
So what are you saying?
Did you carry out statistical analysis to come to a conclusion, or you just derived to you inferred on the basis
Sir,
of the percentage that you have seen here?
So yes, I just took the graph percentage and from the patient. Not, I don't use any statistical conclusion, but I use the percentage directly from the data that I collected.
What was the sample size of your study?
So ma'am, 100 patients were there.
For 100 patients, you could have got to use a statistical analysis.
So this is what the postgraduates need to understand, that the percentages give us a rough idea of what is happening in a given series of patients. But until we apply statistical analysis, our research is incomplete, and we cannot conclude even if the findings appear obvious. So it's a good attempt. You have a good data set, and you should proceed with statistical analysis even if you have not done it so far. And we can see
Yes, sir.
poster now. And
what are the otherwise the percentage chances of placenta preta spectrum if a patient is presenting with previous 1 CS, 2 CS, and previous 3 cesarean sections?
Statistically, I can't correlate right now, ma'am.
No. I'm asking you about the overall percentage chances if a female presents with a previous 1 CS, previous 2 cesarean sections, and previous 3. The percentage chances of PAS, placenta preta spectrum, in a patient who is presenting to you with previous 1 cesarean section, previous 2 cesarean sections, and previous 3 cesarean sections. It's not about your study, it's a generalized percentage which we know worldwide.
Ma'am, I can't correlate that. Well, I
Okay,
can't
no issues.
correct.
No issues, no issues.
Yeah, thank you, Dr. Priya. We can proceed to the next case. If Dr. Deepal has any question, madam, please go ahead.
No, sir. Thank you so much. I have no questions.
Okay,
Thank you,
let's
Dr.
go to the
Priyam,
next
and Tom.
student.
Thank you very much. Thank you very much, judges, for that nice interactive section. Before we go into the next presentation, I would like to introduce and welcome our judges for the session. I would like to welcome Dr. Ashish Shah, sir, who is the professor of Obs and Gynec Department from GMARS Medical College, Gotri, Baroda. He was the ex-dean of the GMARS Rajpipla and past president of Baroda Obs and Gynec Society. Welcome, sir, and sorry for the technical glitches, sir. I would also like to welcome Dr. Deepal
Thank
Shah,
you.
ma'am. Yes, sir. I would also like to invite Dr. Deepal Shah, ma'am, who is assistant professor at Karamsad Medical College, and she is having experience of 5 years. Welcome, ma'am.
Thank you so much, Dr. Sanford.
And I would also like to welcome Dr. Deepa Patre, ma'am, who is a professor at GMERS Gotri Medical College. Welcome, ma'am. So now I would like to welcome Dr. Himali Bin Pranami for her next for her presentation. Dr. Himali Bin, are you there?
Hello, yes.
Technical team, can you please update her poster? Dr. Himali, you can start your screen sharing also.
Yes.
Yes, we can see your poster. And judges, I am allowing her to start her presentation, right?
Yes, please go ahead.
Please,
Thank
Dr.
you.
Himali Bin, you can go ahead.
Hello.
Yes, Dr. Himali, your time has started now.
Hello everyone, I am Dr. Himali, second year OBGY resident from Santosh Medical College and Hospital, Ghaziabad, Uttar Pradesh. I am presenting a case of ectopic pregnancy and interstitial ectopic pregnancies. Ectopic pregnancy is the implantation of blastocysts at sites other than the endometrium of the uterine cavity, and interstitial ectopic pregnancy is rare and accounting for 2 to 4% of the ectopic pregnancies. The classic triad of ectopic pregnancies are abdominal pain, amenorrhea, and vaginal bleeding. Aim of this study is to discuss the presentation and management of the interstitial ectopic pregnancy. Case reports of 3 ectopic pregnancy at rare sites diagnosed and managed in our hospital within a span of 3 days in gynae department. Case 1 is a
Dr. Himali,
29-year-old.
your screen is not visible. Have you started sharing your screen?
I have already shared my screen.
Go to previous slide. It's a
Previous
end of
slide.
show.
This is the end of slideshow.
Go to the first slide.
Hello.
Yeah, you are audible. Please go ahead.
Yes, Dr. Himali, your screen is visible and you are audible. Please go ahead.
Okay. Case 1 is a 29-year-old G4P2L2A1 woman with 7 week 3 days of amenorrhea presented with vaginal spotting and lower abdominal pain with history of recent self-administered medical termination. On examination, she was tachycardic with hypogastric tenderness and induration, and UPT was positive. USG suggested a ruptured left tubal ectopic pregnancy with hemoperitoneum. Emergency exploratory laparotomy with left salpingectomy was performed, confirming a ruptured ectopic pregnancy. The first image is of this case. Case 2 is a 25-year-old G2A1 woman with 4 months of amenorrhea, presented with vaginal spotting and abdominal pain. She had a previous history of medically managed tubal ectopic pregnancy. On examination, she was tachycardiac with abdominal tenderness and UPT was positive. USG suggested a tubal ectopic pregnancy with rupture and emergency exploratory laparotomy was performed, confirming a ruptured ectopic pregnancy. And the case 3 was a 32-year-old G4P2 L2A1. Hello. G4P2 L2A1 woman presented with 8 weeks of amenorrhea and lower abdominal pain for 3 days. UPT was positive and USG revealed a left interstitial ectopic gestational sac measuring 2.4 into 2.3 centimeter. Clinical and radiological findings were consistent with left interstitial ectopic pregnancies, and the patient underwent emergency exploratory laparotomy. Are you able to see my screen?
No, Dr. Himali. Can you go to previous slide?
Sorry, ma'am. One second.
Dr. Hemali, don't worry about the technical aspect. Just conclude your presentation.
Okay, sir. The discussion of this study is the interstitial ectopic pregnancies are very rare. Only 2 to 4% of all ectopic pregnancies occur in the interstitium of the uterus. Interstitial ectopic pregnancy refers to a gestational sac implantation within the proximal intramyometrial segment of the fallopian tube. Interstitial pregnancy has a mortality rate that is 6 to 7 times higher than the other ectopic pregnancies due to its unique anatomical location, where myometrial layer of the uterus surrounding the interstitial part of the fallopian tube protects the G-sac and allow it to expand, which may delay the rupture of the sac until 7 to 16 weeks of the gestation and allow for the formation of large amount of the blood vessels. This results in catastrophic hemorrhage at the time of rupture due to rich blood supply in the area. And the conclusion of this study is we have 3 cases in 3 days in the June itself, and we managed successfully with emergency exploratory laparotomy and salpingectomy. The patients were stable and hello.
In your second case, I guess you said that the patient was managed for an ectopic pregnancy conservatively in her first ectopic pregnancy, and then she had a recurrent ectopic pregnancy which you have presented.
Yes, ma'am.
So what is the percentage chances of a recurrence of ectopic pregnancy with conservative management?
Ma'am, it's 10 to 15%.
And why does it happen?
Dr. Hemali, you have presented a cases of ectopic which are managed in a standard way and very well managed at your institution. My question is, by presenting these cases in this conference, or rather preparing the study on this topic, the first thing that you should ask to yourself is this adding to the existing knowledge that we have in field of research for this topic? So what do you think? Your 3 cases are adding any extra or additional knowledge to what is already existing in scientific domain?
No, sir, we have already managed the ruptured ectopic like this only since long times.
Yes. So for the presentation purpose, it is wonderful, but all the students should take a note that whenever we pick up any research topic, it should be either supporting the existing knowledge or more preferably adding to the existing knowledge that we have in the scientific domain for that given topic. So that would help you into publishing at a very rapid rate otherwise. So with that, I can see Dr. Akshay. Thank you so much, sir, for coming here and encouraging us and allowing us to be a part of this wonderful research conference.
Ashish, I do remember even when you were a student and I was consultant, I was learning from you.
That is never so, sir. We have
Yes, it
learned
is
so much
always. The
from
truth
you,
is
sir.
always a
And
truth. It is your kindness and you are so humble that you are not accepting it, but I am fair enough to admit the reality. And I really mean to say that I really mean to say the audience as well. Where I learned a lot when you were my student. I still remember you helped me in preparing so many lectures of mine as well. Thank you for everything. Deepaben, કેમ છો?
જેમ બસ મજામાં. Thank you, Akshay bhai.
Thank you. Please go ahead. Please go ahead.
sir,
દીપલબેન બી બેઠા છે એકદમ એક્સલન્ટ ટીચર એટ કરમસદ.
Nah, sir. Good morning, sir.
Yes, Dikra. Always happy to see you people. Please go ahead.
Thank you, sir.
It was wonderful to see the interaction between the judges and our coordinator, Dr. Akshay Sasar. And thank you very much, everyone. So I would like to go ahead again with the next presentation.
Yes,
Dr.
please.
Rajveer Barad.
Good morning, everyone. Am I audible, sir?
Yes, Dr. Rajveer. Can we have your presentation? Technical team, can you please upload Dr. Rajveer's presentation, please? Yes, we can see your presentation, Dr. Rajveer.
Yes, sir.
You can go ahead.
Good morning, everyone. Myself, Dr. Rajveer Sanjay Bharat, second year resident doctor from a Sarti Hospital, Bhavnagar. And I am presenting the case of a twin paradox, a life alongside a complete mole, guided by Dr. Rajni M. Parikh ma'am from Department of Obstetrics and Gynecology from Sarti Hospital, Bhavnagar. We present a rare case of a twin gestation comprising a complete hydatidae of a mole and a coexisting live fetus that remained undiagnosed throughout the pregnancy. In a serial antenatal ultrasonography, the pregnancy was interpreted as a singleton pregnancy with a uterine fibroid showing a cystic degeneration. The diagnosis of a complete mole with the coexisting fetus was established only after a delivery and histopathological examination. This case highlights a diagnostic challenge caused by an unusual imaging finding and the need consideration of gestational trophoblastic disease in a differential diagnosis of cystic uterine masses encountered during pregnancy. Objectives: to describe a rare case of a complete hydatidiform mole with a coexisting viable fetus and to highlight the associated diagnostic challenge and clinical implications. Case summary: a 25-year-old female G2P0L0A1 at a 40 week of gestation presented to our institute with a term pregnancy. She was a booked antenatal case at our institute and had received a regular antenatal care. She had a history of one medical termination of a pregnancy at a 6 week of a gestation, and the current pregnancy was conceived following the ovulation induction. An anomaly scan performed at a 21 week of gestation revealed a multicystic mass arising from the anterior uterine cavity, measuring approximately 11 into 9 into 5 mm, projecting into amniotic cavity. The provisional diagnosis was a degenerated fibroid. A serial antenatal follow-up showed the progressively enlarged the mass, which measured approximately 16 into 7 centimeter at a term. At a 40-week one-day pregnancy, decision was made to plan a cesarean section in view of a large anterior wall fibroid obstructing the engagement of a fetal head. The patient delivered a healthy female infant weighing a 3.3 kg. Intraoperative finding reveal a fleshy vesicular and avascular marrow prox of 15 into 17 centimeter attached to the placenta by a thin membrane, giving the appearance of a dichorionic diamniotic twin gestation with one normal fetus and abnormal gestation. The placental tissue alongside with the mass was sent for histopathological examination. And HPE reveals the placenta with no remarkable pathology and a complete hydatidiform mole. In a slide, we can see the USG picture. That is a picture from an anomaly scan showing the multiple vesicular and mass like a lesion. And in a intraoperative finding, we can see a yellowish vesicular and avascular thing that attached with a thin membrane of the placenta. That is a complete hydatidiform mole. And the incidence rate of our case is a 1 into 20,000 to 1 lakh, despite the significant maternal and fetal risk like FGR, IUFD, preterm birth, etc. Continuation of a pregnancy may result in the delivery of a healthy live infant in a selected case with a careful antenatal monitoring with a serial USG. And this patient had a normal CRP and a CBC in her antenatal period. However, a meticulous postpartum beta-HCG surveillance is a mandatory because of a risk of a trophoblastic disease. But in this case, the value of beta-HCG was not detectable after a 6-week postpartum. Conclusion, early antenatal diagnosis of a twin pregnancy with a coexisting complete mole in a normal fetus permit a intensive maternal fetal surveillance, facility timely management and a complication, inform counseling and appropriate delivery planning, thereby reducing maternal morbidity while maximizing the possibility of a successful live birth in the selected cases. Thank you, sir.
Can you show your poster, Dr. Rajveer?
Sir, I only created like this.
So poster is same as what you have presented in the slides.
Yes, sir. Yes, sir. Yes, sir.
Was this patient seen in the first trimester of pregnancy at your place?
No, ma'am. The patient is come at around 19 to 20 week, ma'am. First time patient हमारे पास 19 to 20 week पे आया था with lower abdominal pain की complaint के साथ.
Okay.
Retrospectively, do you think there is any role of MRI in such cases? What is your
Yes,
take
sir.
on that, or what have you come across in various studies?
Yes, sir. I study in one place where the MRI can be a major gold standard for diagnosis of this case.
Okay, thank you, Dr. Rajveer. Madam, Dr. Deepal, madam, would you like to ask anything?
I would like to ask Dr. Rajendra, what were the initial beta HCG level first time you did in postpartum period?
Ma'am, in a first postpartum period, when we did it after 1 week, the value was, ma'am, 109 international unit.
1 lakh.
No, no, ma'am. Only 109, ma'am. 109.
109.
Okay, ma'am.
And what is the role of methotrexate in molar pregnancy?
Ma'am, if it when we monitor a case like this, beta HCG surveillance is done. If the beta HCG value is consecutively rising in a 3 consecutive value, then we can give a methotrexate to decrease the risk of it turn into a gestational trophoblastic tumor.
Okay, thank you. That is all from my side, Ashish.
We can
Thank you,
proceed to
ma'am.
the next case, please. Thank you.
Thank you, sir. Thank you, ma'am.
Hello. Yes, we can go ahead with Dr. Amit Jivani for the next presentation, please. Dr. Amit. Dr. Amit Jivani is there.
With your kind permission, I would like to interrupt. If Dr. Amit Jivani is not available, we can go to switch over to the next speaker. and
Yeah,
we
we
will
can
try to
have.
accommodate. We will definitely try to accommodate the missed out before the entire session is completed. So take the
Okay,
next, doctor, please.
So I would like to have Dr. Salki Chauhan, please.
Next one.
Dr. Salki.
So they were not joined, I think. We can move to next one.
Is Dr. Khushbu or Dr. Nishi available? Sir, the screen is showing that Khushbu and Dr. Nishi both are available. Kindly ask Dr. Khushbu to take over. Shantwan?
Santosh bhai, can you make Khushbu and Nishi co-host?
Hello, sir. Am
Are
I
you Dr.
visible?
Khushbu?
Yes, sir. I'm Dr. Khushbu Patel.
Okay, over to the judges.
Can I start sharing my
Yes,
screen?
please. Yes, go ahead, Dr. Khushbu, with your presentation.
Hello, I am Dr. Khushbu Patel. I'm from LG Hospital, Ahmedabad. I'm presenting a case of bilateral tubal ectopic pregnancy. The blastocyst normally implants in the endometrium lining of the uterine cavity. Implantation anywhere else is called ectopic pregnancy. In tubal ectopic pregnancy, implantation happens within the fallopian tube. The fallopian tube is not designed to support a growing pregnancy. So this condition can lead to rupture. Hello? Am I audible, sir?
Yes, Dr. Khushbu, continue.
Okay. So this condition can lead to rupture and internal bleeding, making it a medical emergency. A 32-year-old second gravida, previous cesarean section female presented with a complaint of abdominal pain and spotting per vagina for 4 to 5 days at the 6th week of gestation. She had previously lower segment cesarean section for triplets 8 years ago. Patient had taken the treatment of infertility, intrauterine insemination for this pregnancy. And patient is known case of hypothyroidism for 8 years and taking tablet Thyrox 25 microgram. Patient general condition was stable. On examination, urine pregnancy test was positive. Mild pallor was present. On per abdominal examination, it was soft and no tenderness was found. Per vaginal examination, cervical motion tenderness was present and right side fornacial fullness was present. Her hemoglobin was 7.4 gram per deciliter. On transvaginal sonography, a right adnexal ectopic pregnancy of 10 size around 4 weeks was found, and 11 into 8 corpus luteal cyst in left ovary and also 13 into 10 simple cyst in left ovary. So after that, we first started the medical management. We given 1 pint blood transfusion for low HB, then injection methotrexate given on day 1, 3, 5, 7 after beta HCG value. On day 1, beta HCG value were 5,447. On alternate day, folinic acid was given. On day 4, her beta HCG level was 5,172, and on day 7, her beta HCG level was 4,258. Patient was after that, patient was constantly complaining of abdominal pain. So we then opted for surgical management. After proper counseling and obtaining informed consent, the patient was opted for laparotomy. The procedure performed under general anesthesia, and 3 by 2 centimeter mass was found on the ampullary region of left fallopian tube. Ovaries and fallopian ovaries of bilateral size was found to be normal, 2 by 2 centimeter mass over isthmus area of the right fallopian tube. On left side, salpingectomy was done, and on right side, a small incision kept over antimesenteric border of a mass, and the mass recovered. Fallopian tube closed with multiple intermittent stitches with Vicryl 30. So on right side, salpingotomy was done, and abdominal drainage was kept on the left side in pouch of Douglas. Uh, uh, 1 pint blood transfusion given post-operatively. On third day, abdominal drain was removed. Patient recovered uneventfully and was discharged on post-operative day 4. On discharge, patient was vitally stable, and we also sent the section for histopathological examination. On right side, the section reveals occasional viable chorionic villi. So it was conclusion of the pregnancy, and on left side section also reveal the occasional chorionic villi and trophoblastic cell. So finding was consistent with the clinical diagnosis of the tubal ectopic pregnancy on both of the side. Bilateral ectopic pregnancy is a rare but potentially life-threatening condition. Early diagnosis and prompt intervention and meticulous intraoperative examination of both tubes are crucial for reducing maternal morbidity while preserving reproductive potential whenever possible. Ectopic pregnancy account for 2% of the all pregnancy. It represents major health risk of the woman of childbearing capacity, which may lead to life-threatening complications if not treated properly. The incidence of ectopic pregnancy has been increasingly diagnosed due to early diagnostic measures like serum beta-HCG level and high resolution of ultrasound technique. Classic triad of ectopic pregnancy include abdominal pain, amenorrhea, and vaginal bleeding. Risk factor include pelvic inflammatory disease, previous ectopic pregnancy, history of tubal surgery, conception after tubal ligation, use of fertility drugs and assisted reproductive technique. And early diagnosis and management of the rupture ectopic can reduce morbidity and mortality. Thank you.
Dr. Khushbu,
Yes,
I
ma'am.
have one question for you. Initially, the WBC were 81,000.
Sorry, sir. Sorry, ma'am. 8,000. It was some printing. Sorry.
Okay. No
Yes,
problem, no problem.
yes, ma'am.
So it was 8,000. So my question to you is, when you are giving methotrexate, how will you like to monitor?
Ma'am, methotrexate can lead to methotrexate have some toxicity like photosensitivity, and it can alter the liver. मतलब liver पर effect થઈ શકે. So serial monitoring of liver function test, and we strictly prohibit patient to go outside in sunlight, and regular follow-up, and also if patient complain of more abdominal pain, or then we opted for surgical management if patient condition was worsen.
Okay. Over to you, sir, if you have any questions.
So, Dr. Khushbu, considering the rarity of the case, when you were preparing this case, how many cases have you come across reported in the literature about the bilateral tubulectopic?
Sir, I found like 3 to 4 cases, uh, uh, and I studied the 3 to 4 cases, and after that I made the presentation.
So, did you go into depth of those cases and how were they managed? Are you aware of the management in those cases that you have come across?
Yes, sir. Um, in one of the cases, it was medically managed with methotrexate and serial um, beta-HCG level monitoring was done. And in one of the cases, it was surgical management. The one side salpingostomy, a salpingectomy was done, and one side, this case, and one side salpingotomy was done.
Yes, Khushbu, is salpingotomy a standard surgical procedure which we usually follow for an ectopic pregnancy management, surgical management? What are the future outcomes of this procedure?
It will depend on the if patient's condition. Like if patient is a family completed, then we can go for salpingectomy. And if patient's family is not completed, then we can like this kid, if it is a bilateral pregnancy, we can save one of the tube.
Okay. Yeah, thank you, Dr. Khushbu. We can proceed to the next presenter.
Thank you, sir.
Yes, the next presenter would be Dr. Silky. Dr. Silky, are you there? Dr. Silky? Hello?
Hello.
If Dr. Silky is not there, we can go ahead with Dr.
Hello?
Nishi, please.
Hello.
Dr. Silky, are you there?
या सर आपको मेरी आवाज आ रही है सर क्लियरली?
Yes, yes, we can hear you, and you can show your screen also.
One second. प्लीज मेरा प्रेजेंटेशन पोस्टर स्क्रीन पर शो हो सकता है क्योंकि मेरे साइड
Just a
से
minute.
हाँ
Just a minute. Dr. Silky, can you can share your screen and it would be there.
सर नहीं हो रहा है आई विल ट्राई सो मेनी टाइम बट नॉट शेयरिंग फ्रॉम माय साइड
We have given you the permission. You can just check it again. Okay, so it is there. You can see that now.
थैंक यू सर गुड मॉर्निंग ऑल ऑफ यू सर एंड मैम I am Dr. Salki Chauhan from GRMC Medical College, Junagadh, Gujarat. My topic is Pandora of abnormal uterine bleeding. I am showing this my slide first page. The preventable risk and early intervention and quality of life outcome in abnormal uterine bleeding. Now the introduction is abnormal uterine bleeding affected 10 to 30% of the women reproductive age worldwide, and remaining one of the commonest reason for a gynecology OPD visit. Apply the Figo Pomcoin system. This prospective cohort study evaluate modifiable risk factor, obesity, polycystic ovarian syndrome, thyroid of dysfunction, anemia, and sanitary lifestyle. हेलो मेरी आवाज आ रही है ना? हेलो हेलो
Yes, Dr. Silky, we can hear you. You can continue.
Thank you. And sanitary lifestyle and track where their control alongside early medical or surgical intervention reduce bleeding severity and improve quality of life among women affected. GRMC Medical College and Hospital, Junagadh. A single cohort followed longitudinally through baseline risk factor, exposure, intervention, and outcome using one pre-specified cure definition across and remain comparatively under described in the literature. And this study was designed to close that local gaps. Now the aims and objective to identify preventable risk factor for abnormal uterine bleeding and evaluate the impact of early interventions on cure rate and quality of life. Uh, Determine complete cure rate with early medical or surgical intervention. Identify prevalence of a preventable risk factor among women with AUB. Classify all women per the FIGO POM coin system. Compare pectoral bleeding assessment chart severity risk factor control versus at rest. Measure quality of life change across preventive medical or surgical arm and determine 6-month reoccurrence and its link to adherence. The sample size is 150 women. Then mean age is 32.4 to plus minus 6.8 years. And cure in medical arm, management is 31.4%, and cure for the surgical arm 63.2%. And the mean quality of life gain is 34.9 patients. And the reoccurrence chances in the after 6 month follow-up is 9%. Study design and the setting. The design is hospital-based prospective observational cohort study is 12 month with a structural 6 month follow-up. The setting is the Department of Obstetrics and Gynecological (OPD) and IPD GRE. GMERS Medical College and Hospital, Junagadh, Gujarat. And study population is women 18 to 45 years with clinical diagnosed abnormal uterine bleeding according to POM coin classification, more than 3 month duration and consecutive sampling. Sample size is 150 that calculate by a P and D and 95%. There's approximately 50% loss of follow-up. In this all study, during in this study, a tool and statistical analysis showed tool structural case record form and pictorial blood loss assessment chart, menorrhagia, multiple attributed quality of life scale, and allocation are preventive only medical or surgical or preclinical severity. POM coin is a category and patient preference are non-randomized. Follow up. PBSC and hemoglobin symptom status and adherence records at 1, 3, and 6 months. Quality of life reassess at final visit. Analysis by a paid system PSS V26 with the chi square Fisher extract pair test Wilson multivariable logistic reasons and p values. Study work follow is enrollment and baseline risk factor assessment, then preventive only medical surgical allocation and structure follow up at 1, 3, and 6 months duration. Cure, quality of life, and reoccurrence outcome. Now this pie chart is show the POM coin classification system. There's ovulation, neomyoma, the structural and non-structural causes, and then structure and causes and non-structural. The structural is ovulation disorders, leiomyoma, adenomyosis, and polyp, and non-structural is endometrial hyperplasia, and non yet classified, and coagulopathies. Preventable risk factors are prevalence are more is obesity. If BMI more than 125 is account for 58%, and sanitary lifestyle is 51%. Anemia if HB is less than hemoglobin is less than 11 is 46%, and poor dietary pattern is 39%. Polycystic ovarian syndrome 34%, and thyroid dysfunction is 22%. Now the complete cure rate by treatment arm is showing that the preventive only 12%, medical management show that is medical management से patient 31.4% cure हुए हैं और surgical management से 63.2% in study. And the last line chart show the pictorial blood assessment score trend, this medical and the medical versus surgically. So surgical arm is more more good than the medical arm, because surgically we
You have overshooted your time. Can you please conclude in 1 or 2 sentences?
Conclusion is preventable metabolic and endocrine risk factor, obesity and sedentary lifestyle, anemia and PCOS, thyroid dysfunctions were highly preventable among women presenting with AUB, and active control of this risk factor correlate with reduce PBSC severity and early intervention and achieve meaningful complete cure rate with a substantial quality of life gain in both medical and surgical arm, and supporting structure risk factor counseling along standard gynecological care. Impact are clinically support structure risk factor counseling along conventional AUB management at a GMERS Junagadh, and public health is provide baseline evidence to prioritize weight management and endocrine referral pathway. The district wide academic is contributed a rare Indian cohort data directly compared medical or surgical cure rate with the one population, and limitation are either no randomized allocation or medical or surgical comparison may be confounded by baseline severity. 6 months follow up may under capture late reoccurrence, and particularly in the medical arm, and single institutional design by limit generalizability beyond Junagadh district.
So the first thing, Dr. Salke, is you have taken all patients of abnormal uterine bleeding and you have evaluated their outcome in terms of medical and surgical management.
Yeah.
Now it's a very diverse group when you talk of AUB in general. You have shown in your pie chart the groups, the etiologies which are there. So the major concern with your study is it's a study where non-comparables are compared. So you cannot generalize the outcome in terms of medical and surgical management across the etiologies. What you should have done is, for a given etiology, how many are treated medically or surgically, not overall for all AUBs. So how do you justify that? Why did you do that? And why did you not do the individual analysis for individual etiology?
Because ये जो टॉपिक है वही बहुत वास्ट है, और इसमें मेडिकल और सर्जिकल थिंग्स को रिलेटेड है. हम कभी भी सर्जरी पर नहीं जाते, इसीलिए हमने फॉलोअप रखा है 1, 3 और 6 महीने का, क्योंकि पहले हम लोग मेडिकली ट्रीट करने की कोशिश करते हैं. अगर पेशेंट मेडिकली ट्रीट नहीं होता है तो हम सर्जिकल पर जाते हैं, जिसमें इंक्लूजन एंड एक्सक्लूजन.
I would like to interrupt. For all causes irrespective of the etiology, do you treat AUB medically?
No, etiology will be shown all points for like thyroid dysfunctions, obesity, anemia, sedentary lifestyle, estrogen increasing, all our things are estrogen increasing things, sir.
You have shown palm coin categories. So for all palm coin categories, would you like to provide medical management first and then only proceed to surgical management?
Depend on severity of the disease. If a patient
so does it not depend on etiology of the disease?
Yeah, अगर हम लियोमाइमा लाइक फाइब्रोइड का साइज देखेंगे तो हम उससे भी कोरिलेट कर सकते हैं. अगर साइज लार्जर साइज एंड स्मॉलर साइज विथ माइल्ड काइंड ऑफ सिम्टम्स पेशेंट अगर आता है लेकर, तो हम उसको मेडिकली पहले ट्रीट करने की कोशिश करते हैं. अगर लार्ज साइज है, अगर फाइब्रोइड का जो कि और भी सिस्टम को इन्वॉल्व कर रहा है, या पेशेंट को बहुत ज्यादा एनीमिक बना रहा है हेवी मेंस्ट्रुअल ब्लीडिंग की वजह से, तो हम लोग उसको सर्जिकली ट्रीट करने की कोशिश करते हैं.
Okay, Dr. Salki, but I sincerely would like to give my feedback that this is a faulty design of the study statistically. So you need to correct the design if you want to do anything in future for the follow-up of this study. You need to correct the design of the study. I'm not saying that it's a wrong study, but the design needs to be corrected so as to justify or compare same etiologies with the outcome rather than different etiologies with the outcome.
Okay.
Thank you. We can proceed to the next presenter, please.
Okay, thank you, ma'am.
Thank you very much, sir, for your inputs. Now we are ready with the next presenter, that is Dr. Nishi. Dr. Nishi?
Can I share my screen, sir?
Yes, you are co-host, so you can go ahead.
Is my screen visible?
Yes.
Yes, sir. Good morning, everyone. I'm Dr. Nishi Shah. I'm a resident from Sola Gemus College. My topic is reducing intraoperative lower segment blood loss in placenta previa with Ashokanan stage. Introduction. Obstetric hemorrhage still remains a leading cause of direct maternal morbidity and mortality. Obstetrics is a bloody business in central placenta previa, and more so of the placenta is morbidly adherent is a nightmare for an obstetrician and can be life-threatening. One of the effective and time-tested method of controlling severe pelvic hemorrhage is ligation of both internal iliac arteries, ligation, as this is a major source of blood supply to the pelvic viscera. But it requires expertise and experience. Bleeding from the placental bed in case of placenta previa is commonly faced, which is less discussed issue till date. The highly vascular and friable lower segment, which forms the placental bed, is slow to retract, and the greater the time it takes, more severe is the blood loss. Devascularization of the lower segment by bilateral uterine antiligation is helpful, but it is only to some extent. Ashokanan stitch is a simple, less invasive, cost-effective, time-saving, and rapidly effective method to control lower uterine segment blood loss in such cases. Clinical description: a 41-year-old female G3P2L2A0 with one full-term normal delivery and one cesarean section with 37 weeks of gestation with USG findings of central placenta previa, grade 2, with informed and written consent, elective cesarean section planned due to the high risk of antepartum hemorrhage. Intraoperatively, Ashokanan hemostatic uterine sutures were placed to minimize bleeding from the placental bed, which resulted into significant reduction of blood loss. Uterine closure done by bringing edges close together with absorbable suture polygalactic one in continuous locking manner. This is a schematic diagram of how the suture is taken. The entry point is A, point of insertion of the needle from anterior to posterior, which is 1 centimeter above the level of lateral fornix and 0.5 centimeter medially to the lateral border of cervix. Point B, point of reinsertion of the needle, which is from the posterior to anterior, 0.5 centimeter below the lower margin of the uterine incision, 2 centimeter medial to the lateral uterine margin, and the C point is between the both where the knot is tied. Benefits: control bleeding effectively, preserve uterus and fertility, quick and easy to perform, and it reduces need for hysterectomy and blood transfusion. Management: once the abdomen was opened, the bladder is pushed down well below the cervix, and then the uterine incision was taken in lower uterine segment as far as possible, avoiding the placenta. After delivery of the baby, the umbilical cord was clamped, applying pressure on it with sterile gauze. Bilateral uterine arteries descending cervical branch was ligated with braided coated polygalactin 910 number 1 on round body needle. Assistant holded the uterus in central upright position. A spade or any retractor was used to guard the intestines behind the uterus to avoid any injury. The Ashokanan stitch, polygalactin 910 number 1 suture material was mounted on straight needle. The mountain needle was inserted in the cervical musculature from anterior to posterior, 0.5 centimeter above and 0.5 centimeter medial to the lateral. Next, the same needle with suture material was reinserted from the posterior to anterior about 0.5 centimeter below the lower edge of the uterine incision on the same side. The knot is tied and secured midway between the 2 points. Similar steps were repeated in the other side. Once the sutures were taken, the lower uterine segment was devascularized, after which the placenta was removed. The uterine incision was then closed after confirming hemostasis from the placental bed. Conclusion: Ashokanan stitch is very effective as it devascularizes the lower segment even before the placental sinuses are open. This approach helps to conserve the uterus and preserve the fertility. It can be helpful where less staff and less facilities are there. If this suture is placed, we can save the mother from the PPH, which is leading cause of maternal mortality. Thank you, sir.
Dr. Nishi, can you elaborate on the technical difficulties that one would face while taking the stitch?
Technical difficulties, if we put the incision more on the lower side, the placenta may bleed. So we should firstly put the incision little above. Other, I don't think I know about that difficulties, sir.
Okay, and approximately how many cases of this stitch you have observed or assisted or performed?
Only, sir, one in the recent times.
Okay.
Are you keeping the cervical canal open like the internal os when you're taking this stitch? Are you putting something from a dilator, maybe from below, or how do you take care that you're not occluding the os? Because I didn't understand the entire procedure. Can you just elaborate on the procedure? You said it's done on both the sides. Could not understand.
Yes. Yes, the collaterals are also devascularized after doing this stage. So the both bilateral side we have to occlude them.
So it's not encircling the lower uterine, lower.
No. It's just blocking the collaterals. And it is a prophylactic stitch, so it is taken before placenta is out.
Okay. How much approximate blood loss could you decrease by taking this stitch?
Approximately 500 ml.
Okay.
How is it better than the normal uterine ligation, Dr. Nishi?
In normal uterine ligation, the lower segment of uterus, all the collaterals are not occluded, so it will still bleed.
So is it at the lower level than the normal uterine artery ligation?
Yes, it is lower.
Now, how will you prevent injury to bladder and ureter?
The bladder is pushed down well below the cervix from starting.
Okay. Okay, sir. If there are no more questions, we can move forward to the next student.
Okay, so I think we can conclude the session. And I would really like to, on behalf of Sogor, I would like to thank all our judges, Dr. Ashish Shah sir, Dr. Deepak Shah ma'am, and Dr. Deepa Patre ma'am, for their valuable time and inputs. I'm sure your comments would have helped the postgraduate students. And I would like to congratulate all the postgraduate students also to make an effort and prepare the presentation and come to this wonderful conference. I would like all of us to start their video if it is possible. I'm sorry that we had a technical glitch. We can just take one screenshot of all of us.
I would just like to say thank you, Sogok, for such a wonderful initiative. And all the students needs congratulatory notes as they have put in their efforts. And this is the beginning, and I'm sure in coming years, students would do better research for us to publish wonderful papers in future. Thank you.
I would like to thank the organizing team for the opportunity and the wonderful arrangements. Thank you. And I would like to congratulate all the students as well.
Deepa ma'am, would you like to say something?
Yeah, thank you, Sobok, for giving this wonderful opportunity for us to be a part of the judging CRIO. And secondly, all the students have given in a lot of efforts. But as Dr. Ashish sir rightly said, we would like to have more clarity on the research work which is presented, so that we could have some good papers coming on from the medical colleges.
Okay, so
Can
can
we
we all
leave
have
the
your
meeting?
video on? So we can take
No.
a all બધા.
Wait a minute. We have a electricity breakdown here.
I can see Dr. Ashwin sir has joined. Welcome, sir. Yes, I request all other students also to start their video so we can just take one screenshot and we can conclude the link for this session. एक मेजर स्क्रीन करना को ना પછી એક સ્ક્રીનશોટ.
Dr. Kamal Goswami is also there. Dr. Kamal, it would be great if you can start your video as well.
Hello, good morning, all of you.
Good morning. Great to see you, sir.
Yes, Ashish, nice sessions conducted by you people. Hello, Saswat.
Hello, good morning.
Good morning.
Kamal bhai, good morning.
Good morning. I myself and Dr. Preeti Bajaj joined from the PDU Medical College, Rajkot.
Good morning, Kamal bhai.
Good morning.
So, Dr. Santwan, are we clicking a photograph now?
Okay, so I've got the photo now, and we are concluding this session. Thank you very much, judges.
Thank you, Dr. Santwan.
Thank you very much.
So I would like to invite Dr. Kamal sir, Dr. Ashwin sir, and Dr. Preeti Bajaj ma'am for judging the next session.
Yeah.
If Dr. Shivangi Malhotra is there in the group. Dr. Shivangi Malhotra, we are making you the co-host. You can share your session, share your screen, and we can go ahead with the presentation. Judges, we are just going to have one presentation for this now. Then we are going to have the official inauguration of the session, and then we can continue with the session after the inauguration.
Okay.
I'm waiting for Dr. Shashwat sir also. Dr. Shivangi, are you there? You have been made the co-host of the session. Mayal Raucha. I think there is some problem with Dr. Shivangi Malhotra. So I
Shivangi
can
is
see
not
Dr.
unmuted. She has to unmute. Probably from the central host has make her unmute.
We have made her the co-host, sir.
Co-host.
For the interest of the time, I am asking another person who Dr. Shalini Nigam. Dr. Shalini, can you hear us?
Hello, Saswat.
Yes, sir. I'm trying to join with the next
Even
in line.
Dr. Dharani and Dr. Drashti is there on the
Yes,
board.
yes. I'm
So
just
can we start?
yes. Dr. Drashti,
Unmute. First
Dr. Drashti,
unmute.
the co-host. Dr. Drashti, we have made you the co-host. You can unmute and share your screen. Your video is on, Dr. Drashti. We can see you.
Dr. Drashti first mute. Yes. Now you unmute.
Dr. Drashti, you can share your screen.
Okay.
Yes. Now we can listen
Yes.
you.
Okay.
Judges, just to brought to your notice, the timers will be there. 6-minute timer is there, and it will be shown in the right corner. Dr. Drashti, can you share your screen?
Yes, sir.
I think our topic is cesarean scar ectopic pregnancy. Number 6.
Yes.
Drashti
Yes,
Thakur. Okay. Okay.
Yes, Dr. Drashti, we can see your screen.
Yes, I am sharing.
Yes.
Now-
Fine. Go.
Yes, go ahead.
Okay. Good morning, everyone. My case is a case of cesarean scar ectopic pregnancy. Underguide myself, Dr. Drashti Thakrar, second year resident at GMERS Medical College and Hospital, Gandhinagar, and I am doing this case under guidance of Dr. Nikhil Anand, Professor and HOD, Dr. Vijay Kansara, Associate Professor, and Dr. Chirag Bankar, Associate Professor. Now, introduction. Caesarean scar ectopic pregnancy is implantation of gestation in the myometrium of a
prior CS scar. Incidence is 1:1,800 pregnancies and rising. It risks scar rupture and massive hemorrhage per vaginum. Diagnosis uses TVS and YL criteria. Management includes medical management like methotrexate or surgical via DNA, laparoscopy, laparotomy, scar excision with uterine repair and uterine artery ligation. My case details are a 32-year-old third gravida with previous 1 CS and 1 abortion with 2 months and 7 days of amenorrhea came to ANC OPD to show her outside ultrasonography reports suggestive of cesarean scar ectopic pregnancy. Her past history was previous 1 LSCS and no any other significant past medical or surgical history. On examination, general examination, temperature normal by palpatory method, pulse is 96 per minute, blood pressure is 110 by 80 mmHg. No pallor, edema or icterus. Local examination, per abdominal, soft, non-tender, transverse scar of previous LSCS present. Per vaginal examination, uterus was bulky, retroverted and bilateral fornicis clear. Patient admitted in gynec ward for workup and management of scar ectopic pregnancy. Her investigations, all routine investigations were normal. Beta HCG was 1,48,568 international unit per ml. On USG, a retroverted uterus showing 40 into 20 mm G-sec present near lower anterior uterine wall, partially in cavity and rest parting its way towards scar. Thin myometrium of around 3 mm thickness around G-sec. Cardiac activity absent. Bilateral adnexa normal. No free fluid in pouch of Douglas. Suggestive of type 2B cesarean scar ectopic pregnancy. Management. After pre-anesthetic checkup, physician fitness and written informed consent, patient was posted for ultrasound guided dilatation and evacuation with exploratory laparotomy if needed. Under USG guidance, dilatation and evacuation done, products removed, active bleeding present. Cervical catheter was done for balloon tamponade effect but failed and active bleeding continues, so decision for exploratory laparotomy taken. Intraoperative laparotomy finding. Placental tissue was adherent to scar site. Seam removed and sent for histopathology. Uterus closed, bilateral uterine artery ligation done, drain kept, and 1 PCV given intraoperatively and 1 PCV in postoperative period. Histopathology report awaited. Postoperative course. Uneventful recovery. Dressing was healthy and patient was discharged on post-op day 8 in stable condition. My conclusion from these cases, high index of suspicion in any pregnant patient with previous CS. Early transvaginal sonography aids in early diagnosis. Multidisciplinary approach and readiness for surgery is life-saving. Uterus preservation is possible with timely uterine artery ligation. Thank you.
Okay, what is the course of the disease if we don't diagnose the scar ectopic pregnancy in first trimester, and if the pregnancy continues, then what happens?
If we don't diagnose, then there can be myometrium thinning and it can lead to uterus rupture, or in later pregnancy it can convert into placenta accreta spectrum or adherent placenta to uterus.
Okay, how will you select the patients for the suction evacuation? One treatment mode is suction evacuation you have mentioned. So what are the patients that can be taken for the suction evacuation?
As here patient's beta HCG was higher, that was 1,48,000, and for that we have selected her for surgical, that is a suction and evacuation, rather than medical management by methotrexate.
Something else. Rather than beta HCG is something more important thing before taking the patient for suction evacuation. Any ultrasonographic criteria?
Yes, as also she is in the type 2B scar ectopic pregnancy. Her myometrium was also thin, 3 mm myometrium, around 3 mm thickness of myometrium around the G-sec was present, and so we decided for a surgical management via suction and evacuation.
Okay. Kamal bhai?
Yes, I have one question is why there is a rising trend of scar ectopic pregnancy?
Because of the increasing number of the cesareans, increasing number of IVF, leading to more number of the CS, and thereby increasing chances of increasing scar ectopic, cesarean scar.
How will you differentiate the cervical pregnancy with the scar ectopic?
In cervical pregnancy, their GSEC is present near the cervical canal, and in scar ectopic pregnancy, GSEC is not seen in cervical canal or uterus. It is towards the anterior side, that is near the scar, leading to more diagnosis towards cesarean scar ectopic pregnancy.
Do you think that the missed abortion, no FCP was there, in which the better management was medical instead of suction and evacuation?
Sir, as here her beta HCG level was more and her myometrium was slightly thin, that is her thickness was around 3 mm. So we decided for a surgical management rather than medical management.
What is the ultrasonographic criteria for diagnosis of scar ectopic?
Absent of the GSEC in cervical canal, absent of GSEC in uterus, presence of GSEC near the cesarean section scar towards the anterior myometrium, presence of thinning of myometrium, and presence of GSEC more likely towards the bladder. Distance between bladder and GSEC is reduced because of myometrial thinning.
Okay.
Okay.
Okay, so thank you very much, judges and Dr. Thank you very much, Dr. Drashti. So we are holding this session for 15 minutes for the official inauguration. I would like to invite all the judges and the participants to join via whole A link for the official inauguration of this conference. We'll resume this session after 15 minutes.
Okay. Okay.
Thank you, sir. Dr. Preeti Bajaj ma'am and Dr. Kamal sir, are you there? And I think Dr. Chandna is also there, our next presenter.
Good afternoon, sir.
Yes, we have made you the co-host. You can share your screen.
Yes.
Dr. Chandna. Welcome, Dr. Ashwin sir, Dr. Preeti ma'am, and Dr. Kamal sir. Shall we start the proceeding? Just unmute yourself. हाँ, ये पूछिए। Dr. Ashwin sir, can you hear me? Yes, Dr. Preeti ma'am, we can hear you. Dr. Ashwin sir and Dr. Kamal sir, please unmute yourself, then we can go ahead with the next session. Yes, sir.
Okay, now, initially we are trying for unmute, but not allowed. Now it's done.
We are just waiting for Dr. Kamal sir to unmute himself.
Yes, sir, we are here.
Yes.
Yes, sir, we are here.
Okay, next presenter.
Sir, she's Dr. Darshana. Sorry, she's Dr. Chandana. Dr. Chandana, please introduce yourself.
A very good afternoon, respected judges. This is Dr. Chandana, a first year PG student from GMERS Medical College, Sola, Ahmedabad. Today, I am presenting a poster on ovarian torsion of a benign serous cyst adenoma under the guidance of Dr. Pallavi ma'am, our professor and head of unit. May I start my poster presentation?
Yes, you can start your presentation. Judges, the timer will be there on the right hand corner. And Dr. Chandana, your time starts now.
Okay. Ovarian torsion is a time ischemia, hemorrhagic infarction, and possible necrosis in left if left untreated. It accounts for approximately 2 to 3% of all gynecological emergencies and is most commonly associated with benign ovarian masses larger than 5 centimeters. Serous cyst adenoma is one of the most common benign epithelial ovarian tumor and predisposes the ovary to torsion because of its size and mobility. The non-specific clinical presentation often delays diagnosis. Therefore, a high index of suspicion and prompt surgical intervention are essential to preserve ovarian function and future fertility, particularly in adolescents. Today, my case is about a 17-year-old unmarried female presented to the emergency department with acute onset left lower abdominal pain for 2 days. The pain was sudden in onset, severe and non-radiating, and progressively increased in intensity. There was no history of fever, vomiting, urinary or bowel complaints, trauma, or previous similar episodes. UPT was negative to rule out any ectopic. The lab investigations, the routine lab investigations turned out to be normal with a raised LDH, and we have sent tumor markers which were also within the normal limits. The radiological findings, pelvic USG revealed an enlarged left ovary containing an 8 into 7 centimeter hemorrhagic cyst. Color Doppler demonstrated markedly reduced to absent vascular flow in left ovary, highly suggestive of ovarian torsion. Mild free fluid was present in the pelvis. Operative findings. Emergency laparotomy was performed. Intra-op findings were an 8 into 7 centimeter, the same findings as the USG. Hemorrhagic left ovarian cyst with the ovary twisted at its vascular pedicle and mild hemoperitoneum. Detorsion was performed, followed by left partial salpingo-oophorectomy. And the right ovary was also examined, which showed multiple simple cysts, and multiple punctures were made for preservation of the ovarian tissue. Histopathological findings revealed cyst walls lined by a single layer of latent to low cuboidal epithelium resting on a fibrous stroma. Extensive areas of hemorrhage, edema, and congestion within the cyst wall and contents were consistent with torsion. No evidence of malignancy was identified, confirming benign serous cystadenoma. Post-op outcome was uneventful and the patient was discharged in a stable condition. Regular follow-up was advised. The surgical summary was emergency laparotomy plus detorsion along with a left partial salpingectomy. Salpingo-oophorectomy, sorry. Ovarian torsion is uncommon but potentially fertility threatening, especially in adolescents. The non-specific presentation, acute abdominal pain, leukocytosis, and absence of pathognomic signs make diagnosis challenging. DDs include appendicitis, ruptured ovarian cyst, ectopic pregnancy, and PID. USG with color Doppler remains the imaging modality of choice, demonstrating reduced or absent ovarian blood flow. In this case, the 17-year-old presented with acute pain and Doppler findings confirming torsion. Ovarian torsion is secondary to benign serous cystadenoma, is uncommon but can threaten fertility, especially in adolescents. Diagnosis is thus challenging as symptoms and lab findings are non-specific and may mimic other causes of acute abdominal pain. The key clinical takeaways from this is that ovarian torsion accounts for 2 to 3% of gynecological emergencies, and fertility sparing surgery should be attempted in young patients. Histopathology confirms diagnosis and rules out malignancy. Thank you, sir.
Okay, why you did the partial salpingo-oophorectomy, and why not preserve the tubes and ovary in this young patient?
Sir, because the torsion happened at the tubo-ovarian ligament. Sorry. So that part of the tube was also included in the torsion. So in order to prevent a recurrence of the torsion.
Actually, recent concept is for the conservation of the tube and ovarian. Most of the time when ovarian torsion occurs, tubal torsion is always there. But
Yes.
if you do untwisting, then most of the time reperfusion is started.
Yes, sir.
Okay. Okay. Now, what are the radiological diagnostic signs for torsions? What is Whirlpool sign?
Sir, Whirlpool sign is the color Doppler finding which is seen on USG.
And which is the most common finding, consistent most common finding in ultrasonography suggestive of torsion? Not the Whirlpool sign.
Sir, Doppler findings is the most consistent finding.
Without Doppler also, there are one consistent findings which usually there in most of the cases.
Sorry, sir, I'm unaware of that.
Okay. Now, what could be done for the prevention of recurrence in such patient? Suppose you have done the detorsion and saved the ovary and tube, but this lax ligament made it to the further torsion. Can we prevent the further torsion in future retorsion? What could be done?
Sir, oophoropexy, oophoropexy, I was reading about it, but I haven't completely read about.
What is the technical aspect of it? Kone jode joint kariye. Which suture material is ideally should be used in ovariopexy rather than ovariopexy?
Sorry, sir, I am not.
Okay. Okay. Dr. Kamal, sir.
Yes, Dr. Ashwin, you have asked almost everything regarding the ovarian torsion. No question.
Okay.
And second thing is probably this presentation was not in the original list.
Yes, list ma nathi. Saswat. Hello, Dr. Saswat.
Yes, sir. Yes, sir.
This is not in our
Yes,
list.
sir.
Yes.
Sir, actually,
Sir, I was busy in emergency duty. That's why I had to add it in last moment.
Okay, so we have to include in our sessions only.
So we are also
yes, sir. Yes, sir.
Okay. Tell the technical team to add in the Google Sheet. Google Sheet ma bhi
Yes,
nahi hoi
sir.
pachi.
Yes, sir. Yes, sir. I'll ask them to add.
અમે પેપર પર તો નોટ કરી દીધું પણ ગૂગલ શીટ માં એન્ટર કરાવજો તો જ અમારા માર્ક્સ અપલોડ થશે ને.
Yes, yes, yes,
Yes, sir.
Right.
Yes,
Okay,
sir.
thank
Yes,
you.
sir.
Thank you, doctor. Thank you.
Thank you so
What's
much.
your name? Please name.
Chandana. Dr.
Chandana,
Chandana.
because we have to write Chandana. And from which medical college?
GMS Medical College, Sola. Sola,
Sola.
Ahmedabad.
GMR Sola. Okay, no problem. Thank you.
Thank you, sir.
Thank you, Dr. Chandna. Thank you, Dr. Ashwin sir, Kamal sir, and Preeti ma'am for your wonderful insights. Now we move ahead with this next presenter. She is Dr. Shivangi Malhotra. Dr. Shivangi, we have made you the co-host. Please share your screen.
Hello.
Yes, we can see you now. Please share your screen now.
So just a second, I'm trying to
Yes, please. Dr. Mildow, you will be the next presenter, so be ready with your presentation.
but I'm unable to add my
Share
Is there
the
the icon for share the slide?
uh,
just look at the below tab line.
Start the sharing. There is a one arrow is there. Start the sharing. Yes, something is done.
We are trying to upload her poster from here.
Yes, that can be done. Yes, uploaded.
okay.
That is your poster, Dr. Shivangi?
Yes. Yes,
Yes,
it's
you
my
can
poster.
Your time start now.
Okay.
go ahead.
Good morning, esteemed faculty and my colleagues. I'm here to present a poster on a long journey through endometriosis. My topic was Pandora of AUB. My topic illustrates a patient who had a 17-year-long clinical journey, which ultimately culminated in a definitive surgery of hysterectomy. So the patient presented at 22-year-old seeking treatment for infertility. Uh, she went through multiple channels. She went through multiple diagnostic modalities, but unfortunately, because the conclusive diagnosis was not made, the disease progressed and reached to class 4. And she came to us as a stage 4 endometriosis with complete distortion of pelvic anatomy and severe pelvic adhesions present. Ultimately, the patient could not conceive and remained a nullipara female. She started her journey seeking treatment for fertility. In the course of that, during multiple ultrasounds, she was eventually first diagnosed as a case, misdiagnosed as a case of PCOD, for which bilateral ovarian drilling was done. After that, through continuous follow-ups wherein her symptomatic complaint of chronic pelvic pain and dysmenorrhea did not subside, ultimate further USGs or further ultrasounds showed right adnexal cyst, which was initially thought to be endometrioma. Sorry, which was initially thought to be a dermoid cyst, and exploratory laparotomy was undertaken. On the histopathology of the lesion that was removed, it was confirmed to be a chocolate endometriotic cyst. Despite the first laparotomy done and there being a confirmative diagnosis of chocolate cyst present, patient was not taken up for aggressive management, and she was not advised for aggressive fertility treatments to conceive. She kept complaining of she still had same persistent complaints of chronic pelvic pain, dyspareunia, and dysmenorrhea. Ultimately, in 2011, she was admitted with a case of chronic PID, acute on chronic PID with query left ovarian cyst, and a laparoscopy was taken up, during which the POD was severely obliterated and there were multiple rectosigmoid adhesions, bowel adhesions seen, sir. During this surgery, they have still not enlightened the patient regarding her diagnosis of endometriosis so that she could have further taken an aggressive management for her infertility. Eventually, patient kept taking over-the-counter medications and was also prescribed combined oral contraceptives for her pain and dysmenorrhea. We've received the patient in July, sir, and she presented to us with a case of menorrhagia since 3 months with dysmenorrhea and chronic pelvic pain. On our examinations, we could assess that on physical examination, her uterus was found to be ventrofixed, and all her previous imagings and her USGs and previous clinical findings suggested that the patient could be a case of endometriosis. But our TVS findings also found out that the patient currently had an adenomyotic uterus with a bulky uterus with possible adhesions present in the POD. The same findings were confirmed when the patient was taken up for total laparoscopic hysterectomy, sir. Initially, the plan was to laparoscopically examine the patient because that provides the best visualization for such patients with adhesions. On laparoscopic findings, the POD was completely obliterated with multiple bowel adhesions, such that the uterus itself was very difficult to separate and mobilize. The left ovary was not visualized intra-op, possibly due to severe adhesions. It was converted in an open laparotomy, sir, and ultimately the uterus was removed. The patient was able to achieve symptomatic release through hysterectomy. After proper counseling of the patient and giving her multiple treatment options, the decision for hysterectomy was taken, and the patient was explained that this will not cure the disease itself, but will give the best symptomatic relief as of now, since the patient and her husband did not wish for fertility at this juncture. Hence, my case demonstrates a long 17-year clinical journey of a patient who was misdiagnosed at multiple steps and hence finally received to us at 37 years of age with complete distortion of pelvic anatomy, multiple adhesions, a tubo-ovarian mass, and hydrosalpinx also demonstrated in the intra findings with chronic cervicitis as well. The patient was able to achieve symptomatic relief with hysterectomy
Dr.
and
Shivangi,
was
I would like to say your time is about to come. So just conclude your slide.
Yes, I wish to conclude with this poster the importance of ESHRE guidelines, which suggest that even with proper TVS guidelines or ultrasonographic imaging, if the diagnosis is reached sooner, the outcome of the patient is better and the fertility can be preserved in a better way. Is the take-home message, sir, from this poster.
Okay, so you have did the total
Thank you,
abdominal
sir.
hysterectomy.
Yes, sir.
Hello? You did
Yes,
total
sir.
abdominal hysterectomy. What about the ovary, whether you have preserved or removed?
Sir, right-sided ovary was already removed in 2008. Left-sided ovary could
Already
not be
removed, yes. What about
visualized.
left?
Left-sided ovary could not be visualized, sir, during our hysterectomy. It was likely
Now,
very adherent.
what is the chances for further recurrence of the endometriosis in your case?
So there is always a 15 to 20% chance of recurrence in such patients, especially since the left ovary could not be visualized and removed. There is a strong chance that an endometriotic cyst or endometrioma can develop later on.
How we can reduce the recurrence in this case? Is there any options now?
Yes, yes, sir.
Ovary
There
is
are.
still there, so there are significant chances.
Yes, sir. The way to reduce recurrence in such a case is if she does not desire fertility, like my patient, she can be counseled and given GnRH antagonists because they cannot help in fertility or pain management alone, but they can at least decrease the estrogen production. And the estrogen is already going to be reduced because one-sided ovary is removed. So we can counsel the patient and start her on those medications if she wishes to.
What are the likely complications that may arise in such surgery when frozen pelvis due to endometriosis is there?
Sir, if we
complications.
encounter the likely complications should be, sir, if the bowel is completely adherent, there can be injury to the bowels. There can be injury to the other pelvic structures, like if the broad ligament is completely frozen and the kissing ovaries are present, you can also, if you're not careful and go too laterally, you can always end up injuring the ureter as well. The bowel and the rectosigmoid pouch present is likely to be injured if there are such adhesions present in the pouch of Douglas sir. And there is always a chance that because of such adhesions, some endometrioma or some nodules or some adhesions can be left inside, which are not completely removed, causing recurrence again in the patient.
Dr. Kamal sir.
The majority of the question asked by the, again, Ashwin sir. As you wrote the case report, and we are in a hybrid research conference. So as per the research protocol, which kind of the study is this? Case report or case study? Single case study?
So this is a retrospective case study that I've done after we've treated as
Whether
in,
it's a observational study, analytic study, or anything else.
no, so this is an intervention. We did an intervention, and then we also retrospectively saw what all interventions and what all treatment options the patient was given. So it is in a way, we did an intervention and retrospectively saw the clinical journey of the patient and then decided what intervention we want to do with the consent and counseling of the patient. Sorry, sir,
Okay.
I'm not able to.
Okay, thank you.
Thank you so much, sir. Thank you so much.
Someone is asking, I am also not able to listen.
Sir was asking a question, he was not able to.
Any further questions?
Okay. Thank you very much, Dr. Shivangi. Before
Thank you so
moving
much, sir.
further, I would just like to introduce our judges for the session. We have Dr. Ashwin Vachani, sir, who is Professor and Head of Department of Obs and Gynec Department, SMEMR Surat, who is also current President of Surat and Obs and Gynec Society. Welcome, sir.
Thank you, Saswat.
We have Dr. Kamal Goswami, sir, who is the Professor and Head of the Unit of PDU Medical College and Hospital, Rajkot. Welcome, sir. And we have Dr. Preeti Bajaj, ma'am, who is MS IVF Fellow, Assistant Professor at PDU Medical College for 4 years. Welcome, madam. So now we go ahead with the next presentation. The next presenter is Dr. Mayal Rao. Dr. Mayal Rao, we have made you the co-host. Please share your screen. Dr. Mayal Rao, are you able to listen to us?
So I'm sharing my screen. Hello.
Yes, we can listen to you. Yes.
Can you?
Yes. It is being processed now. Dr. Shalin Nigam, you will be next.
Okay, sir.
Please be ready.
Okay, sir. Can you see my poster? Is my
Not
being
quite.
Just a second.
I think it is in the process.
Can you see it now? Hello?
It's buffering.
Yes,
Yes,
now
we can see now. Please, go ahead.
Good morning, everyone. I am Dr. Mehta from LG Hospital, Aligarh, the second-year resident representing Narendra Modi Medical College. Today, I present a poster under the guidance of Dr. Rakshita Patel, my head of the unit, Dr. Munjal Pandya, my associate professor, and Roshni Patel, my assistant professor. I am presenting a poster about missing streams, hidden danger, discussing about extrauterine property migration with ileal adhesion following DL. So in this case, we discuss about insertion with EV post about property insertion. resulting in uterine copper migration. So, absence of retrieval strings and subsequent imaging facilitated the diagnosis of extrauterine copper migration with bowel loop potassium. This case highlights the importance of meticulous insertion technique with early imaging and IUCD strings when not visualized, and early intervention like laparoscopy or laparotomy for removal of the migrated copper in order to prevent adhesions further. I introduce immediate post-abortal insertion, that is DNE, of an intrauterine contraceptive device is a safe and effective method of contraception with low risk of complication. Uterine perforation and extrauterine migration of copper T following DNE is an exceptionally rare complication, but it has serious complications. While uterine perforation after IUCD insertion is approximately 0.4 to 1.6 per thousand insertions, and perforation after post-abortal, that is DNE, IUCD insertion is approximately 1 per thousand insertions. I report a case of a 20-year-old female with a GPAL score of P1A1L with a previous history of LSCS, who underwent dilatation evacuation for incomplete abortion followed by immediate copper T insertion. She presented 6 months later with the chief complaint of abdominal pain. Pelvic ultrasonography failed to identify the IUCD within the uterine cavity, and X-ray was done, which confirmed an extrauterine copper T. The patient was posted for a laparoscopic removal, but upon laparoscopy, it was seen that the copper T was adhered to the bowel loop. Therefore, the laparoscopic retrieval was converted to laparotomy due to adhesions in the bowel. It was successfully performed, confirming the extrauterine migration with ileal bowel loop resection, and ileoileal anastomosis was done. The post-op recovery was uneventful. Upon clinical examination of the patient's complete blood count was normal. Upon general examination, the payload was absent. Patient was vitally stable, and per abdomen examination, it was soft. There was a transverse scar of CS present, and on per speculum examination, cervix no abnormality was detected, and copper T wire was not seen on per speculum examination. On per vaginal examination, the uterus was anteverted, it was normal in size, and the copper T wire was not felt. The patient was then sent for ultrasonography. The uterus was anteverted and it was empty with no intrauterine contraceptive device visualized within the endometrial cavity, but there was a 2x2 linear echogenic structure consistent with IUCD noted in the right hemipelvis area in the interbowel region separate from the uterus and adnexa, which depicted a possibility of extrauterine displacement of copper T. Upon X-ray pelvis, there was an extrauterine copper T. The X-ray was done with a uterine sound, which confirmed that it was an extrauterine copper T in the right hemipelvis region. The patient was posted for, initially it was posted for hysterolaparoscopical copper T removal. But upon doing hysteroscopy, the endometrial cavity was normal. The bilateral corner was also normal, and the IUCD was not visualized in the endometrial cavity. On laparoscopy, a copper T wire was seen. On laparoscopy, a copper T wire was seen. The copper T wire has two arms, the vertical and the horizontal. The vertical arm was the same, but the horizontal arm was not seen. It was seen embedded in the iliocecal junction. Therefore, an intra-op surgical call was made, and the laparoscopy was converted to laparotomy. Upon laparotomy, it was found that there were adhesions in the bowel loop. Adhesiolysis was done. The ileal loop resection was done, and ileoileal anastomosis was done along with drain insertion. So I want to present an intra-op video. Just a second, sir. Sir, is my video visible?
Yes.
Yes, visible.
Yeah, sir. So you can see this was the vertical arm of the copper T, and then it is seen embedded. The horizontal arm is not seen. and it was embedded in the ileal loop. Therefore, an intra-surgical call was made for ileal bowel loop dissection. The vertical arm we can see, and the horizontal arm are seen embedded in the bowel loop. And the wire was seen embedded in the bowel loop. So therefore, a surgical call was made, and the patient was operated by surgeons thereafter. Therefore, what are the risk factors of the what are the risk factors? Sir, I present risk factors are that recent instrumentation following DNA, that is small, unrecognized. Yeah, so the risk factors were the recent instrumentation that is following DNA. Small unrecognized perforation created during DNA may allow the intrauterine contraceptive device to pass into the peritoneal cavity during or after the insertion. This is one of the most important risk factors. Or difficult or forceful insertion during the DNA procedure may also cause this, sir. Or failure to appreciate the resistance during the contraceptive device insertion may also cause this. Unrecognized uterine perforation during DNA. Perforation during DNA may not be clinically apparent, but subsequent IUCD insertion may inadvertently place the device through the perforation into the peritoneal cavity. Previous uterine surgeries such as previous cesarean section, that is, or a myomectomy or hysterectomy. In this case, the patient had a previous cesarean section history. Therefore, a scarred uterus is more vulnerable to perforation. And also, the failure to confirm IUCD position post-DNA is also an important risk factor, that is, absence of post-insertion assessment and missing strings not invested promptly. Therefore, sir, I conclude that during DNA, gentle uterine sounding should be done. Never we should force the intra-copperty. We should insert the copperty gently. Careful insertion after DNA is very essential, as the gravid uterus is soft and therefore it is more prone to perforation. Missing IUCD string should prompt immediate TVS, that is transvaginal ultrasound, and if necessary, pelvic X-ray or CT to avoid delayed diagnosis. If delayed diagnosis happens, it leads to adhesions or interbowel adhesions, as it happened in this case. And early localization and laparoscopic retrieval prevents the complication. Once the migration is diagnosed, early laparoscopic removal and prompt removal is recommended to prevent adhesions and injury to adjacent organs. And delayed diagnosis increases the risk of bowel involvement. Thank you, sir.
Suppose copperty is diagnosed accidentally outside the uterine cavity, it is purely asymptomatic. Suppose it is in anterior compartment, not in the posterior compartment, whether it is required the removal or not.
Sir, if it is completely asymptomatic and patient wishes to remove the copperty, then we can do some intervention. And we should perform an operative scopy in order to look for if the patient has any bladder symptoms or if it is adhered to the bladder anterior compartment in order to prevent further complications in the future.
So what are the warning signs or symptoms at the time of inserting the copperty that may alert that it may be the misplaced?
Sir, during insertion.
Most of the time it is problem of insertion.
Yeah, so during insertion, we have to first of all insert the copperty gently and we have to feel the resistance. Like if there is resistance, we should stop there and then insert the copperty. We should not do forceful insertion of copperty. We should appreciate the resistance during insertion of the copperty, the fundal resistance.
Any symptoms to the patients that warns us it may be some problem? Post-insertion problem?
Yeah, patient presents with abdominal pain, or patient may present with extreme bleeding PV, bleeding per vaginum. Patient may also present with not passage of stool or urine, sir.
Okay, Kamal bhai.
Any government program is running for post-abortal insertion of IUCD?
Yes, sir.
And how much compensation can be given in such kind of cases?
Sorry, sir, I am not aware. No, sir. Sir, sorry, you are not audible. Hello? 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 Hello?
MEC criteria.
Sorry,
Dr.
sir, you
Kamal
are
sir,
not.
Dr. Kamal sir, we have missed your audio. So can you repeat that again, please?
Can you hear me?
Hello?
Yes, yes. Now we can hear you, sir.
What is medical eligibility criteria for IUCD insertion?
Medical eligibility criteria. Hello? So did you ask what is the medical eligibility criteria?
What
Yes,
is
Dr.
category?
Kumail.
1, 2, 3, 4.
Hello? Sorry,
Yes,
sir. Can you
medical
please repeat the
eligibility
question, sir?
criteria. You continue.
For copper T insertion.
Yes.
Sir, if the patient wishes, if the patient wants family planning, if the patient has a previous patient has one normal full-term delivery, if the patient is having no complications and patient has normal endometrial cavity, which that
No,
is
I'm
normal
asking only gross criteria.
anatomy. Sorry, sir.
I am asking only gross criteria. Category 1 means what? 2, 3, and 4.
NDC criteria.
For any contraception. Okay, which property you have inserted in this case?
So we have inserted copper T 388.
We can't hear you.
Hello? 388. Hello?
What is the lifespan of 380A?
10 years, sir.
Okay, all right.
Okay, all right. Thank you.
Thank you very much, sir. Thank you.
Okay, so the next speaker is from our side, Dr. Shalini Nigam.
Yes, sir.
Okay, so Dr. Shalini, please share your screen. We have made you the
Yes, sir.
co-host.
Yes, sir.
So this is a poster, right? Missing strings.
Yes, sir. Poster. Yes, sir. Poster.
Yes, yes, Dr. Shalini, you can start your presentation.
No,
Yes, sir.
this is not Shalini's poster. Okay, now she's sharing. Okay.
Yes, sir. So, myself, Dr. Shalini Nigam. First of all, good afternoon, sir. Myself, Dr. Shalini Nigam. I'm from GG Hospital, Jamnagar, Shri MP Shah Medical College, Jamnagar. I have made this poster under the guidance of Dr. Nalini ma'am, my HOD. So, first of all, introduction. Diabetes during pregnancy is the most common medical disorder affecting maternal and neonatal health. My topic is impact of pre-gestational and gestational diabetes on feto-maternal outcome. So both pre-gestational and gestational diabetes are associated with an increased risk of adverse feto-maternal outcome. Definition of pre-gestational diabetes and gestational diabetes mellitus. Pre-gestational is also called pre-existing diabetes. It is seen before the it is mostly observed before the pregnancy, diabetes before the pregnancy, or the diagnosed first time during pregnancy, before 20 weeks of pregnancy. Gestational diabetes mellitus, glucose intolerance with onset or first recognition during pregnancy, usually after 20 or 24 weeks of pregnancy without previously diagnosed diabetes. So, aim of this topic is to compare the fetal-maternal outcome among pregnancy complicated by pre-gestational and gestational diabetes. Objective of this topic is to compare maternal complications, compare neonatal outcomes, and identify the relative risk of adverse outcomes in both the PGDM and GDM. And also to how to prevent and early intervention strategies. And I have taken 50 GDM patients and 50 pre-gestational diabetes mellitus patients. So first of all, pathophysiology is a maternal hyperglycemia. If there is maternal hyperglycemia present in the patient, it mostly transfers through placenta to the fetus by facilitated diffusion. Then fetal effects seen like macrosomia and altered organ maturation. Then fetal effects after that, after delivery, neonatal outcomes seen like hypoglycemia, respiratory distress syndrome, and ICU admissions, and hyperbilirubinemia leading to jaundice, congenital malformation, and maternal outcomes. After the maternal outcome can be seen mostly PPH. Patient can go in PPH, or patient can present with preeclampsia. Cesarean patient mostly see a cesarean section is done in both the PGDM and GDM. Sir, I will compare the outcome between both PGDM and GDM. Maternal outcome include mostly preeclampsia and PIH is seen in most मतलब वो दोनों में कंपेयर करें तो PGDM में ज़्यादा देखने को मिलता है preeclampsia और PIH के causes. Then preterm that includes the rate 26% in preeclampsia and PIH. Preeclampsia cases are seen in 26% of the patient in PGDM patient and 14% in GDM patient. Preterm birth is also more in the PGDM patients as compared to GDM patient. Cesarean section also seen mostly in PGDM patient as compared to the GDM patient. PPH chances also seen mostly PGDM patient. Then infection, then future risk of type 2 diabetes mellitus, both seen mostly in the PGDM patient. Neonatal outcomes also, neonatal outcome includes mostly NICU admissions in PGDM patients as compared to the GDM patient. Neonatal hypoglycemia also seen mostly in PGDM patient, 24% more as compared to the GDM patient. And then the microsomia, respiratory distress, hypercongenital, all mostly seen in PGDM patients. So pre-gestational discussion, pre-gestational diabetes demonstrated significantly higher rate of both maternal and neonatal adverse outcome compared to gestational diabetes. Fetal hyperinsulinemia secondary to maternal hyperglycemia is the key mechanism leading to macrosomia. Poor glycemic control, higher HbA1c was significantly associated with increased NICU admission, maternal complication, and neonatal morbidity. Early diagnosis, strict glucose monitoring, and appropriate management strategy can improve fetal-maternal outcomes. Key messages: PGDM is associated with significantly higher risk of adverse fetal-maternal outcome compared to GDM. Good glycemic control before and during pregnancy can substantially reduce risk. Multidisciplinary approach and timely delivery planning improve outcome. Routine monitoring and early intervention are essential for better fetal-maternal outcomes. Prevention of pre-gestational diabetes, preconception and during pregnancy. Achieve and maintain optimal glycemic control, HbA1c less than 6.5 or less than 6 before conception. Preconception counseling and education. Healthy balanced diet and regular physical activity. Achieve and maintain a healthy body weight. Avoid tobacco, alcohol, and terotogenic drugs. Early booking and regular antenatal checkups. Frequent blood glucose monitoring and appropriate insulin or medication. Prevention of gestational diabetes mellitus. Universal screening between 24 to 28 station, 5 gram OGTT. Maintain healthy body weight during pregnancy. Balanced diet rich in whole grain, fiber, fruit, and vegetable. Reduce balanced diet rich in whole grain, fiber, fruit, and vegetable. Reduce refined sugar and saturated fat. Regular moderate physical activity, 30 minutes per day. Adequate weight gain as per IOM guidelines. And early detection and prompt management to prevent complications. Thank you, sir.
Okay. What is the current government guidelines for screening of GDM?
Sir, in India, we follow DIPSI guidelines. It includes the screening at the first visit and then at 24 to 28 weeks. Fasting is not required in these patients. Sir, we give 75 gram oral glucose mixed in 300 ml of water. And then we perform it up. We measure it after 2 hours of giving this glucose. If
Suppose
blood
after
glucose
taking
levels,
the oral glucose, patient
Ji, sir?
develop the vomiting, then how do you interpret the test?
If sir, we give it. We will try to give it again after half an hour. If again vomiting happens, then we will call the patient after 1 day, next day.
No, if we give second times, then we can't calculate the dose of the sugar, glucose. Madam. So there is no point of you giving the second time the oral glucose.
Yes, sir.
Okay, what is the full form of DIPSI?
Sir, diabetes. Sorry, sir. Let me remember, sir.
Okay, Kamal bhai.
Can you tell me why there is high increasing rate of cesarean section in pre-GBM in compared to GBM?
So the voice is not audible. Hello? Sir,
Can you tell me the high rate of cesarean section in pre-GDM in compared to GDM? What are the reasons?
Sir, actually, due to fetal distress.
Am I audible?
And yes, sir, yes, sir. Due to fetal distress and macrosomia or contracted pelvis. So the rate of cesarean section is high in diabetes, the pre-gestational diabetes as compared to gestational diabetes.
Okay. What are the late sequelae patient get if
Yes. Sorry, sir.
you followed the patient in a postpartum period?
So, sir, I haven't listened the starting words. So sorry.
What are the late sequelae?
Late.
Suppose you followed both the patient, GDM and pre-GDM cases for next, say, 6 weeks, 6 months, and 6 years. What are the late sequelae? How many patients continue the diabetes? How many patients develop nephropathy? How many patients develop retinopathy, like that?
Yes, sir. In most cases, in pre-gestational diabetes, just diabetes मतलब diabetes ज़्यादा देखने को मिलता है, मतलब DM2 के पेशेंट्स ज़्यादा मिलते हैं pre-gestational diabetes में, मतलब after 6 weeks अगर हम उनको मॉनिटर करते रहे तो. And
what is your opinion
if
whether
not,
patient's venous blood is ideal or capillary?
So capillary blood glucose is mostly monitored for.
What is ideal? What do you do in a DIPSI guideline?
Sir, we do on the random blood. Sorry, capillary blood level.
Okay.
What are the indications of termination of pregnancy in a case of uncontrolled diabetes with GDH?
So, indications.
Yeah.
If fetal distress, in case of fetal distress or in case of CPD, And if uncontrolled diabetes is there, then we have to look for the symptoms of
It's okay. We can take next.
Okay, thank you. Thank you, Salini. Now next.
Yes, we can take next participant.
Hello. Start the slide sharing. Dharni, Dr. Dharni Patel.
Yes, sir.
Start your slide sharing. Okay, now visible. Please start the timer and you start, doctor. Start.
Yes, sir. I come.
Yes.
Screen.
We are seeing your poster. Visible.
Yes,
Yes.
sir. Right.
It's visible.
Sir, I am unable to see that.
What happened? You just scroll your screen. We are seeing.
Dr. Dharani, we are able
complete
to
separate
see your poster. You can go ahead and describe. Your time is also started.
Yes. Good morning, everyone. I am Dr. Dharni Patel, second year PG resident from GMERS Medical College and Hospital, Gandhinagar. I am presenting a case under the guidance of Dr. Nikhil Anand, Professor and HOD, and Dr. Vijay Kansara, Associate Professor. I am presenting a case of a complete septate uterus presenting as a primary infertility, diagnostic hysteroleproscopy with hysteroscopic septal resection. In introduction, the septate uterus is the commonest congenital uterine anomaly and is linked to subfertility, recurrent pregnancy loss, and preterm birth. It must be distinguished from the bicornuate uterus, which has an indented external fundal contour and needs different management. In modern classification like ESHRE and ASRM, define the septum by objective cavity and fundal criteria, so its reported prevalence varies widely with the criteria applied. Combined hysteroscopy and laparoscopy shows both the internal septum and the external fundal contour, confirming the diagnosis in one sitting. The aim is to that this case demonstrate that hysteroscopy and laparoscopy accurately classifies the septate uterus in primary infertility and guides a single sitting hysteroscopic correction while counseling honestly about the uncertain reproductive benefit of the septal resection. A 26-year-old woman with primary infertility, general and systemic examination and baseline investigations were normal. On pelvic MRI, it shows divergent uterine horns, mild external fundal flattening without significant fundal indentation. Intercornual angle is around 97 degrees. Single cervix and vagina, which classified it to separate uterus according to ESHRE classification U2A C0 V0. Based on the MRI findings, the decision for the surgery was made. Operative findings on laparoscopy, broad fundus, normal external contour, midline fibrotic dimple, normal fallopian tubes, ovaries, and pouch of Douglas. On hysteroscopic examination, on hysteroscopy findings, complete septum from fundus to isthmus, dividing the cavity into two, normal tubal ostia and endometrium. Septum incised with 5 mm cold seizure under laparoscopic guidance, and single symmetrical uterine cavity was made. Methylene blue chromoperturbation test was done to see for the bilateral free spillage and tubal patency, confirming the tubal patency. Here are the photographs.
First one is showing the pre-resection hysteroscopic view of the complete septum, which is dividing the cavity into two chambers. Second one is the hysteroscopic findings of fibrous septum along with the fundus. On third one, during the resection, in which one septum was cut down during, using the cold scissor. Post resection on hysteroscopy findings, like figure 4, single unified cavity was made. And laparoscopy images, first one is pre-resection, in which fundus was broad. Second, post-resection fundus contour is normal, with bilateral both headnecks are normal, and free spillage was seen on the with methylene blue. So in discussion, a septate uterus can be corrected hysteroscopically. A bicornuate uterus cannot. So the distinction may be certain before the surgery. So when imaging is inconclusive, combined hysteroscopy and laparoscopy settles it in one setting. So here it revealed the complete septum U2B that MRI had reported as partial. Resection reliably restores the cavity, but the fertility benefit is unproven. The TRUST trial found no gain in live birth. A 2025 Cochrane review found no high quality evidence of benefit, and observational data suggest benefit, but that are confounded. So conclusion is the hysteroscopic septal resection under laparoscopic guidance gives safe single sitting correction of the septate uterus with confirmed tubal patency. Accurate classification, honest evidence-based counseling about the uncertain reproductive benefit of resection are central to the management. Thank you.
How will you differentiate the bicornuate uterus and septate uterus in ultrasonography? There are some guidelines there. No doubt, combined hysterolapro is the best.
Yes, sir. In ultrasonography, we have to measure the angle between the fundus of the uterus. If angle is more than 90 degrees, then it can have a bicornuate uterus. But if angle is less than 90, then it can be septate. And if external contour, then if external indentation is less than 1 centimeter, if external, yes, sir.
Continue.
If external indentation is less than 1 centimeter, then it suggests a septate uterus.
Why there are more chances of abortion in case of septate uterus? And what kind of the abortions are more likely, first trimester or second trimester?
Second trimester abortions.
Why? Okay. Last question. What do you mean by total septum? Not complete, not partial, but total septum.
Total septum means from uterine cavity, cervix, and longitudinal vaginal septum also.
Yes. How will you manage such conditions?
Hysteroscopic resection.
No, but how will you manage hysteroscopically by vaginal septum, cervical septum? Okay. Kamal bhai?
Yes, am I audible?
Yes, sir.
Yes. My first question is, which one is better, 3D or MRI? In your case, and why?
3D USG, because MRI couldn't differentiate it between the complete septum and partial septum.
Second question is your patient needed some post-operative further workup or management?
Yes, sir. Post-operatively, we can give estrogen therapy to for the healing of the endometrium, and follow up.
Which component and what is the dose post-op estrogen therapy?
Component. Estradiol 2 mg per day, 2 mg twice a day for 21 days, and then we can give withdrawal bleeding, progesterone for withdrawal bleeding.
And why there is a little discrepancy between MRI and surgical staging. MRI is suggestive of U2A and surgical staging is U2B.
2B, yes, sir.
Any reason for specific cold seizure is used instead of bipolar?
Yes, sir. It can less thermal injury.
Okay, that's it.
My last question.
Yes. One question more.
Is hysteroscopic septal resection is required in all cases of septate uterus?
No, ma'am. If patient had complained of recurrent pregnancy loss or infertility, then we have to first we have to rule out all the causes of infertility, and then if only the septate uterus was the problem, then we have to operate for the septate uterus.
Okay.
Thank you.
Thank you very much, doctor. So we go ahead with the next presenter, Dr. Akshara Shah. Are you there? Yes, she is there. Dr. Akshara, unmute
Yes, sir.
yourself.
Yes, sir.
Yes, and share your screen.
Akshara.
Sir, is my screen visible?
Yes, Dr. Akshara, your screen is visible. Judges, can we start our session?
Yes.
Yes, Dr. Akshara, go ahead, please.
Good afternoon to all the faculties and my dear colleagues. I'm Dr. Akshara Shah of GMRS Medical College, Gotri, Vadodara. I have done my poster presentation on the topic against the odds, successful expectant management of early onset fetal growth restrictions, sir. Under the guidance of Dr. Ashish Shah, sir, my head of department and professor, sir. Sir, I would like to start with the what is an early onset fetal growth restriction, sir? Is associated with the increased perinatal perinatal mortality and morbidity due to the placental insufficiency and chronic fetal hypoxia, sir. The primary challenge in such cases, in all the cases with fetal growth restriction, is balancing of the risk of prematurity against the progressive fetal compromise. In this case, we have we can see the contemporary management mainly relies on the color Doppler and CTG testing and serial DFMC monitoring, sir. My case demonstrates how a vigilant surveillance and individual expectant management can improve a neonatal outcome in a high-risk pregnancy, sir. I had a case of 23-year-old female. She had come at 28 weeks. Sorry, sir. Is my screen still visible?
Yes, now visible. Again lost.
Sorry, sir. My case was of a 23-year-old female. She had come to us at 28 weeks plus 3 days. She had come she was a fourth parasite with fourth gravida, para 2, abortion 1, dead 2, sir, with previous to LSCS. She had a history of bad obstetric history, sir. Both the childs had died due to different reasons, sir. She had taken private visits previously, sir, where she had done an outside scan at 27 weeks, which was suggestive of 25 weeks, 3 days parameters, with her weight suggestive of less than 1 percentile and CPR index less than 1, sir. She was advised termination at 28 weeks, sir, with bad obstetric history. She had come to us for a second opinion, sir. So we had advised her that we can try and we can try to prolong her pregnancy, but it would require serial hospital indoor with everyday thrice a day CTG monitoring and Doppler every 2 weeks to 3 weeks Doppler monitoring of her with the USG, sir. We had kept her indoor in our ANC ward for almost 9 weeks. So we had prolonged her pregnancy from 28 weeks to 37 weeks. On admission, sir, we had done the steroid coverage, and a rescued steroid coverage was done, sir, at 36 weeks. Other than that, we had done continuous monitoring via CTG monitoring, DFMC, and Doppler monitoring, sir. She was given nutritional therapy and supportive treatments in view of high protein diet, alamine sachet, alamine drips, and plenty of oral fluid and good diet, sir. Uh, her serial CTG, her serial Doppler monitoring was suggestive of, sir, on admission, her CPR ratio was less than 1. Slowly, sir, it was increased to more than 1, but there were her Doppler changes resulted in stage 1 and stage 2, sir. But every day her CTG was reactive, sir. She was good in, she was perceiving her fetal movements, and there was, we could see a fetal weight was increasing, sir. We had kept her indoor, and sir, we had taken her elective section at 37 weeks, sir. She delivered a male child of 1.8 baby weight, sir. The section was uneventful. The newborn was kept in NICU for 6 days, sir, for low birth weight and FGR staging, sir. The mother and baby both were discharged at the 12th day, postpartum 12th day, sir, in a healthy state, sir. The clinical insight that I would like to give is the daily NSC complements Doppler surveillance by providing real-time assessment of fetal well-being, sir, enabling safe prolongation of pregnancy until fetal and maternal indications for delivery time, sir. And serial color Doppler is a useful way of taking a decision of continuing pregnancy versus the termination of pregnancy, sir. Sir, when we look at the Doppler changes, sir, we use the Doppler PI value of the Doppler, sir, of umbilical artery, middle cerebral artery, and the ratio CPR ratio, sir, which is a good standard to let us which helps us assess the fetal adaptation of the placental insufficiency, sir. Usually, if CPR ratio is more than 1, it is said that the fetal, we can prolong the pregnancy, sir. Here I have attached a few of the Doppler images that were seen, sir. And there is I have made a tabular column of all the Doppler, all the USGs that we had done, sir, and which is showing the chronically increasing in the fetal, effective fetal weight of the baby, sir. Thank you, sir.
Okay.
Yes, sir, मैंने आपको भेज दिया.
Hello.
Yes, sir.
Now, what are the common causes of early onset IUGR?
Sir, early on.
ये वो है बिल रिसीव कर.
ये इसमें गलती है.
Please mute yourself. Someone is speaking in
करवा के
between.
आपको भेजता हूँ. सर जी आपने अभी वो दिया नहीं है ना, सबमिट नहीं.
Hello, sir. The main causes of early onset fetal growth restriction are, sir, lacking. So one of them is lacking nutrition, sir.
Nutritional causes usually led to the late IUGR.
Okay,
early
sir.
onset IUGR means early onset in the early pregnancy, first half of the pregnancy.
First
like
half
your
of the. Yes, sir. Sir, I cannot recollect, sir. Sorry,
okay.
sir.
What are the fetal causes of IUGR? These are all maternal causes, maternal lack of the nutrition and all these things. What are
Yes,
the
sir.
fetal causes of IUGR? Mother is not responsible. Fetus, her or itself is responsible. Okay, apart from the Doppler and ultrasonography, what are the other methods for screening of IUGR during antenatal checkup?
Sir, one is most can be the clinical examination, sir. Whenever a patient comes in our ANC OPD, if her per abdomen examination, when we do the per abdomen examination, if it doesn't correspond to her gestational age, that can be one of the earliest signs that we can pick up to know if there is a developing IUGR, sir.
Okay, Kamal bhai.
Yes, my question is, why you have taken the elective cesarean section instead of still waiting for 38, 39 weeks or induction of labor?
So we had planned for elective CS because she was a previous to LACS, and the last CS done was 1.5 years back, sir.
Okay.
So we did not want to go for the trial of labor, and sir, she had already developed stage 2 FGR, sir, at 35 weeks, sir. But we were trying to wait to gain for the fetus to gain some more weight, sir. So as we were around 1.8, 1.9 baby weight, we had planned for termination before the baby goes into develops distress, or we need to take an emergency section, sir.
Okay. Do you think that the patient is benefited by doing the LECTG?
Sir, in the late stages or near-term patients, I have from what I have seen, so that it helps in knowing if there is a if the baby develops a distress, sir.
And my last question is, if your patient, say, hypothetically crosses the 34 weeks and the CTG becomes abnormal, but the Doppler study is normal, would you like to extend the pregnancy,
So can you just repeat the
or
question? I
you would
lost
like
the
to
voice.
terminate?
So I just lost the voice. Can you repeat the question, please?
Suppose your patient crosses the 34 weeks or around 34 weeks and the CTG is abnormal, but the Doppler study is normal. Would you
So
like to?
sir,
what
we
do
would
you
like to first give the corrective measures, sir. If in the view of if we see so according to the latest NICE guidelines, sir, in CTG, if it is a pathological CTG, we should plan termination as soon as possible, sir. But if the CTG is recovered, sir, with corrective measures after half an hour to 1 hour, sir, then we can wait and watch and keep a strict monitoring of the CTG, sir.
Okay, that's it. Any question?
Thank you, sir.
Thank you, Dr. Akshara, and thank you, judges. The next participant is Dr. Anjali. Yes, Dr. Anjali, you can share your screen.
Yes, sir.
Good afternoon, Dr. Anjali.
Good afternoon, sir.
Hello, start, Dr. Anjali.
Yes, sir, I am trying to share.
Yes, it started. It's in process. And it's done. You start now.
Yes, sir. Good afternoon, all the faculty. Myself is Dr. Anjali Jinjuwadia, second year resident working in the LG Medical College. I am going to present the poster on the Yusuf syndrome under the guidance of the Dr. Akshisha Patel, HOU. Vesical uterine fistula is an uncommon pathological condition developing between the uterus and cervix and urinary bladder, most commonly after the iatrogenic injury during the cesarean section, especially emergency cesarean section. My case is a 20-year-old female patient present with the second gravida with a cyclical hematuria, pain, urinary continency following in the emergency cesarean section done 1.5 years ago. For non-progress of labor in second stage of the labor, a patient came with a chief complaint of the cyclical hematuria and menstruation start after 6 months with the cyclical hematuria. On examination, patient is vitally stable. On investigation, USG abdomen and the pelvis is normal. On CT IVP, there is a well-defined fluid-filled fistulous communication between the bladder and the uterus. After counseling and obtaining the informed consent, patient opted for the trans-abdominal and trans-vesical uterine fistula repair. Cystoscopic done. On cystoscopic, there is a 0.5 into 0.5 centimeter fistula was identified on the supratriangle region. Cystostomy done racket-shaped incision was made around the fistula's connection and was deepened up to the uterus. The fistula tract was excised and opening of the uterus closed with the number 1 polygalacton suture transversely. Urinary bladder was closed in 3 layers with number 2 polygalactic and number 3 polygalactic suture. The vesico-uterine peritoneum was closed to act as a transposition between the bladder and repair uterus. The abdomen was closed and first catheter was applied. A cyclical hematuria relieved after surgical treatment. The periuretral catheter was removed after 3 weeks. The MRI revealed a well-defined hypointense scar on the T2 weighted image. Other treatment option: if small fistula detect early, we can manage conservatively with continuous bladder drainage for 4 to 8 weeks along with the antibiotic. The success rate is low, less than 5. The cause of the peripartum bladder and uterine injury resulting in the fistula formation iatrogenic. Risk factor for these is in late first or second stage of the labor, forceps delivery, manual removal of the placenta and placenta prurita. Vesico-uterine fistula is a very rare condition, account for 1 to 4% of the all urogenital fistula, represent the least common type of urogenital fistula. Majority of the cases occur after cesarean section, mostly a late cesarean section. Yusuf syndrome is uncommon. Meticulous practice of the obstetric and surgical principle during cesarean and other obstetric intervention can prevent formation of the fistula. Thank you.
Why you did the MRI after the surgery?
Sir, follow-up with checkup matters.
But whether the MRI is needed after repairing the fistula, any fistula, whether it is VVF, RVF, or utero, vesical. Okay. Can we do this case laparoscopically?
Laparoscopically? Yes, sir.
Yeah. Now, what are the high-risk indications of cesarean section where we are likely to injure the bladder? Ultimately, this is the injury at the time of cesarean section.
Yes, sir. Sir, obstructed labor and the late second stage of the labor.
Second stage seizure, obstetric labor, anything else where bladder is more vulnerable for the injury?
Placenta prurita.
Suppose there is suspicious bladder injury during cesarean, how will you confirm? On table.
We can do methylene blue dye test and.
Okay, Kamal bhai.
What is the triad of yourself syndrome?
Sir, cyclical hematuria, amenorrhea.
Is your title is yourself syndrome?
Yes, sir.
Is your
cyclical
title?
Hematuria.
Yes.
Cyclical hematuria, amenorrhea, urinary incontinence.
Which one is the gold standard investigations to diagnose uterovesical fistula?
Cystoscope.
Have you diagnosed?
So on cystoscopy there is a.
Okay. Suppose after the fistula repair, patient comes, say after 2 years with the full-term pregnancy, what do you do? Do you go for the vaginal delivery or cesarean section?
Yes, question is the mode of delivery.
What do you choose?
Okay.
Okay.
Okay, thank you.
Thank you, sir.
Last participant.
Dr. Anchal.
Last, I think.
Yes, sir. Yes, sir. She's the last one. Dr. Anchal, are you there? Dr. Anchal, please come online.
We are contacting her.
Technical team, please make her co-host. She's not able to unmute herself and Devendra bhai, Santosh bhai.
She joined. Please make her unmute.
સંતોષ ભાઈ એમને co-host બનાવી દેજો.
Sir, we didn't find her name actually.
She said she has joined. Let me ask her. She's joined by which name? Dr. Anchal, you can just write by which name you have joined in the comment section.
Dr. Anchal, you are the co-host. Please share your screen.
That is that you. Yes, Dr. Anchal, now you can share your screen, please.
Yes, sir, I'm sharing. Is my screen visible, sir?
Yes, it's visible. You can, judges, can she start?
Yes, yes. Can start.
So myself is Dr. Hashim, second year resident on Option Clinic in PDU Medical College, Rajkot. Today I'm going to present on a poster, and my topic is Bernard-Sollier syndrome in pregnancy. And I'm presenting under guidance of Dr. Shekhar Prajapati ma'am and all my assistant and associate professors and head of department. Introduction. Bernard-Sollier syndrome is an inherited platelet function disorder caused by a defect in the glycoprotein receptor 1b9 complex, which is essential for platelet adhesion. It is characterized by giant platelets, thrombocytopenia, and prolonged bleeding time. It is considered as a high risk because because there is an increased risk of severe maternal and neonatal bleeding. It's very rare and its incidence is 1 in million cases. And it is inherited as an autosomal recessive condition. Clinical features. The features are easy bruising, epistaxis, gingival bleeding, menorrhagia, excessive bleeding after surgery or trauma, or there is a life-threatening condition such as gastrointestinal or intracranial hemorrhage. Pathophysiology. In pathophysiology, there is there is a gene mutation of 1P9. That means there is a defective quantity of decreased quantity or impaired receptor on the platelet, that is 1B9, which decreases the binding to bond-delivering factors, and there is a decreased platelet adhesion to injured epithelium. Laboratory findings. In laboratory findings, platelets can be normal or decreased. Platelet size will be just, that means there will be megakaryocytes. Peripheral smear will be there will be giant platelets. Bleeding time will be prolonged, but PT time will be normal. Platelet function test will be impaired. Dystrophin induced platelet agglutation. Flow cytometry, that is a gold standard test that will have a decrease or absent GP1B9 expression. On electron microscopy, there will be giant platelets with open canalicular system. In my case, there was a patient who was 22 years old, second gravida, para 1, abortion to the line, and she presented at the gestation was 39 weeks, 4 days, and presented with lower abdominal pain, thrombocytopenia, and raised blood pressure. She was a known case of Bernard-Solé syndrome and was diagnosed since childhood. There was a positive family history as her mother was also a known case of Bernard-Solé syndrome. She was not having any bleeding diathesis during her antenatal period, and on admission, her hemoglobin was 12.3, platelet count was 20,000 with normal bleeding time. Uterus corresponding to 34 weeks with a single live fetus in cephalic presentation. In prophylaxis, we have given patient a tranexamic acid, IVDD for 7 days, 6 units of platelet concentrate, and 1 unit of SGP was transfused before the delivery. On the day 4 of admission, patient was kept for that she can go into the spontaneous labor. But on day 4 of admission, LSPS was performed as she was had become 1 day postdatism with poor bishop score and was taken LSPS under general anesthesia on 25th of June at 5 p.m. A healthy female child weighing 2.8 kg was delivered. The post-operative period was uneventful and 4 pints of platelet concentrate was transfused during the post-operative period. The patient was closely monitored for any bleeding during the post-operative period. The test for the neonate was also done, but the neonate had normal platelet and was not having any bleeding manifestation. Patient was discharged on the post-operative day after hematologist and physician opinion. Conclusion. Successful pregnancy outcome in women with Bernard-Solé syndrome requires a multidisciplinary approach, including obstetrician, hematologist, anesthesiologist, neonatologist, and transfusion medicine specialist. Careful antenatal surveillance, individualized delivery planning, timely availability of blood products, and preparedness for postpartum hemorrhage are the key components of management. With appropriate counseling, close monitoring, and coordinated care, favorable maternal and neonatal outcomes can be achieved. Despite the challenge posed by the rare bleeding disorder, continued reporting of cases and further research are needed to establish evidence-based guidance for the management of Bernard-Solé syndrome during pregnancy. That was my second presentation on Solé syndrome. Thank you.
Okay, what is your obstetric outcome in first pregnancy, whether she required any transfusion?
Yes, sir.
CS1
Sir. 4 pints platelet concentrate was transfused in her first pregnancy as per patient and relative information, and she was delivered as a normal vaginal delivery in her first pregnancy, sir.
Okay, platelet concentrate as well as the single donor platelet, both are used for the increase in the platelet count. What is the difference between two?
The single donor platelet is means useful and more effective for as patient will have less side effects and if there is a single donor plasma.
કેટલા count વધે એક single donor માંથી?
The 10,000.
10,000? No. STP, single donor platelet.
Around 25,000. Sir. STP.
No. 50.
25,000.
Okay, Kamal bhai.
So in the same case, normal delivery was conducted by us before 2 years. So why took the cesarean section this time?
Sir, patient, according to hematologist's opinion, patient could be, we could do expectant management till 40 week of her pregnancy. If she goes into the spontaneous labor, we can manage her as a normal delivery. But after that, she had become 40 week one day, and the plan for the induction was not there as she was having a low platelet count, and we have transfused after that. But so she was taken into LSCS as her bishop score was not good, and in spite of inducing that patient, it was very rare that she will deliver by normal vaginal delivery. So after that, plan for elective CS, emergency CS was taken after that.
How will you differentiate Bernard Solier from the ITP?
Indian thrombocyte. So in Bernard Solier syndrome, there will be a defective platelets. If we'll do risk-of-fit test, it will not be beneficial. I think immune thrombocytopenic culture, there will be antibodies against the platelet, so it will disrupt the platelet and will have a bleeding manifestation where the when this platelet count is normal, it can be normal as well. It is usually not, but can be normal. But there will be megakaryocytes. The platelet size will be increased and its function is decreased because the defector on platelet count, that is GP1B9, that attached to water within factor is defective.
Any blood test is available by doing which we can stamp it's Bernard?
The RIPA, risk-of-fit induced platelet aggregation test.
Okay. That's it.
As well as flow cytometry as well. So.
Okay, thank you. Thank you. Hello,
Thank you,
Dr.
Yes,
Sawan. Now
yes, sir.
conclude the session.
Yes,
We will
sir.
upload
Thank
the
you very
marks.
Yes, sir. Thank you very much, Dr. Ashwin, sir, Dr. Kamal, sir, Dr. Preeti Bajaj, ma'am, for your insights. And I'm sure the postgraduates would have taken very good points out of your teaching. And I congratulate all the postgraduate students to present their presentation and upload it over here. And on behalf of SOGOG, I thank all the judges and the participants. Thank you very much. It was a wonderful
Thank you so
learning
much.
experience.
Thank
Okay.
Thank
you.
you. Thank you.
Thank you.
क्या किया क्या क्या कॉमन सर
देवेंद्र भाई,
हाँ सर, बोलिए.
આપણે next session, shall we start with the next session?
या प्लीज चालू करते हैं.
ડોક્ટર રૂમી ભટ્ટાચાર્ય જજીસ છે, આપણે એમને મેડમ.
मैडम वॉज देयर. संतोष
yes,
भाई
yes.
उनको को होस्ट बनाइए. रूमी मैडम
बना दिया है.
नहीं, वो लेफ्ट हो गई थी, फिर से बनाइए.
ओके.
So we start with our next session, and I welcome all our three judges, senior consultant Dr. Rumi Bhattacharya madam, Dr. Purviben madam, and Dr. Kanak Lataben madam, to conduct the paper poster presentation further. So I request the first candidate, first doctor, Dr. Modia Bhumi. Is Dr. Bhumi online? Dr. Bhumi? Dr. Bhumi, you are mute.
संतोष भाई, पूर्वी पटेल मैडम को बनाया आपने को होस्ट. ओके.
Yes, fine. So now the over to judges. Purvi madam, કેમ છો? પ્રણામ.
બસ કેમ છો? નમસ્તે.
પ્રણામ madam. રૂમી madam, પ્રણામ. કનકલતા બેન, પ્રણામ.
પ્રણામ પ્રણામ.
So over to judges.
Hello. I think we are ready with the participants. Yeah. So this is a
Yes,
very
ma'am.
good initiative. It's going to be a good experience, and I think we can build on it more as we gain more experience with increasing time. The residents are at their homes, and then they are able to present and get an experience out of it without much pain and suffering. So it's a very good initiative, and I hope it will be a good learning experience for all of us.
Dr. Devendra bhai, either you or madam, the resident doctor should start the slideshow, please.
Hello. Hello.
Yes, you are very much audible. Stay online. Devendra bhai, Bhumi madam nu presentation on karso, please.
Sir, we have her abstract only. Okay. So only Bhumi has to present from their side only.
Bhumi madam, will you be able to upload your presentation, Dikra?
Yes, sir.
Please do that.
And also
Yes, sir.
all the participants has to join with your registered name for without any delay.
अभी चालू हो गया मेरा, प्लीज दरवाजा बंद कर दो.
Kanaklataben, you are mute.
No, sir, I am audible.
Now you are
Anna.
unmuted. That's fine. That's fine. Yes, Kanaklataben.
How are you?
તમને
Fine.
જોઈને આનંદ. કેટલા બધા વખતે જોયા.
Last time when you come at Bhavnagar.
પૂર્વીબેન, હું કનકલતાબેનને કહેતો હતો કે અહીંયા હતા ને ત્યારે બી એટલું ફાસ્ટ સર્જરી કરે તો હમણાં પૂછતો હતો કે હજી બી તમે એટલી જ ફાસ્ટ સર્જરી કરો છો તો કે અક્ષય હજી એટલી જ ફાસ્ટ સર્જરી કરું છું. આમ 13, 14,
થોડીક
15
ધીમી
મિનિટમાં તો
થઈ ગઈ
સિઝેરિયન
છું.
15 મિનિટમાં તો સિઝેરિયન પૂરું કરી દે. one of the fastest gynecologist I have seen. એટલે બીજા એક અમારા સિનિયર હતા સંદીપ વાછાણી, રાજકોટમાં છે. એટલું ફાસ્ટ સર્જરી કરે 13-14 મિનિટમાં તો સરસ રીતે સિઝેરિયન પતાવી દે, અને એ બી સરસ રીતે. એવું નહીં કે બરાબર નહીં.
આપણે અજેશ દેસાઈ સર પણ.
Yes, yes. Dr. Bhumiben.
Yes, sir. I can't uploaded my presentation, sir.
Bhumi madam, તમે તમારું upload, by the time you upload your presentation, shall we go to the next doctor, please, with your kind permission?
It is Dr. Kanan, sir.
Yes. Dr. Kanan.
Yes, sir. It is Dr. Kanan, not Kanan. Thank you.
I'm sorry about that.
Yes, Dr. So shall we start with our presentation?
Can you see my presentation?
About to see. Yes.
One
Judges, over to judges, please.
1 second. Nani came thai screen. How should I make it bigger? Sorry.
So that is fine. That is very much.
Okay.
That is absolutely fine, Dr. Kanu.
No, sir, I am not able to see my. Can you see my slides?
Yes.
We people are able
Okay.
to see it.
Okay. Okay. Okay.
Before
Good
putting your-
afternoon, everyone.
Okay, okay. It is visible now. Sorry.
Okay. Good afternoon, everyone. My name is Dr. Kanan Kottala, and my paper is on the pregnancy outcomes in the women with sickle cell disease or trait. So, what is sickle cell? They are caused by the mutation in the beta globin gene at the 6th position in the hemoglobin, where the glutamic acid is replaced by valine. Normally RBCs live up to 90 to 120 days, but sickle cells survive only for 10 to 20 days. So, what is the sickle cell disease, which is the homozygous state for the HBS, where both the beta globin chain have this replacement, while sickle cell trait is the heterozygous carrier state, where only one beta globin chain has this replacement. So, what happens whenever there is loss of oxygen or increased oxygen demand, polymer or rigid rods leading to a sickled RBCs, which stick to the blood vessels and stresses happen, which leads to hypoxia and pain, typically vaso-occlusive crisis. In the early 1970s, the median life expectancy of a person with sickle cell disease was 14 years. Now, 50 years, 60 years later, the median life expectancy is 40 to 60 years, and people live into their reproductive years and beyond. Although 50 years ago, people with sickle cell disease were discouraged from becoming pregnant, now most should be supported if they choose to pursue a pregnancy, but they and the doctor should be aware of the unique maternal and fetal challenges associated with it. So why should I continue? Okay. Why pregnancy is a high risk in sickle cell disease? Oxygen demand, we all know, obviously increases in pregnancy during developing placenta and fetus. Interestingly, plasmatic levels of placental growth factor, which rises during pregnancy, are already elevated from baseline in sickle cell disease, and it is thought to be correlated with the frequency of acute pain episodes. So the scenario in India, 1 second, I am not able to see my own slide. Okay, sickle belt, prevalence of sickle cell as high as 35%, comprises tribal populations of South Gujarat, Madhya Pradesh, Odisha, Chhattisgarh and Vidarbh region of Maharashtra, where 6 to 8% pregnancies present with sickle cell disease. Sickle cell disease is a major cause of maternal and perinatal adverse outcomes. It is the main reason for the need for blood transfusions during pregnancy in this belt. An important component of high-risk pregnancies to diagnose and effectively manage for successful outcome. So what all bad obstetric outcomes are related to the sickle cell pregnancies? They are gestational hypertension, PPH, repeated infections, premature rupture of membrane, oligohydramnios, unfavorable cervix, disseminated intravascular coagulation, preterm birth, small for gestational age infants, obviously severe anemia, and most serious ones are pain crisis and acute chest syndrome. So objective of my study is to study the obstetric outcomes in women with sickle cell disease or trait, which include complications, mode of delivery, and pregnancy outcomes. It's a retrospective and descriptive study aiming to analyze evolution of pregnancy in patients with sickle cell disease, which is AS or SS pattern on HB electrophoresis, with the control group which has AA pattern on HB electrophoresis in last 2 years. 80 patients' data was analyzed by using computer-generated random numbers by using purposive sampling. 40 were sickle cell disease or trait, and 40 were control. Before going into my studies description, just a quick management protocols: oxygen with propped up position for sickle cell disease or trait, soda mint or alkali treatment, zinc and antioxidant vitamins like A, C and E to reduce oxidative damage due to chronic redox imbalance and reactive oxygen species formation, folic acid supplementation and blood transfusion. Most effective but debatable management: indirectly, a transfusion reduces abnormal erythropoiesis by lowering medullary stimulus and thereby production of HBS by bone marrow. And reduced HBS decreases vascular alterations in placenta and improves oxygenation of fetus. So table 1 was hemoglobin levels of pregnant mothers. We can see mean hemoglobin in sickle group was 8.9, while it was lower compared to control group, which was 11.2. Here we can see 35% sickle group had less than 8 hemoglobin, while 10% of control group had less than 8. Another was birth weight of newborns. Mean birth weight was lower, up to 2 kgs in sickle group, while it was lower compared to the 2.4 kgs in control group. Gestational age of newborns. Mean gestational age in sickle group was 36 weeks 5 days, while in control group was 38 weeks 1 day. And preterms were around 60% in sickle group, while it was around 20 to 25% in the control group. And the mode of delivery. Here we can see that 40%, cesarean rate is much higher in sickle group, which is 60%, compared to the control group, which was around 40%. Most common indication for cesarean in sickle group were fetal distress and known progression of labor, compared to previous cesarean with no labor pain in control group. Here I have compared my study with the original article, which was published in the Journal of Obstetrics and Gynecology of India in 2005, where all the 4 parameters of hemoglobin, preterm birth, low birth weight, and mode of delivery were almost comparable with that study. So to conclude, sickle group 1 had a lower hemoglobin, lower birth weight, lower gestational age at delivery, and higher cesarean rate compared to the group B, which is control group. Most common indication of CS, as I have discussed earlier, fetal distress and non-progression of labor compared to previous LSCs in group 2. The screening of all anemic antenatal cases in sickle belt area and early, aggressive, and comprehensive perinatal care seems vital for improved perinatal outcome in these high-risk mothers. Thank you.
Okay, Dr. Kanan. The questions for you. How many of the subjects were sickle cell trait and how many were disease in the 40 cases that you've studied?
Yes, ma'am. I have mentioned it. It was around only 2 to 3 cases were sickle cell disease. As such, sickle cell disease will have so much higher rate of blood transfusions and all, so they will not be conceiving much. So mainly were sickle traits. So it was nearly
I beg to differ.
95% were sickle trait.
I beg to differ. There we receive a lot of sickle cell disease patients at our hospital at Medical College, Baroda.
Okay.
I would like to give you a data. Say last 3 years average, we had 67 sickle cell disease patients, 161 sickle cell trait patients.
Yes, ma'am. So, okay, in 40, I had 3 sickle cell disease, others were
so
sickle trait.
what the point I am trying to drive is that would it make your outcomes different? Because the number of sickle cell disease was less.
Yes,
your
ma'am.
outcomes are not going to be so poor because sickle cell trait will anyway not have such poor outcomes as disease, I believe.
Yes, ma'am, and that's why I had not much of perinatal death cases or anything.
Exactly.
And also whatever cases I have seen, even this I had started in my residency, and there mainly we saw maternal mortality also very high in sickle cell disease.
Exactly.
So a bit consciously, but I have taken a less number of sickle cell disease. Whoever had not maternal mortality or perinatal mortalities were taken mostly. Because otherwise the study would be a bit much more complicated and it would go into mortality and what were the causes and all.
Yeah, but then that is what is the real picture, right?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. What is the role of low molecular weight heparin and aspirin? Would you like to elaborate?
Ma'am, we can give it up to we should give in antenatal period, but it doesn't have much of a. I haven't seen much beneficiary effects in that. We will give prophylactically
It
in
is
all.
recommended that you give aspirin and LMWH in subjects who are having sickle cell disease.
Yes.
Right. What about iron supplementation, the routine iron folic acid supplementation?
We will not prefer iron, ma'am. Folic acid we can give. Not much of iron supplementation.
Are you sure?
Ma'am, see, there are bit of a difference of opinion here, but I believe that iron supplementation should not be vigorous, at least.
Okay, do you know about any national program regarding sickle cell condition in pregnancy or otherwise?
There are national programs for hemoglobinopathies overall, Sickle cell, I don't know.
So in 2023, the Indian government started a national program on eradication of sickle cell disease.
Okay.
And it's working very well at grassroots levels. And screening for all pregnant women, not only those in tribal belt, but all pregnant women is recommended under the
For
program.
HB electrophoresis. Yes.
Kanaklata ma'am.
Which contraceptive advice will you prefer in a postpartum sickle cell disease?
Ma'am, mainly IUCD will work good in postpartum period for these women, but not immediate postpartum. I will give it after interval. And barrier contraceptives also.
What is the new therapies? As it is a SOGO clinical research hybrid conference. So what is new advance in treatment?
Ma'am, overall, there is not much of a new advancement, but as ma'am said, which I was not aware, but prevention is the best therapy for these cases. So, better even pre-marriage screening, and and also tertiary care management with better antenatal setup will help. But as sadly in thalassemia or in any hemoglobinopathies, we don't have much of a advanced treatment or management for that.
Actually, gene therapy is a newer concept.
Yes, ma'am, but already. Okay.
Hello.
Hello, ma'am.
Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay, so what is your opinion that whether all antenatal patients should undergo the screening for abnormal hemoglobin traits, and what is the bearing of this trait on this testing? Can you hear me?
Yes, ma'am. So
Do
you are
you
talking
think
about
all
HB electrophoresis?
yeah, do you think all antenatal or pregnant patients should undergo hemoglobin electrophoresis? And
Yes,
what
ma'am.
is its bearing on the routine and quite aggressive parental therapy which are going around in the CHC, PHC levels and even in hospitals? Almost all pregnant ladies with moderate anemias are given parental iron without testing. So what is your opinion?
Okay. In my opinion, all the girls actually should undergo HB electrophoresis and thyroid even before marriage. I think वो जो बोलते हैं कुंडली मैचिंग से better everyone should go for HB electrophoresis. We have also undergone HB electrophoresis in MBBS. And for the second part, no, I am not much into favor of aggressive iron correction treatment.
Yes.
That is my personal opinion, ma'am. Because I think if you are already checking and you are tagging anemia in the first trimester, you have plenty of time. Counsel for the compliance of iron tablets only. If and at fifth month you again check the hemoglobin. If it is getting better, so in my personal opinion, I don't believe in much of injectables
Yes.
and aggressive treatment.
Have you seen any cases of iron toxicity?
Yes, ma'am. In my residency days, I have seen two, and I have even seen one patient going into ICU and had a very severe
Because
allergic
I
reaction.
have seen one case of neurological problems, patient coming with neurological problems because of iron overload in
Yes,
a
ma'am.
case of thalassemia minor.
Yes, ma'am. So actually what ma'am said, I don't believe in much
She was
iron therapy
getting
for
around
the
6 parental iron therapy.
hemoglobinopathies.
Yeah. Okay. Thank you so much.
Okay, madam. So with kind permission of judges,
Yeah, we can move on to the
if
next
it is
part.
done, we can take the next candidate, please.
Thank you so much, ma'am.
Yes.
Thank you.
Thank you.
Thank you. Is Dr. Bhumi available now? Dr. Bhumi?
Yes, sir. Yes, sir.
Bhumi, your is
Yes,
probably
sir.
now it is possible to upload your presentation. Is it? Devendra bhai?
Yes, sir. Already uploaded, sir.
Devendra bhai, तो बस please start. Madam, judges, shall she start? Dr. Bhumi?
Yes, please.
Okay.
Yes, sir. Good afternoon, respected chairperson and judge. I am Dr. Bhumi Modia from the OBGY Sri Krishna Hospital. Today I am presenting the case of first trimester bleeding revealed complete heredity for molar. This case is interesting because of the patient presented with multiple classical feature of complete mole, including
Sorry for the
high.
interruption. Bhumi, your screen is not seen, Dikra. We are able to see your face, but your presentation is not on the screen, दिख रहा. Kindly
Sir,
share your slides.
Sir, basically, I am sharing
uh,
slides.
Okay, please do that.
Okay. So, otherwise, do close your video. Okay. So, it's better to see.
भूमि बेन, देवेंद्र भाई जो बोल रहे हैं
yes,
वो सुनिए आप.
yes, sir.
Okay. So, I'm sharing my screen. It is visible.
Yes. भूमि
Okay.
बेन,
Now it is visible. Okay.
Yes, it is.
Please go ahead.
not visible.
It was visible. Now it's gone.
This is visible. Okay.
Not yet. Not yet, Devendra bhai. Yes, now it is. Bhumi Ben, can you see your slides, please?
Yes, sir.
Okay, start.
Good afternoon, sir. Respected chairperson and judges, I am Dr. Bhumi Modia from the Department of OBGY Shri Krishna Hospital, Karam, sir. Today I am presenting the case of first trimester vaginal bleeding reveals a complete hydatiform mole. This case is interesting because the patient present with multiple classical features of complete mole, including hyperthyroidism and moderate anemia, gestational trophoblastic disease. It is a spectrum of disorder arising from the abnormal proliferation of trophoblastic tissue. Complete hydatiform mole is the commonest benign form. Early diagnosis is important because delayed treatment may result in severe hemorrhage, hyperthyroidism, and persistent gestational trophoblastic neoplasia. Our patient was 22-year-old, fourth grade para to living to A1 with 11th week and 4 days of imminence. She present with bleeding per vagina for 1 day with passage of a grape-like vesicle with and also history of excessive nausea and vomiting. On examination, she was hemodynamically stable. The uterus was enlarged to approximate 18 weeks, which was significantly larger than the gestational age. On speculum examination revealed bleeding with passage of vesicles. Investigation that supported the diagnosis, hemoglobin was 8.9 gram per dl, suggesting moderate anemia. Beta HCG was greater than 1 lakh m international unit per ml. Thyroid function test showed suppressed TSH, elevated free T3 and free T4 based on the clinical presentation, and investigation diagnosis was complete hydatiform mole with hyperthyroidism and moderate anemia. The patient was optimized pre-operatively. Blood was arranged because of the anemia. Then immediately she underwent suction and evacuation under general anesthesia. Intraoperatively, multiple grape-like vesicles were evacuated, and the specimen was sent for the histopathological examination, which was suggestive complete hydatiform mole. Then post-operatively, she was monitored in the ICU because of the, hyperthyroidism and the risk of complication. She remained hemodynamically stable throughout her hospital stay. The post-operative period was uneventful. Her hemoglobin improved clinically after a transfusion, and then she was shifted ICU to general ward, and she recovered well and was discharged in stable condition with active with advice regarding the contraception and serial beta HCG monitoring. To conclude, complete hydatiform mole should be suspected in women presenting with excessive vomiting, vaginal bleeding, uterine enlargement greater than the gestational age, and very high beta HCG level. Early diagnosis and immediate suction evacuation and correction of anemia, multidisciplinary care, and strict beta HCG monitor are essential to essential for excellent maternal outcome. Thank you.
So, Dr. Bhumi, can you compare the outcomes between a complete and a partial hydatidiform mole?
Sorry, ma'am?
Can you compare the outcomes of complete hydatidiform mole versus partial mole?
Yes, ma'am. In a complete mole, fetal tissue present, and in a complete mole, no any fetal tissue, and also in a partial mole, in a beta HCG level not much high. In this case, beta HCG level more than or equal to 1 lakh international unit per ml.
What about outcomes? I think I asked you about the consequences or outcomes.
Yes, ma'am. In complete mole, risk of hemorrhage and hyperthyroidism. She antenatally she not known case of hyperthyroid after molar pregnancy. She has a hyperthyroidism, ma'am. And,
Okay, when you are following up a patient, how would you diagnose persistent trophoblastic disease?
Yeah, after beta HCG level plateau over the three consecutive week, and beta HCG level rise above consecutive over consecutive 2 week, and beta HCG level persistent 6 month, rise persistent persistent for 6 months, and histopathological examination also.
Kanak, madam.
But up to how much period would you like to take her follow-up?
Ma'am, after evacuation, repeat beta HCG after 48 hours, then every weekly beta HCG monitor until normalize, and then after normalize, then every month for 6 months, ma'am.
Up to how much time? Up to how much year?
Almost, ma'am, 3 years.
And which contraceptive advice would you like to give her?
OCP, ma'am.
Why OCP? Which other?
Because of ma'am, in IUCD we have to if IUCD is, so we have to completely beta HCG level normalize, then we have to use IUCD. So oral contraceptive and barrier method should be asked.
Would you like to use methotrexate?
Ma'am, yes, ma'am, but in persistent GTN, so ma'am, methotrexate and will be used as chemotherapy.
Dr. Bhumi?
Yes, ma'am.
Do you have idea about PSTT, persistent placental site trophoblastic tumor?
Sorry, I can't hear, ma'am.
Placental site trophoblastic tumor. Do you have any idea about this? And is there any difference between this and the regular molar pregnancy?
Hello. Sorry, ma'am, I can't hear.
Placental site trophoblastic tumor. Can you hear me?
Sorry, ma'am. Yes, ma'am. It it is arise from the proliferation of trophoblast at the placental implantation site.
Is there any difference in the clinical or lab parameters? between this and the regular molar pregnancy?
Uh, uh,
क्लिनिकली या लेबोरेटरी पैरामीटर्स में कोई डिफरेंस है कि सेम ही है मोलर जैसा?
नहीं, sorry, ma'am, in this molar pregnancy, beta HCG more than 1 lakh international unit per ml, but in other partial and placental tissue less than 1,000 milli international unit per ml.
So you want to say that beta HCG is not a reliable marker, isn't it, for PSDT?
Yes, ma'am.
So is there any other marker which we can follow?
Sorry.
Okay. Human placental lactogen. Okay. That is a more reliable
Yes, ma'am.
marker. Okay. Thank you.
Thank you.
Okay, Dr. Bhumi. I think we can move on to the next person.
Yes, madam. The next speaker, next Dr. Hardi Patel.
Yes, sir.
Hardi Ben available? Okay. Archit sir, are you able to hear?
Yes, sir.
No, I'm talking to Dr. Archit sir at Surat. No? Okay. Give me a minute. Okay, sir. Noted. દેવેન્દ્ર ભાઈને કોને અર્ચિત સર સુરતમાં છે એમને નથી સંભળાતું સર એમને સંભળાતું Meanwhile, we proceed with the case with kind permission of judges. Purviben?
Yes, please.
Shall Dr. Hardiben start? Meanwhile, we are looking upon the technical issue with Dr. Archit sir.
Sure. Yes, we can start.
Okay, Dr. Hardiben, please go ahead.
Yes. Good afternoon, everyone. I am Dr. Hardi Patel, third year resident from Pramukh Swami Medical College, and today I'll be presenting a rare challenging case, which is maternal survival in rare triple challenge, diabetic ketoacidosis, acute pancreatitis, and intrauterine fetal demise at 29 weeks. Now, diabetic ketoacidosis or DKA is a rare but life-threatening metabolic emergency during pregnancy, occurring in only about 0.5 to 3% of diabetic pregnancies. Pregnancy itself predisposes women to ketosis due to increased insulin resistance, accelerated starvation, allowing DKA to develop rapidly, sometimes even with only moderately elevated blood glucose levels. Acute pancreatitis is also uncommon during pregnancy. However, when it coexists with DKA, both conditions worsens each other, resulting in severe metabolic derangements and significantly increased risk of maternal and fetal mortality. So, the simultaneous occurrence of DKA, acute pancreatitis, and IUFD and a previous cesarean section was exceptionally rare and requires prompt multidisciplinary management. So, upon the case presentation, our patient was a 38-year-old Gravida 3, Para 1, Living 1, and Abortion 1 with previous cesarean section, who presented at 29 weeks, 3 days of gestation, and was referred to our center with diabetic ketoacidosis, acute pancreatitis, and intrauterine fetal demise. On admission, her random blood sugar level was 292, and which indicated
Excuse
significant
me, Dr. Hardi, can you
hyperglycemia.
please shift your slides? Yeah. Yes.
Okay. So on admission, her random blood sugar was 292, which indicated hyperglycemia, and HbA1c was 11.1, suggesting an undiagnosed or poorly controlled diabetes. Her serum lipase and amylase were raised, indicating and confirming acute pancreatitis, with a raised CRP, and serum acetone level was positive, and which indicated active ketosis and severe inflammation. So the patient was then immediately shifted to intensive care unit and was managed with aggressive resuscitation with IV fluids, insulin infusion, correction of electrolyte imbalance, and with broad spectrum antibiotics. After achieving the initial metabolic stabilization, the patient was then taken up for emergency C-section under general anesthesia.
and because of the previous cesarean section with IUFD and patient's critical clinical condition. And thus the patient delivered a 1.6 kg male fetus with IUFD. So, and post-operatively, the patient was then shifted to ICU, had prolonged ICU care with ventilatory support, intensive glycemic management as well. Fortunately, the patient then recovered and was discharged in a stable condition on post-operative day 10. On the clinical implication, this case highlights several important points. Those are the first, that the clinician should maintain a high index of suspicion of acute pancreatitis whenever a pregnant patient with DKA presents with severe abdominal pain, persistent metabolic acidosis. Second, the successful outcome depends on the early multidisciplinary management involving obstetricians, physicians, intensivists, anesthesiologists, and surgeons. Finally, strengthening the antenatal diabetic screening and timely referral system may help with preventing catastrophic maternal complications. On conclusion, the coexistence of DKA, acute pancreatitis, and IUFD carries an extremely high risk for maternal mortality, and early diagnosis, aggressive metabolic corrections, and coordinated multidisciplinary care with timely obstetric intervention can save a mother's life. Thank you so much.
What triggered the DKA? Was there any trigger?
Ma'am, she was already, she was actually a diabetic patient initially, which was, and she had no prior treatment of this. It was a newly diagnosed case of diabetes,
Okay.
and she
So
was
she was
not on
not
any
on any
treatment.
treatment.
Yeah.
Her HbA1c is
11.1 hatu, ma'am.
okay. So how much chances of fetal anomalies?
She was, yeah, she is uncontrolled diabetes and was pre-gestational diabetic. This indicates, because so the chances of fetal anomalies higher.
Which are common in diabetes?
Cardiac anomalies and neural tube defects, like caudal regression syndrome, and common like VSD are also common in diabetic patients.
Why IUFD occur?
That is also due to the hyperglycemia, can be one of the major reasons why the intrauterine fetal demise occurred.
What else would you put as differential diagnosis for severe abdominal pain in such a patient?
Severe abdominal pain could be acute abdomen, like could be any torsion or any appendicitis could be one of the reason, or pancreatitis.
In the
Pancreatitis
setup
was
of
there.
pregnancy?
Sorry, ma'am?
Because she is pregnant.
Ma'am, can you please repeat the question?
With pregnancy, what would be the differential diagnosis you would consider when a patient presents with severe abdominal pain?
During pregnancy, one reason can be due to abruptio placenta. Acute abdominal pain could be that of that. And could be due to any other associated conditions like appendicitis. Could be due to any torsion if there is an ovarian cyst, undergoing torsion, or due to the degeneration of the fibroid underlying in the uterus.
Were there any other evidence of acute pancreatitis apart from amylase levels?
No, ma'am, there wasn't any other indications.
Is there any history of vomiting, excessive vomiting in first trimester in this patient?
No, sir, there wasn't any history of vomiting associated.
Why vomiting is important in diabetic patients?
Because the decay leads to electrolyte imbalance, so vomiting is important.
Actually, you have
It could be a decay with hyperemesis gravidarum. It could. And what was the recovery of this patient? How acute pancreatitis was resolved in this patient? Did you follow up the patient?
Yes, sir. The follow-up was done.
And
And
how patient recovered?
the patients recovered gradually, and she still was started on insulin therapy and was they still going ongoing with insulin and regular hypoglycemic medications.
Akshay bhai, I think we are done.
Yes, madam. Okay. So thank you, doctor. We go to the next speaker, Dr. Krishna Parekh. Dr. Krishna, are you available? Krishna. Dr. Krushali Amin.
Krishna is there. Just make her.
Krishna is there. Okay.
Yeah.
Yes.
She
Am
will
I
be.
audible, sir?
Yes.
Okay. Uh, is my paper visible, sir?
Not yet. Devendra bhai.
Yeah, just a second.
So it is presenting by Krishna itself. So
Is it visible, sir?
Yes, now.
Yes.
Okay. Good afternoon, everyone. I'm here to present my paper presentation under guidance of Dr. Puvi Patel, my PG guide Dr. Garima Gandhi, and co-author Dr. Jani. The title is Multidisciplinary Management of Pregnancy Complicated by Type 3 1 disease in a research supported government hospital. 1 disease is the most common inherited bleeding disorder, where type 3 is the rarest and the most severest. In type 3, there is near complete deficiency of 1 factor and markedly reduced factor 8. And in pregnancy, complicated with type 3 1 disease, it carries an increased risk of antepartum hemorrhage, intrapartum bleeding, and postpartum hemorrhage, which requires a multidisciplinary management involving obstetrician, hematologist, anesthesiologist, and physicians. The aim is to present the successful multidisciplinary management of a primary gravida with type 3 1 disease who underwent an uncomplicated vaginal delivery without postpartum hemorrhage. Uh, the case presents as a 23-year-old female primary gravida, a booked case with regular ANC visits, presented at 38 weeks, 5 days of pregnancy with the diagnosed case of type 3 1 disease, was admitted to SSGH hospital for planned safe confinement. Her history follows as her menarche was normal at 13 years of age, but it was with irregular cycles with heavy menstrual bleeding, for which she was advised to take levonorgestrel and ethanol estradiol. Then she was on ocipil, she was on mala and ocipils. Since then, after 2 years earlier, with she presented with heavy vaginal bleeding, where she underwent a series of investigation and was diagnosed with type 3 1 disease, for which she received factor 8 and 1 factor replacement therapy for 2 to 3 doses before conception. 1 year before pregnancy, she wanted in view to conceive, she was advised to stop mala and was started on tranexamic acid, TDS. Her antenatal management was first 3 months of amenorrhea. She went to a private hospital where she had complaint of gum bleeding. She was hospitalized for the same and again received injection factor 8 and 1 factor. In third trimester, at 7 months of amenorrhea, she was admitted in our hospital where she was advised weekly injection factor 8 and 1 factor at the dose of 1500 international units, which was covered under Janani Sishu Suraksha Karyakram program, and it was continued up till term. Throughout the pregnancy, the patient was on tablet tranexamic acid, and on admission, she was started on injectable tranexamic acid. Her management presents as her admission. We had made we had the hematologist and physician reference in order of the von Willebrand disease, where the physician and hematologist advised to administer factor 8 and von Willebrand factor uh, at the dose of 3,500 international units intravenously every 12 hours for 4 days prior to the planned induction, and daily factor 8 monitoring when she was induced after 4 days with Foley's catheterization, and Servipram was used in view of cervical ripening. She underwent artificial rupture of membrane where the labor progressed satisfactorily and normal vaginal delivery took place, where she delivered a healthy male baby of 2.4 kg with first degree perineal tear with no excessive bleeding. This shows the trend of factor 8, where we have regularly measured factor 8 at the time of her admission till postpartum 2 days, which shows that the levels increased tremendously. The maternal outcome showed no antepartum hemorrhage, no intrapartum hemorrhage, no postpartum hemorrhage. The patient's vitals were stable with normal hematological investigations, and the patient was discharged healthy on tranexamic acid as well on hematologist opinion. Postpartum condition, the mother was readmitted in medicine department in view of bleeding per vagina since 2 days after 1 week of delivery, where ultrasound was performed, which revealed no retained products of conception, where she was administered 1,500 international units of injection, factor 8, 1 milligram factor once. She got discharged again medical advice after 2 days, after 2 weeks on tranexamic acid on hematologist opinion. The neonatal outcome, von Willebrand factor type 3, it is an autosomal recessive disorder. Uh, she delivered a male baby. Her Apgar score at birth was 8. At 1 minute, it was 8. And at 5 minutes, it was 9. The baby was normal and healthy, and he was discharged. And he was called for follow-up in pediatric OPD for pediatric hematologist opinion after 1 week of discharge. Type 3 von Willebrand disease is extremely rare, where pregnancy does not normalize von Willebrand factor levels. Plasma-derived factor 8 and von Willebrand factor concentrate remains the treatment of choice. Multidisciplinary care significantly reduces hemorrhagic complications. Vaginal delivery is feasible with appropriate planning. Type 3 von Willebrand disease is rare but high-risk obstetric condition. Careful antenatal planning and multidisciplinary collaborations can achieve excellent maternal and neonatal complications. Timely factor 8 and von Willebrand factor replacement allowed successful vaginal delivery without postpartum hemorrhage. Thank you.
If PPH occurs, how will you treat in this case?
Yes, ma'am.
If PPH occurred in this case, how will you manage?
Yes, ma'am. If PPH occurs, we have already kept blood products ready. Uh, uh, Platelet concentrates were kept ready. So we would administer platelet concentrate in order to control bleeding at that moment of time, so that the PPH stops. The actual underlying cause was a von Willebrand factor, but PPH can be controlled by administering the blood products like fresh frozen plasma and platelet concentrates.
Can you prevent PPH?
Yes, ma'am. We can prevent it.
In these patients particularly?
Sorry, ma'am.
In this type of patients with von Willebrand disease?
Ma'am, we can prevent PPH by starting exactly after the baby gets delivered. We will start oxytocin, 20 units oxytocin intravenously. We will administer misoprostol in order to.
These are for all patients, for these type of patients with von Willebrand disease. Anything you can give?
And additionally, ma'am.
Yes, they are lacking in factors, isn't it?
Yes, ma'am. Factors that were already administered.
Anything else? Desmopressin, etc. Can you give?
Sorry, ma'am. What?
Can you give desmopressin?
Yes, ma'am. Desmopressin can be given.
Yes, it will prevent, isn't it?
Yes,
Along
ma'am.
with you must keep an adequate level of the factors. You can give desmopressin and the tranexamic acid or other antifibrinolytics.
Yes, ma'am.
Can you give epidural?
Ma'am, We can give epidural, but it is not recommended according to GTG guidelines. In
No,
type
if the
3,
patient
it is
requests for labor analgesia, then what will you do?
ma'am, if this patient requires labor analgesia, epidural is not uh, advisable. According to the guidelines, it is said that it is in type 3, it is not feasible. It will cause more of complications rather than helping the patient with the pain.
See, in some studies, it is said that if the levels factors are more than 50 international units, then you can give. Of course, this is a type 3, it is more risky, but the
Yes.
factor levels have to be adequate. Then you may give, depending on the choice of the anesthetist and in which center you are working.
Okay.
Why it is important? How you come to know this is type 3 1 milligram?
Ma'am, sir, before coming to our hospital, she went to hematologist where she went a series of investigations which landed up to the diagnosis that she's having type 3 von Willebrand disease.
Why it is important to know type of 1 milligram and why it is important for future unit also?
Firstly, sir, there are 3 types of von Willebrand disease where in first it is quantitative, where it is mild to moderate quantitative deficiency of factor 8. In second, it is qualitative defect in von Willebrand. There's a qualitative defect, and in type 3, there is severe quantitative defect. So depending on that, the treatment of choice changes. And also the mode of inheritance, the type 1 and type 2 are autosomal dominant, and the type 3 is autosomal recessive. So it may help in further managing the patient.
For the managing the patient and the
The child that is born.
newborn also. Thank you.
Yes.
Which type of contraception is better in such a condition?
Ma'am, OC pills is more feasible in this patient because
What
it
is
will also help. Sorry,
role
ma'am.
of LNG, Levonorgestrel, LNG, Mirena, yeah.
Yes, ma'am. We can also use that, but more feasible is OC pills because it will also help in control the bleeding that the complaint she is having.
Actually, barrier is best, and second one is LNG, yeah, Mirena.
Okay, ma'am.
Okay. Any further questions from any of the judges, please? Are you done with this presentation? Oh, okay, thank you. We move to the next doctor, Dr. Krushali Amin. Dr. Krushali Ben, are you available?
Hello?
Yes, Dr. Krushali Ben.
Yes, sir.
Okay. Devendra bhai, Krushali Ben ni slides.
I will screen share.
Okay. Over to judges, please.
Is the presentation visible?
Partly. The slides are being cut at the bottom.
Is it visible, ma'am?
Lower part is not visible.
I think you should open it and save it on the desktop or somewhere and then open it.
Okay, ma'am. Share. Is it visible, ma'am, now?
Yes, it is visible. Judges, please.
Yes. Yeah, please go ahead.
Go ahead, Dr. Krusha.
Visible. Good afternoon. I'm presenting on the maternal near miss to maternal mortality, a perfect storm when typhoid mimics cardiac emergency in pregnancy, unmasking Sjogren's syndrome during pregnancy. Maternal septic shock secondary to enteric fever with profound hypokalemia, severe sinus bradycardia, and newly diagnosed Sjogren's syndrome in third trimester of pregnancy. A 32 years old gravida, 2 para 1 living one with previous one lower segment cesarean section, 34 weeks, came to our hospital from a private hospital in Borsat for management of enteric fever with history of fever since past 5 days. Patient presented with complaint of lower abdominal pain and outside vidal positive reports with severe nausea and vomiting. Before going into the details of the case, I'd like to discuss the basic pathogenesis of the case, wherein typhoid fever, the basic etiological agent is Salmonella typhi, which is transmitted via the fecal-oral route. Contaminated food or water is responsible for the same. This organism survives gastric acidity, invades Bayes patches through the specialized M cells, escapes the intracellular killing, and spreads or seeds into the RE system, the reticuloendothelial system, namely mesenteric lymph nodes, liver, spleen, bone marrow, and results in primary bacteremia. In this particular case, there are certain pregnancy-related immune changes, namely reduced the Th1 immunity and increased Th2, type 2 humoral immunity with altered macrophage and neutrophil function. The adaptation surely reduced the fetal rejection, but also impaired the clearance of intracellular pathogens like Salmonella typhi, allowing a greater bacterial proliferation as shown in the figure. Secondary to the primary bacteremia, there is cytokine storm and implication of sepsis in the patient. Progressive bacterial multiplication stimulates the release of certain cytokines like tumor necrosis factor alpha, interleukin 1-6, nitric oxide. These inflammatory mediators produce systemic vasodilation, resulting into hypotension, increased capillary permeability, relative hypovolemia, myocardial depression, leading to septic shock, characterized by tissue hypoperfusion and hypotension. Subsequent SIRS, systemic inflammatory response syndrome, converts into multi-organ dysfunction syndrome, resulting into acute kidney injury, metabolic abnormalities, lactic acidosis. Pregnancy further increases oxygen demand, making maternal decompensation even more rapid. Hypokalemia, basically in this case, due to persistent vomiting causing GI, gastrointestinal potassium loss, intracellular potassium shift during recovery from acidosis and stress, and underlying Sjogren's syndrome, which was by the course developed, which can cause distal renal tubular acidosis with excessive urinary potassium loss. The combination produced extremely low serum potassium values, 1.2 milliequivalents per liter. Severe sinus bradycardia, profound hypokalemia alters cardiac membrane excitability by impairing myocardial repolarization, giving results in sinus bradycardia, ST segment depression, ventricular arrhythmias, and certain fetal effects like preterm labor in this particular case. Reported cases of typhoid fever in pregnancy generally describe miscarriage, preterm labor, fetal loss, and maternal sepsis. Here, in my case, profound hypokalemia in pregnancy, mostly associated with hyperemesis gravidarum, distal renal tubular acidosis, was one of the reasons. Sjogren's syndrome associated with distal renal tubular acidosis has been reported as a cause of severe hypokalemia during pregnancy. However, concurrent septic shock due to enteric fever has rarely been documented nowadays. This case therefore contributes important clinical evidence regarding recognition of refractory hypokalemia in septic obstetric patients. The patient came to us with normal temperature, pulse 44,
Sorry
BP
to
was...
interrupt.
Yes, ma'am.
Are we supposed, are we supposed to see all this on your slides? Because we are seeing the first slide.
No,
Yes, ma'am.
I'm saying only first.
Sorry, ma'am.
Your slide is not moving. We are saying only first slide.
Okay, yes, ma'am. Just a second. Sir, can you share my slides since I'm not able to Hello?
Just share me now on the same number, please.
Yes.
Do it as soon as possible. So I just share you. You just stop sharing your screen, okay?
Yes.
That is visible?
Yes.
Okay.
I think
Hello?
that Dr. Krushali.
From the beginning, ma'am?
No, I think that we've seen. You can start from wherever you stopped.
Yes, ma'am. So, reported case of typhoid fever in pregnancy generally describes miscarriage, preterm labor, fetal loss, and maternal sepsis. Just as I explained the basic pathogenesis of the process, the patient here was, she came here with afebrile temperatures, hypotension, and 44 pulse. She had outside Vidal positive tests, and during the course, we discovered that she has Sjogren's syndrome. Anti-Ro and anti-La antibodies were positive. The further management that we did was we gave 5 cycles of KCl with magnesium sulfate, with the support of magnesium sulfate. Following stabilization, fetal distress developed, necessitating emergency lower segment cesarean section. Platelet transfusion were administered perioperatively because the platelet counts also declined approximately to 90,000 from 150,000. Initially, post-operative recovery was satisfactory. However, patient developed persistent fever. Radiological imaging revealed bilateral pleural effusion. ICU care and multidisciplinary management was taken care of. The patient developed altered sensorium followed by sudden cardiac arrest on the post-op day 12. Cardiopulmonary resuscitation was unsuccessful. Thus, the main clinical relevance of my case would be that enteric fever may rapidly progress to septic shock during pregnancy. Potassium being less than even 1.5 milliequivalents should immediately raise concern for life-threatening arrhythmias. Bradycardia in septic pregnancy is unusual and should prompt electrolyte evaluation. Early ICU involvement, multidisciplinary management were crucial. Severe hypokalemia refractory to replacement should prompt investigation for renal tubular acidosis and disorders and autoimmune diseases, including Sjogren's syndrome. Conclusion, enteric fever during pregnancy should not be considered a benign illness. Development of septic shock with severe bradycardia mandates immediate evaluation for electrolyte abnormalities. Profound hypokalemia that is disproportionate to the gastrointestinal losses should prompt investigation for renal tubular disorders, and early multidisciplinary management, aggressive electrolyte correction, and timely obstetric intervention remain the cornerstone for successful management. Thank you. Can all the slides be reflected on the screen, please, sir? Hello?
Yeah, just a sec.
Next slide. Next, please. Next, please. Next. Next, please.
So what were the features of hypokalemia that you observed in the case?
Ma'am, the patient was lethargic. The ECG changes showed ST depression and T inversion. There were a few episodes wherein the patient was noted with ventricular arrhythmias, and patient was malaise. There were multiple episodes of nausea and vomiting.
Where the patient is already diagnosed with?
Yes, ma'am. The patient came with outside positive Vidal tests. The titers were elevated and she had a positive Vidal test. We reconfirmed it at our facility as well here. Although Vidal is not a gold standard diagnosis for typhoid fever, so we again did blood cultures and stool cultures were also sent, which were diagnostic of the same, that the patient had enteric fever and had typhoid. And during this thing, in spite of giving 5 cycles of potassium correction along with magnesium sulfate, her potassium levels were not corrective. And that's how we involved the nephrology team. And during the course of her stay, which was approximately of 15 to 20 days, we came to know that she has an underlying Sjogren's syndrome as well, since the anti-Rho and anti-La antibodies were positive.
Did she have any features, signs of acute abdomen? Is typhoid-related intestinal perforations?
There were no ma'am. There were no intestinal
There are no
perforations.
features.
No features of intestinal perforation, no features of myocarditis as well, ma'am, which is very commonly associated with typhoid. There was no gastroenteritis also. But yes, she did have fever persistently before she came to our facility for approximately 5 to 7 days. And post-operatively, she had recurring fever episodes till almost post-op day 12.
How was the baby?
Sir, the baby, since we did an emergency C-section because at 34 weeks, the baby was kept on NICU CPAP, thereafter recovered well on NICU room air, and now they have taken it to their home. The baby is fine, sir, but we lost the mother during the course.
So,
Is there okay? Yes.
Is there septic shock followed by persistent hypokalemia, or there was no septic shock and only? So, what do you think? Enteric because mother died because of enteric, or died because of Jograns?
No, sir, the mother has died because of the septic shock, which was secondary to enteric fever. Because on her on admission, her vitals, apart from the blood pressure and pulse, as far as her complete blood count, CRP, ESR, and procalcitonin levels were concerned, they were all normal, which further on worsened after post-operative period due to secondary sepsis.
So,
If
in a
it
way,
is because
would you say that the surgery precipitated the condition? Would you say that?
Surely, ma'am.
Not that it could have been avoided. I'm just.
Yes, ma'am.
Yeah.
Ma'am, there could be a possibility because we were waiting for the feto-maternal stabilization before we could perform termination of pregnancy, since her potassium levels were not normal in spite of giving 5 cycles. Once we obtained an optimum range of 2.5 potassium, we did an emergency C-section. In view of secondary fetal distress, the NST was non-reassuring and the fetal heart dropped to 110 beats per minute. And yes, ma'am, secondary to cesarean section, this could have precipitated more.
बेटा जोग्रान syndrome में fetal heart तो आम पण ઓછા રહે. So is it a real fetal distress? એના fetal distress સિવાય બીજા બધા parameters કરાવેલા હતા સોનોગ્રાફીમાં બીજી રીતે
Yes,
જોયું?
sir. Yes, sir. We did a USG OBS Doppler here after she was admitted at our facility. At that time, the parameters were normal. And on the 5th day after she got admitted, we went for the emergency C-section.
What is the risk to the fetus because of Sjogren's syndrome?
Ma'am, fetal distress, preterm labor, fetal hypoxemia, fetal acidosis.
Anything special because of Sjogren's? Because of the transfer of the maternal row and all that? Is the baby still alive?
Yes, ma'am. In our facility, the baby was kept in the NICU room air. Yes, it was.
Okay.
She was fine.
Yeah. So because of the transfer of the maternal and those anti-row, Ra and whatever, is there any specific problem the fetus or the newborn baby can face?
Ma'am, other autoimmune disorders can also be transmitted to the baby.
બેટા એના સિવાય હાર્ટમાં કઈ થાય?
Yes, sir.
હાર્ટમાં કઈ fetal હાર્ટમાં કઈ થાય? persistent fetal heart કદાચ fetal જે તમે distress લાગ્યો હોય fetal distress ના બી હોય એવું બી થાય ને. તો પેશન્ટ સેટલ થવા દીધું હોત તો વધારે સારું નહીં હતું. પહેલા તમને ખબર જોગ્રાન પાછળથી ખબર પડી કે પહેલા
સર પાછળથી ખબર પડી સર અમને ખબર જ નથી કે જોગરન છે પેશન્ટ ને એમને પોતાને બી નથી ખબર.
થયા પછી ખબર પડી ને કે
યસ સર સિઝેરિયન કર્યા પછી ખબર પડી.
ઓકે.
Actually, એવું બેબી હોય ને congenital heart block તરફ હોય છે થોડું.
Yeah, yes.
Yes, ma'am.
Okay. Yeah, I think we have no more questions. Thank you, Dr. Krushali.
Thank you, ma'am. Thank you.
દેવેન્દ્ર ભાઈ, I think આ 5 જ હતા ને presentations?
Yes, madam. ये
આ
complete हो
session
गया
માં.
ये session. We
हाँ.
move to next session. Okay.
Okay, thank you.
Yeah. And okay.
Okay. Thank you so much.
Thank you.
Thank you.
Hello. So we are done with the session and we proceed with the next session. Before that, I would like to thank all the judges for sparing time. Dr. Rumi Bhattacharya madam, Dr. Purvi Ben madam, Dr. Kanaklata Ben, and Dr. Archish Bhai. Archish Bhai કેમ છો?
Thank you, Akshay.
અર્ચિસ તને કેમ છો પૂછીને તરત જ દીપ્તિનો ફોન આવ્યો બાજુમાં.
એટલે અમારા પૈસે
યસ એ બધી સાચી લાગણી હોય ને એટલે એવું.
બરાબર.
So we go with the next session. Next session માં બી પૂર્વેન if I am not mistaken, you are there in the as a judge. કદાચ તમારી સાથે communicate થયું હોય ને તમે હા પાડી હોય કે you will be able to stay for little more duration. Is it like that or કે ના એવું ત્યારે નહોતું પણ હજી બી શક્ય છે? તો would you like to stay online? તમને feasible હોય તો?
હા, બેસી શકું છું. એટલે
Sure, તમારું
ત્યારે
lunch
નતું પણ હમણાં ફિઝિબલ છે.
હા અને તમારા lunch નું તો પૂર્વીબેન?
I am done. હા.
Sure.
Okay.
So we go with the next session. Archis bhai and Dr. Rumiben, thank you for your involvement. Archis bhai, the same statement stands true for you as well. કે તમને feasible હોય તો કે તમે
No, I will
busy છો?
leave. No.
સારું,
Okay,
અમને
thank you.
ક્રાઇસિસ થશે તો હવે અમે તમને ફોન કરશું કે અમારે જરૂર છે.
Sure. Okay.
થેન્ક યુ હર્ષિશ ભાઈ. અમદાવાદ આવો તો ઘરે આવજો. દીપ્તિને ગમશે, મને ગમશે.
ચોક્કસ.
Thank you. So we go with the next doctor, Krishna Patel.
Yes, sir.
Dr. Rohit bhai, as a judge, are you online available? Madam, give me 1-2 minutes. I'm trying to adjust the co-judge with Dr. Purviben madam, Dr. Krutiben Deliwala and Dr. Rohit Jain. Give me 2-3 minutes time. I'm working upon it and then we will start the session.
ને meanwhile મને પેલું આ સેશન નું ગૂગલ ફોર્મ મોકલાઈ આપજો.
Ha, we'll do that.
I'm sharing, madam. No worries.
Dr. Rajni Parikh madam. Give me 2-3 minutes. We'll revert back to you.
बड़ोड़ा के वो डॉक्टर पूर्वी मैम है ना
रोहित भाई 1 मिनट बात करूं. રોહિતભાઈ, સોબોગમાં આપણું પેપર પોસ્ટર કોન્ફરન્સમાં સેશન શરૂ કરીએ છીએ, જેમાં આપ જજ છો, તો તમને અત્યારે ઓનલાઈન જોઈન થવું કન્વીનિયન્ટ છે? તો શરૂ કરીએ છીએ સેશન સર, તો જોઈન થાવ ને સર પ્લીઝ. તો પૂર્વીબેન બરોડાથી મેડમ છે, આપ છો. ભાવનગરથી ડોક્ટર રજનીબેન મેડમ છે. પછી એ રતિબેન બી જોઈન થયા છે. આપ બી થાવ તો હવે 2 મિનિટમાં શરૂ કરીએ. સર એક જ મિનિટ કહું, 5 8 40 મિનિટ 40 મિનિટ સર. હે ને? થેન્ક યુ સર. તો તમે જોઈન થજો ને સર. હા સર, હા સર, થેન્ક યુ સર, થેન્ક યુ. ડોક્ટર કૃષ્ણાબેન,
Yes, sir.
are you ready? So Dr. Purviben madam and Dr. Rajniben madam, over to Dr. Purviben and Dr. Rajniben. Let us start with the first doctor of your session.
Sure, let's start.
Purviben, over to you.
Okay, we can start with Dr. Krishna. Hello, Rajni Ben. Unmute કરવું પડશે.
રજુ સાહેબ જાડે આ એક જણાવ્યા આપશો. તમે દેવેન્દ્ર બેન કહો ને તો કૃષ્ણાબેન નું મોકલેલું એ નહીં, કૃષ્ણાબેન આ થઈ ગયું. ઓકે, કૃષ્ણાબેન નું સ્લાઇડ શેર કરાવડાવો. કૃષ્ણાબેન, આર યુ એબલ ટુ મેક ઇટ અપ?
No, sir.
Rajni madam,
Just give.
your mic is mute. Please unmute. Rajni Ben, you are not audible.
Dr.
Kindly
Krishna,
unmute.
please try to share your slides.
उनके साइड नहीं हो रहा है कृष्ण. ओके.
Yeah, started.
મેડમ તમારું અનમ્યુટ કરો ને, તમારું મ્યુટ છે. કરી દઈએ. હા, રજનીબેન નું અનમ્યુટ કરો ને, રજનીબેન મેડમ નું. તમને ફોન કરાવડો મેડમ, અને તમને ગૂગલ માર્કશીટ મોકલું. અને કદાચ કઈ કન્ફ્યુઝન થાય મેડમ તો તમે અત્યારે પેપરમાં લખજો, પછી કરી દઈએ. પણ એને પહેલા તો અત્યારે આમ તો તમને અનમ્યુટ કરી શકાશે.
જો ડોક્ટર સંગીતા રાહ જોવે છે, એને ઇન્વોલ્વ કરો. નિતિનભાઈ નો ફોન હતો.
संगीता पांडे.
હા, રાહ જોવે છે.
ઓકે રજની મેડમ.
Hello. Yeah.
Purviben and Dr. Rajniben both are available now. Dr. Krishna, you may please start. Your judges are ready. Yeah.
Sir, my slide is visible.
Your
You
your
are not
slides are
visible.
Yes.
it is which is visible dikra.
Can I start?
Yes, please.
Good morning to respected judges and one and all. One and all present here. My topic is think beyond a tubal ectopic, a rare left ovarian pregnancy with coexisting pulmonary tuberculosis. Myself, Patel Krishna, guided by Dr. Kanak Latanakul.
So it is a request, kindly mute or microphone except the judges and Dr. Krishna Ben, please. Everybody is requested to mute your microphone except the doctor who is present in the case and both the judges and Rohit Bhai if he is able to join. Dr. Krishna,
Yes, sir.
start your case.
Myself, Dr. Krishna Patel, guided by Dr. Kanak Lata Madam, Department of Obs and Gynecology, Government Medical College, Bhavnagar. Today, my topic is a thing beyond a tubal ectopic, a rare ovarian pregnancy with coexisting pulmonary tuberculosis.
Introduction. Ovarian ectopic pregnancy is a rare form of ectopic pregnancy accounting for 0.5 to 3% of all ectopic pregnancies. It is often misdiagnosed as ruptured corpus luteum cyst or a tubal ectopic pregnancy. Early diagnosis using transvaginal ultrasound and serum beta HCG is challenging but crucial because ovarian tissue is highly vascular and cannot stretch to accommodate a growing embryo. This condition carries a massive risk of severe internal bleeding. It is considered a crucial medical emergency that usually terminates in tissue rupture during the first trimester. Case presentation. My patient profile. My patient is a 26-year-old female, G5P2A2L2, 6 week of pregnancy with a known case of pulmonary TB, present with bleeding per vaginal since 3 days. On clinical examination, vitals are stable. For abdominal examination, it is soft and mild tenderness was present. On per vaginal examination, uterus is normal size, no cervical motion tenderness at present. Spotting present. On laboratory finding, UPT faint positive, serum beta HCG 11550 milli international unit per ml, ultrasound finding approx 19 into 15 size thick wall lesion noted in left adnexa with internal small cystic area with peripheral rim of vascularity. Intraoperative finding during laparotomy on intraoperative finding during laparotomy on gross examination, left ovarian ectopic pregnancy, approx 2 into 3 centimeter mass was present, which is unruptured. Left fallopian tube is normal, right ovarian and fallopian tube is normal, bilateral uterosacral and pouch of Douglas are normal. On operative note, laparotomy left-sided partial oophorectomy is done and specimens sent for histopathological examination. On histopathological examination, a gross examination that is 2.5 into 2 into 1.5 centimeter size, creamish white firm single tissue species received. On cutting open, bright yellow with central small white area and peripheral scanty grayish tissue was seen. Whole tissue was processed and on microscopic examination studies saw ovarian parenchyma with extensive utilization, few follicle with stoma, evidence of product of conception was present. Discussion. Ovarian ectopic pregnancy is a rare and require a high index of suspicion. Risk factors include IUCD use, assisted reproductive technique, pelvic inflammatory disease, previous ectopic pregnancy. Pulmonary TB does not directly cause ovarian ectopic pregnancy but may coexist and complicate perioperative management. Fertility preserving surgery should be considered whenever feasible. Conclusion. Ovarian ectopic pregnancy, though exceptionally rare, should remain a key differential diagnosis in every woman presenting with early pregnancy bleeding and an empty uterine cavity. Prompt ultrographic evaluation, timely surgical intervention, and histopathological confirmation are life-saving. This cause highlight the importance of maintaining a high index of suspicion even in presence of coexisting conditions such as pulmonary tuberculosis to preserve maternal health and further fertility. Thank you.
What was your histopathological diagnosis?
My histopathological diagnosis was a gross examination.
No, gross, not microscopic.
A studied section with ovarian parenchyma with extensive utilizing few follicles and a product of evidence of product of conception.
Okay.
So what are the diagnostic criteria for an ovarian ectopic?
The diagnostic criteria is Figelberg criteria, in which there are four criteria is included.
in which the tube should be patterned of the side of which means the tube should be patterned at the ovary in which the ectopic pregnancy has occurred. The G-sac should be present in the ovary. The G-sac of the ovary should be connected to the uterus by by ovarian ligament, and the histology there should be evidence of histopathological examination.
Was there any lesions because of tuberculosis in the abdomen?
Yes, ma'am. There was a lesion. The tube, the at the back of the uterus, there was a small uh, raised lesion was present.
What sort of lesion was present?
Sorry, hello.
Yeah, go ahead. What was the lesion that you mentioned?
There was a very small raised multiple lesions was present.
Did you send them for histopathology?
No, ma'am. The patient was on ATT, so we have continued the ATT treatment.
Okay. I think we can move to the next.
Thank you, doctor. Now the next doctor to present the case is Dr. Darshit Dodia.
Yes, sir.
Yes, sir. Over to judges, please.
Yes, Dr. Darshit.
Rohit bhai, welcome. Rohit bhai, you need to unmute your mic. Kindly unmute. Okay, doctor, you may
Is
please
my
start the
slide visible,
case.
sir?
You are audible. Go ahead.
My slides is visible, sir?
No.
Yes, very much.
Okay, sir. Okay, thank you.
Yours?
So, good evening, judges. Myself, Dr. Darshit Dodia. I am a first-year resident in the Department of Obstetric and Gynecology at Government Medical College, Bhavnagar. I have prepared this presentation under the guidance of Dr. Kanaklata ma'am. The topic of my poster is Against the Odds, a Successful Vaginal Delivery with Just 4,000 Platelet Counts. Introduction. Severe thrombocytopenia during pregnancy is a rare but potentially life-threatening condition associated with significant maternal and fetal morbidity. Management becomes particularly challenging when complicated by labor and premature rupture of membrane, requiring multidisciplinary approach to minimize hemorrhagic complications. Case summary. A 25-year-old female patient who is primigravida presented at 38 weeks, 3 days of gestation with 10 hours of prom and severe thrombocytopenia and was in a labor pain. On presentation, patient had a platelet count of 4,000, and on taking a history, we found that there is a decreasing trend of platelets in the patient has a 70,000 platelet count on 19/12/25, 27,000 count on 27/3/26, and patient presented at 4,000 count on 8/04/2026. Patient has a past history of transfusion of 2 units of packed RBC and 2 units of platelet concentrates. So in view of 10 hours of prom, we induced the patient with CP gel, and the delivery outcome was a full-term normal vaginal delivery with a mediolateral episiotomy, and a healthy female baby with a birth weight of 2.5 kg was delivered. Baby was admitted in an NICU and was under observation. The baby was on a room air and was successfully breastfeeding. During the intrapartum period, we transfused 4 units of PEG cell concentrate, and after during the postpartum course, we again transfused the patient with 4 units of PEG cell concentrate, 1 unit of SDP, and 4 unit of FFP. Even after all this transfusion, the platelet count of the patient dropped from 4,000 to 2,000. So we ordered many investigations to rule out other causes of thrombocytopenia. The patient had a negative dengue, negative malaria, even immune hemolysis was peripheral smear of the patient shows severe so severe thrombocytopenia with abnormal RBC with normal RBC morphology. So we did further management. We take a physician opinion.
You are not clear. You use a different net, I think.
And we started pulse methylprednisolone.
You are not
Any questions
audible.
from the? Sorry, yes, madam. Please, आप बोलिए.
नहीं वो लास्ट का सुना ही नहीं दिया. He's not clear. शायद नेट के इश्यूज है.
Might be. Dr. Dodia, sir. It seems that he is. Yeah, you are right, madam. He is not in the network. Let me call him. Wait for a minute, madam.
Hello.
Dodia, sir.
Hello, am I audible, sir?
You are audible now.
Okay, sir. Sorry
In
for the
between the
disturbance.
part, yeah, no problem. There was some connection problem. Madam, over to judges, please. Dr. Rohit, sir, you need to unmute.
Discussion was not audible.
Shall I repeat, ma'am?
Yeah, repeat from discussion.
Okay, sir. Diagnostic and therapeutic challenge. Severe thrombocytopenia, a term carries an extremely high risk of maternal hemorrhage. Determining the safest timing and mode of delivery requires balancing obstetric indication against bleeding risk. Platelet transfusion alone often provides only transient improvement in immune-mediated thrombocytopenia. Corticosteroids play a pivotal role in achieving a sustained platelet recovery. Conclusion. Number one, severe thrombocytopenia in pregnancy demands early recognition and multidisciplinary management. Number two, platelet count may remain critically low despite multiple transfusion, highlighting the importance of identifying immune-mediated causes and initiating a corticosteroid therapy. Individualized obstetric management with timely blood component support can result in favorable maternal and fetal outcome even in extreme thrombocytopenia.
Yes, so Dr. Darshit, a nice case and very good presentation. But the only thing that I want to point out here is, though you have written a normal vaginal delivery, but I don't consider it as a normal delivery, right? So it's good to
Okay.
mention only vaginal delivery.
Yes,
You
sir,
must
that's
be
right.
knowing what are the criteria to fulfill a term like normal delivery, right?
Yeah,
So
that's right, sir.
she
I will
being having
definitely correct, sir.
thrombocytopenia, yes. Otherwise, I think you had given SDP
Yes,
to
sir. I
her.
have one pint SDP, 8 pints of
Hmm.
platelet concentrate, and 4 pints of FFP, sir.
Okay, so are there any guidelines for that SDP for choosing an SDP over normal platelets?
Sir, as far as I know, sir, we choose SDP because of the sir platelet efficiency. 1 pint of SDP improves platelet count by around 50 to 80,000, I think, 50 to 70,000, while one pint of RDP increases platelet count by only 5 to 10,000. So, in such cases of severe thrombocytopenia, we preferably use
So is it available there
SDP.
in your
Yes, sir. We
institute?
have. Yes, sir. Yes, sir. We have issued
Okay.
SDP, sir.
Okay. Okay, right. So, in such cases, if required, would you go for any operative vaginal delivery?
Sir, we can go for operative vaginal delivery, but if only if there are any obstetric indication. Otherwise,
Yes.
we can go for vaginal delivery, sir.
Yes, exactly. All right. No more questions from my side.
Thank you, sir.
What care you will take during the postpartum period after you have delivered the patient? What are the other complications that can occur in case of thrombocytopenia?
Ma'am, we have to continuously monitor patient for the PPH. And ma'am, since a lot of blood products are going, so we have to also look for ma'am whether there is a transfusion overload. We can keep a water clot pad inside a vagina to um, to minimize oozing.
Anything about the wound? Episiotomy?
Ma'am, I'm not getting what specifically what do you
Which
want?
complications can occur in the sutures or episiotomy you have taken?
Okay, ma'am. Hematoma can occur in a
Okay, so you
episiotomy.
should look for hematoma in such
Yes,
patients.
ma'am.
PPH you
We
are
can
already
we can
managing.
monitor pulse and BP of the patient. We can also monitor temperature so that.
Okay.
Okay, thank you. Any further questions from any of the judges, please?
No.
No, thank you.
Okay, thank you, doctor. Thank you, Dr. Darshit.
Thank you.
We go ahead with our next doctor, please. Dr. Hershey Saab. Dr. Hershey. Meanwhile, if
Yes,
yes, Dr. Hershey is there.
yes.
Dr.
A very
Hershey,
good
are you ready?
afternoon.
Good afternoon, Dikra.
Yes,
Are you ready with your presentation?
yes, yes,
Over
I
to
am.
judges,
I
please.
am. Just a second. Can you? Is my poster visible, sir?
It is off-center. Yes, it is visible. Yeah, it is fine.
Okay.
So over to judges, please.
Very good afternoon, judges. My name is Dr. Harshi Shah, and I'm a first-year resident at GMAS Medical College, Sola. I will be presenting my poster prepared under my guide teacher, Dr. Shilpa Gupta ma'am. The name of my poster is A Long Way to Conceiving, a case of tubal recanalization with subsequent ruptured ectopic, followed by intrauterine pregnancy. I'll start with the introduction. Surgical tubal recanalization is an effective fertility restoring procedure after tubal sterilization, but is associated with an increased risk of ectopic pregnancy due to altered tubal function. Early pregnancy surveillance is essential for timely diagnosis and management. Here we present a rare case of a ruptured ectopic pregnancy followed by tubal recanalization, followed by a successful intrauterine pregnancy, highlighting both the risks and favorable reproductive potential after the surgery. The case is of a 28-year-old third gravida with previous 2 uneventful full-term normal vaginal deliveries and a history of tubal ligation performed 1.5 years ago. The patient came to the gynecological OPD for surgical tubal recanalization and she was admitted for the same. The procedure was carried out successfully. After 5 months, the above mentioned patient presented to the emergency department with lower abdominal pain and altered sensorium, feeble pulse, and a blood pressure of 100 by 60 mmHg. After appropriate investigations, a timely diagnosis of ruptured ectopic was made. The patient was taken for emergency laparotomy with right salpingectomy in view of right cornual ruptured ectopic, as you can see in the photo. The patient was shifted to HDU on a ventilator and was extubated 24 hours later and later discharged 1 week later. The same patient came to obstetric OPD 6 months later and was diagnosed with live single intrauterine pregnancy of 8 weeks and went on to deliver a healthy term infant 7 months later. We managed the patient after taking a written and informed consent for emergency laparotomy. The patient was transfused with 4 PCV, 4 cryo, 4 FFP, 4 platelets post-surgery. The patient was intubated for 24 hours, after which she was discharged. The patient came to OPD at 8 weeks of pregnancy, 6 months later, and very close early pregnancy monitoring was done with serial beta HCG levels, ultrasound imaging, and regular ANC checkup. She went on to deliver a healthy term infant. Pregnancy after surgical tubal recanalization is associated with a higher risk of ectopic pregnancy, necessitating early pregnancy surveillance. A ruptured cornual ectopic pregnancy can present with hemodynamic instability and requires immediate surgical intervention to reduce maternal mortality and morbidity. Despite a ruptured ectopic pregnancy requiring cycloingectomy, fertility may be preserved, allowing subsequent spontaneous conception. This case demonstrates the successful term intrauterine pregnancy is possible even after ectopic pregnancy following tubal recanalization, emphasizing the importance of early ultrasound confirmation and close follow-up in all post-recanalization pregnancies.
What was the indication for recanalization?
Ma'am, the patient had a second marriage.
Okay. What are the advices that you give to the patient once you discharge her after a recanalization?
Ma'am, we do tell the patients to not we advise contraception for the next 3 months and ask them to come for regular follow-up to check the blood levels of the patient, and we tell the patient to not lift heavy weight or have any intercourse or have effective contraception for the next 3 to 6 months.
When the patient presented with the ectopic pregnancy, what was her gestational duration?
8 weeks.
So, when you discharge such a
Okay.
patient, your advice should be that she should come as soon as she has a missed
Yes.
feed, as early as
Yes.
possible.
Yes,
Okay, so
ma'am.
she should not land up in emergency.
Yes, ma'am.
So after a tubal recanalization, when would you usually the patient, the couple, they ask when should we try for pregnancy? So what would be your counseling and your advice after such surgery? When should they get try having pregnancy?
Sir, you're not audible. Can you repeat the question, please?
After a tubal surgery, tubal recanalization, when would you recommend to the couple to have pregnancy again? Try for the pregnancy.
So we would, okay, after discharging a patient post-surgery, we will usually advise the patient to try for pregnancy after 3 to 6 months in the next menstrual period, during the menstrual cycle.
Yes, usually they should skip 2 to 3 menstrual
Yes, menstrual
cycles, and
cycles.
after
Yeah.
that you can
After 3
ask them
menstrual
to
cycles,
try.
yes.
Yeah, yeah.
Yes, sir.
What are the chances of having an ectopic after a tubal surgery recanalization? Incidence?
So tubal recanalization surgery, post that, there is a 5 to 10% chance, but literature states a more specific 4 to 8% chance.
It's almost say 3 to 6%. That's the chance, not
Yes.
more than 10 ever.
Yeah, 5 to 10, 4 to 3.
Yeah. All right. No more questions.
Okay, thank you, Dr. Harshi. So
Thank you, sir.
we go to our last doctor of this session, Dr. Rutvi Ben Sah. And પૂર્વી બેન પછી તમને રિલીવ કરી દઈએ. સોરી, તમે 2 કલાકથી સ્ટેન્ડ
મને
સ્ટીલ
લાગે
છો.
છે કે હું વહેલી જોડાઈ ગઈ હે ને એટલા માટે
તમે એક સેશન વહેલા જોડાયા હતા, પણ that is fine. અમે સારું રહ્યું તમે હતા તો. So that is so nice of you. તમે ત્યાં કશું ખાધું નથી ને ભૂખ અમને લાગી ગઈ છે. Okay, so we go to the next doctor, Dr. Rutviben. Dr. Rutviben sir, are you available? Yes, she is.
Good afternoon, all teachers.
Over to judges.
Is my poster?
We are not able to say it. Try if you can, otherwise I will ask. Yes, yes.
Can
Wait
you
for a
see
minute.
my poster?
Not yet.
I'm not able to share it.
We'll try to help you. Wait for a minute. Wait.
Okay.
Dr. Rutviben.
Can you see it?
Yeah, it is processing. Yeah, it
Yeah.
is processing. You can start the slideshow. Okay, so it is
Okay.
getting bigger.
Um,
Yeah, it is processing. Wait a second. Yeah, it is visible.
okay.
You can start.
Uh, okay. Septic. Good afternoon, everyone. My poster topic is a rare case of septic abortion presenting with unexplained bradycardia. I am Dr. Rutvi Shah, and I am presenting this poster under guidance of Dr. Shilpa Gupta. Uh,
Dr. Rutvi,
in
wait. Your poster is not visible. Wait for a minute.
okay.
उनका आ नहीं रहा डॉक्टर रुचि का तब यहाँ से ओके
Uh, can you see?
Not yet,
Hello.
Dikra. Our technical person is helping. We are able to see it. You can go ahead now.
Okay. Good afternoon, everyone. My poster is on topic of rare case of septic abortion presenting with unexplained bradycardia. My guide is Dr. Shilpa Gupta. Introduction. Septic incomplete abortion is an important cause of maternal morbidity and mortality. It results from infection associated with retained products of conception and can rapidly progress to septic shock, multi-organ dysfunction, and death if prompt treatment is not instituted. The coexistence of profound anemia and bradycardia further compromises tissue oxygenation, worsens hemodynamic instability, and significantly increases the risk of adverse maternal outcomes. Early diagnosis, aggressive resuscitation, broad spectrum antibiotic therapy, blood and blood component transfusion, and timely uterine evacuation are the mainstays of management. I report a maternal near miss event of a 32-year-old woman with septic incomplete abortion complicated by retained products of conception, profound anemia, hemoglobin of 2.2 gram per dl, altered sensorium, recurrent bradycardia, and vasopressor requirement, who was successfully managed with multidisciplinary critical care and management. Case details: 32-year-old woman, sixth gravida, para 5 and live 4, a known case of epilepsy, was referred from CHC Dholka with complaints of fever for 4 to 5 days and was diagnosed as a case of incomplete abortion with sepsis and very severe anemia, profound bradycardia. On admission, she was poorly responsive to painful stimuli with a GCS score of E2, V4, M5. General examination revealed marked pallor, and first speculum examination showed active passage of blood clots. Initial investigations revealed hemoglobin of 2.2, WBC count of 28,000, platelet count of 4 lakh, PT was 15 seconds, APTT 23.2, and INR 1.02. Ultrasonography demonstrated retained products of conception measuring 4 into 3 centimeter, confirming incomplete abortion. Management. The patient was immediately resuscitated with intravenous fluids 80 ml per hour transfused with 2 units of packed red blood cells and started on a broad spectrum intravenous antibiotics in a step up manner. Following initial resuscitation, her sensorium improved and she became conscious and oriented. However, she developed multiple episodes of bradycardia requiring atropine administration and vasopressor, which is noradrenaline support. Repeat investigations on the following day showed hemoglobin of 6.4, total count of 30,000, and platelet count of 4.4 lakhs. Cardiac evaluation revealed a 2D echo with an ejection fraction of 55 to 60%, no regional wall motion abnormalities, and negative troponin I, excluding a primary cause for bradycardia. MRI brain and EEG was normal, ruling out CNS as a cause for bradycardia. The patient received an additional 1 unit of packed RBCs and 2 units of FFP. After achieving hemodynamic stabilization, dilatation and evacuation was done successfully on 18th March to remove the retained products of conception. The post-operative period was uneventful. Noradrenaline was gradually tapered and discontinued as the patient remained hemodynamically stable. Discussion and conclusion. Septic incomplete abortion is a life-threatening obstetric emergency that can rapidly progress to septic shock, especially when associated with retained products of conception and profound anemia. This patient presented with severe sepsis, altered sensorium, and extremely low hemoglobin, making it a maternal near miss case. Early resuscitation with IV fluids, broad spectrum antibiotics, blood transfusions, vasopressor support, and timely evacuation and dilatation resulted in a favorable outcome. This case highlights that septic incomplete abortion with profound anemia may present with unusual manifestations such as recurrent bradycardia in addition to sepsis and hemodynamic instability. Early recognition, aggressive resuscitation, broad spectrum antibiotics, blood transfusions, and timely uterine evacuation and multidisciplinary critical care resulted in a successful maternal outcome despite this life threatening presentation. Thank you.
Dr. Rutvi, one thing that I found in your case details that was missing is some details of her abortion. When did she has her abortion? What was the like? It was by pills or by any surgical intervention? And when did
Uh,
she started having fever? Those details are not there.
Oh, sorry, sir. She actually took some MTP pills from a private hospital, and after that she went back there. That she has this complaint of some blood clots passing, and but they were like they referred her to CHC, and CHC referred her to our hospital.
Right. So whether that because once it's a septic abortion, you must inquire whether that was legal or illegal.
Sir, it was legal. She went to a private hospital, and then
By
she went
private
to
hospital,
CHC.
you mean a gynecologist or a BAMS,
No,
BHMS over the counter drug?
Mhm.
no, sir, ma'am, gynecologist.
Less likely a gynecologist not doing a sonography and sending you. Anyway, findings for abdomen. Was there any guarding rigidity, any signs of sepsis?
Uh, no, ma'am. There were no guiding rigidity.
Okay, and what about what care you will take when you are doing a curettage in such a case with sepsis and severe anemia?
Um,
When you are performing dilatation and evacuation, what
patient,
care you will take? What
uh,
precautions you will take?
patient. First, we have to, matlab uh, hemodynamic stability. First, we have to achieve. After that, we will uh, give antibiotics, and then we will do dilatation and evacuation. And at the time of procedure, we have to, as in this case, the patient had repeated episodes of bradycardia. So we checked that she doesn't have bradycardia at the time of dilatation and evacuation.
Any other
Are there
care?
any surgical complications that can arise during the procedure? That's what madam is asking. Because she is having sepsis. You are
So
evacuating.
what madam is asking, had it been this patient is hemodynamically stable, right? So did you do means surgical evacuation immediately means after 12 hours or 24 hours, or you could have waited for 2 days or 3 days or more?
We actually waited for 2 to 3 days more after
Why?
giving
Why?
all
The reason
the
was why did you wait? Had it been अगर ये normal हो मतलब hemoDynamically patient stable होता तो भी आप वेट करते कि इमीडिएटली कर देते नेक्स्ट डे?
नहीं तो वेट नहीं करते.
ओके और सेप्टिक अबॉर्शन में जनरली कॉम्प्लिकेशन होता है चांसेस ऑफ परफोरेशन, तो उसको प्रिवेंट करने के लिए आप क्या कर सकते हैं? यूट्रस इज सॉफ्ट, ऑलरेडी देयर इज इन्फेक्शन.
So
You should start an oxytocin drip. This is just I'm asking a question. ये आपने किया ही होगा, but you should start and 20 minutes oxytocin and
Okay,
You
ma'am.
will not use a curette, you will use MVA syringe,
Okay, ma'am.
right?
Okay.
Yeah. Thank you.
Thank
Thank you,
you.
ma'am.
I think sessions for this hall is completed now.
Okay.
There are no more cases, I
Hello, good
think so.
afternoon, everyone. I'm Dr. Sanful Mehta.
Yes.
And on behalf of SOGOG, I would like to thank all the judges of the session, Dr. Purvi Ben Patel, Dr. Rohit Jain sir, and Dr. Rajni Parikh ma'am, to nicely conduct the session. And we conclude the session. And I also like to thank all the participants for making this session very nice. We had a very good interactive session. Thank you very much, judges, for
Thank
joining.
you. Thank you.
Thank you. Thank you.
So we go into the next session. And the judges for the next session are Dr. Sangeeta Pandey ma'am, who is the professor at Karamsad Hospital, and another Dr. Mona Gandhi ma'am. Welcome, Dr. Mona Gandhi ma'am and Dr. Sangeeta ma'am. Am I audible to you?
Yes.
Good afternoon,
Yes.
madam.
Good afternoon.
Dr. Sangeeta ma'am, are you there? Sangeeta ma'am, you can unmute yourself. We have made you the co-host of the session. Somika Devi, Dr. Somika Devi is the presenter. Dr. Somika, are you there? Dr. Somika, we have made you the co-host. You can unmute yourself and you can share your screen to proceed further. Okay, we welcome Dr. Sangeeta ma'am. Good afternoon, ma'am. Okay, so we have the judges with us, Dr. Sangeeta ma'am and Dr. Mona Gandhi ma'am. And I'll ask the presenter, Dr. Somika. Dr. Somika, can you hear us? Okay, if Dr. Somika is not there, can we go to the another student, Dr. Ashwini.
Okay.
Dr. Siddhi. Dr. Siddhi, are you there? Disha, Disha Patel. Dr. Siddhi, Dr. Disha Patel. Yes, Dr. Disha is there. Dr. Disha, please unmute yourself. We have made you the co-host. And you can share your screen also. Dr. Disha, can you hear us? We can
Yes,
see
yes,
you.
yes.
Okay, you can share your screen, please.
Okay.
Judges, I hope you have got the Google sheet for the marking system.
Yes, yes, we have. We have
Okay,
received.
so yes, ma'am. So there will be 6 minutes of time, and the timer will start on the right hand of the corner. Once Dr.
Okay.
Disha is ready with her presentation, we'll let you know.
Okay. It's not allowing me to.
You can just see that on the bottom section there will be share screen button available.
Yes. Okay, okay. I've got it.
Yes,
Okay.
right.
Uh,
Yes, we can see your presentation.
okay.
Judges, can we start her presentation?
Yes, yes.
Yes, Dr.
Okay.
Disha, your time starts now.
Okay. Myself, Dr. Disha Patel, first year resident doctor at Baroda Medical College. I am sharing the case of unusual presentation of genital tuberculosis under guidance of Dr. Garima Gandhi, an AP assistant professor at Baroda Medical College, and Dr. Pooja, third year resident case. I am presenting a very unusual presentation of genital tuberculosis. A patient of 42-year-old woman presented to the OPD with a complaint of heavy menstrual bleeding. She has having this complaint of heavy menstrual bleeding since 2 years. Uh, Patient has no other complaints like intermenstrual bleeding, abdominal distension, or any thyroid disorder, weight gain or weight loss, nothing. Patient has no, even not a history of any contact with uh, tuberculosis patient, or patient is no having no fever, no chills, tigers, nothing. Her menstrual history was she has menarche at 13 year menstrual history. She has a regular moderate 4 to 5 days she is having her periods, 28 weeks 28 days of cycle. Patient has obstetric history. She is para 2 live 2 birth of vaginal deliveries, and both are live children. Her past history is she is having also a mild abdominal pain while menstruation. Initially it was not responding later on. Her personal history was she is a vegetarian. Appetite was good and sleep was also adequate. Patient has a regular bowel and bladder habit. No non-smoker, non-alcoholic, or no drug addiction. Her general examination where appearance was well built, a weight of 70 kgs, height was 150 centimeter, BMI of 31.1 kgs. She was not paler, no icterus present, no absent of cyanosis and edema, no lymphadenopathy were found. Her vitals, she was vitally stable, SpO2 of 98% on room air. Temperature was also, she was afebrile. Her blood pressure was 100 by 70 mmHg, respiratory rate of 16 per minute. Systemic examination also found to be normal. Her CVS S1, S2 sounds were present, no murmur were heard. Respiratory system was also fine. Bilateral air entry was present. Both lungs were clear. Abdominal examination shows normal, no dilatation of the veins, or all quadrants moves equally with respiration. And mild obesity was found to be there. Palpation, no local rise of temperature, no hepatosplenomegaly, no lymph nodes were palpable, no free fluid clinically. palpable. Then local examination, external genital appearing normal. For specular examination, cervix appearance healthy, and multiparous os was there. Bleeding through os was present. No discharge, no abdominal lesions were there. Bimanual pelvic examination shows uterus was symmetrically and weeks of pregnancy, 10 weeks size of uterus, globular and mobile. Transmitted mobility was present. Mild uterine tenderness was there. No adnexal mass felt. Bilateral fornix were free with no tenderness at present. USG was found to be 9.8 into 4.4 centimeter. Adenomyosis was also present in the patient. Bilateral ovaries were not visualized. Endometrial thickness was 4 mm. Bilateral ovaries were normal. Patient was offered medical management initially and hormonal management. However, due to the previous failed medical management, she opted for abdominal hysterectomy. And patient was admitted in gynec department. Her investigation shown normal blood investigations. She was having a hemoglobin of 11.7 gram. Total count were 5,700. Platelet were 2,31,000. Other liver and renal function tests were also normal. Then pre-op finding, when patient was planned for OT on table, 200 to 300 of serous ascitic fluid was strained and sent for the cytology. Small multiple white tubercles were present over entire peritoneum, omentum, uterus, uterovesical fold, and serous of bowel and mesentery. Bilateral fallopian tubes were found to be lead pipe consistency and classic beaded appearance. Bilateral ovaries were normal. Uterus was 10 week size and regular surfaces with white tubercles over the anterior and the posterior surface. Uterus was exterior out and held with the straight clamp also. Then specimen was okay. On cut section, thickened myometrium with ill-defined areas where adenomyosis was there and endometrial cavity was normal. Then on HP report, it was found to be the section of histology was thickened tubal wall were there with well-defined granuloma formation consisting of epithelioid histiocytes and multinucleated Langerhans cells were there. And after the OT patient was, yes, after this OT, there was a high chance of fistula. Even the chance of fistula was very high if when she was found to be tuberculosis over there. We inserted a drain. We put a drain which was removed on 10th day after the OT when drainage fluid was 25 ml consecutively for 2 days. After 10 days, drain was removed and then patient was
Dr. Disha, your time is up. So, beta, I'll ask you to just conclude your presentation.
okay. I will conclude my is genital tuberculosis should be considered in a woman presenting with the chronic pelvic symptoms, abnormal uterine bleeding, infertility or unexplained pelvic adhesions, particularly in tuberculosis endemic region. Early recognition and timely intervention of antibiotic tubercular therapy are essential to reduce morbidity in a reproductive age group of women. Thank you.
Okay. What was your post-operative management in this patient?
Post-operatively, ma'am, when we started anti-tubercular drugs to her, which was our four main drugs which we give in a patient. We started on rifampicin, ethambutol, isoniazid, and pyrazinamide.
So histopathology was saying that adenomyosis was there and tuberculosis. Both histopath was suggestive of both adenomyosis and tuberculosis. You mean to say that
Adenomyosis was also there, and the granuloma formation was also found.
And
Sorry?
ascitic fluid cytology? You have
Ma'am,
tried the 200 cc of ascitic fluid for operatively.
yes, ma'am.
So what was the cytology of
Uh,
ascitic fluid?
Ma'am, ascitic fluid found to of acid fast bacilli was there.
Okay. So suppose if you have done pre-operatively DNC, is it possible to diagnose genital tuberculosis by DNC?
Uh, but ma'am, the endometrial thickness was about 4 mm only. So,
So my question is it possible to diagnose genital endometrial tuberculosis by DNC? Yes or no?
mm, no, ma'am. In
Okay. Okay.
Okay, judges. So can we go
Yeah.
ahead for the another presentation?
Yes.
Thank you, Dr. Disha.
Okay,
So now
thank you.
I would request Dr. Somika to unmute yourself and share your screen. Okay, I think Dr. Somika has just left. Ashwini, no, Dr. Ashwini, are you there? Dr. Siddhi is there. Dr. Siddhi?
Yes, sir. Good afternoon.
Yes, please. Unmute yourself, share your screen, and we'll go ahead with your presentation.
1 second.
Judges, I think Dr. Somika and Dr. Ashwini has somehow left out. So
Okay.
we are going ahead with Dr. Siddhi's presentation, then we'll accommodate Dr. Somika and Dr. Ashwini later on.
Yes, sir. No problem.
Wait a minute, sir.
Yes,
I'm unable to share the screen.
Yes. Ashwini has come. Yes, Dr. Siddhi.
Yes, sir. Hello.
Yes.
My slide is visible, sir.
No, Dr. Siddhi, your slide is not visible.
I'm unable to do, sir. Can you please help me out?
Okay.
You go
Can you
ahead.
share your poster to my WhatsApp, please?
Yes, sir.
It is visible.
Is it visible?
It is visible at present.
Yeah, it is visible.
Yeah,
Okay.
yeah. Not required.
Okay.
You
Okay,
can
Shall I
go ahead.
start, sir?
Go ahead. Yeah, yeah. You can start.
Okay,
Okay.
Dr. Siddhi. Judges, you are able to see the Dr. Siddhi
Yes,
screen?
yes, very well. Very well.
It's now, it's available. Okay, Dr. Siddhi, your time starts
Okay,
now.
sir.
Go ahead.
Good afternoon, everyone. Myself, Dr. Siddhi Kansara, second year resident doctor in working in the Department of Obstetric and Gynecology at Government Medical College, Bhavnagar. I'm here presenting a poster named Hyperreaction Luteinalis Mimicking an Ovarian Ectopic Pregnancy, a case report under the guidance of the Dr. Kanakta Nakum ma'am, my PG guide and my mentor. Uh, I'm starting the introduction part of my poster. Hyperreaction luteinalis is a benign condition characterized by the marked, often bilateral multicystic ovarian enlargement due to exaggerated physiological response to human chorionic gonadotropin hormone. Although most frequently encountered in the gestational trophoblastic disease or multiple gestation, its occurrence in the ectopic pregnancy is exceptionally rare because hyperreaction luteinalis can macrosomically mimic ovarian malignancy or pregnancy, avoiding aggressive, unnecessary surgical resection. My objective of this poster is to present a rare case of the hyperreactive luteinalis that mimic a ruptured ectopic pregnancy and to emphasize the importance of the conservative surgical management. Uh, my clinical profile of a patient is my patient is 35-year-old female, para 1 Liban, abortion 3, presented with the 2-day history of the acute lower abdominal pain accompanied by the hemodynamic instability. Uh, on a lab investigation, beta SAG was the 141.7 milliliter international per ml. On the ultrasound, on a pelvic ultrasonography, reveals the complex left adnexal mass with a significant hemoperitoneum, raising suspicion for the ruptured ectopic pregnancy. Emergency exploratory laparotomy was done, and on intra-op finding, left ovary was enlarged, edematous, and the multicystic with an rent on the upper pole of the left ovary was present, from where active bleeding was present, and the conservative partial left oophorectomy was performed, successfully preserving the surrounding healthy tissue. On discussion part, hyperreaction luteinalis is a rare benign ovarian changes due to excessive beta HCG stimulation, exceedingly rare in the ectopic pregnancy. It macroscopically appearance can mimic the ovarian malignancy or a ruptured ovarian ectopic pregnancy, uh, potentially leading to the unnecessary complete oophorectomy. Intraoperative findings should raise the hyperreaction luteinalis consideration, but definitive diagnosis rests on the pathology examination, extensive theca granulosa cell luteinization, and stromal edema. On concluding myself, the rare in ectopic pregnancy, hyperreaction luteinalis must be considered in the differential diagnosis of a complex cystic adnexal mass in reproductive is one because limiting benign process that spontaneously resolve following the clearance of the beta SAG. Conservative management aimed at the fertility preservation is the paramount. Early intraoperative recognition and the precise histopathological correlation are essential to prevent the unnecessary oophorectomy and avoid diagnostic pitfalls. My key learning from the poster are every bilateral complex adnexal mass is a reproductive age movement is not an ovarian neoplasma or pregnancy related changes must be considerable. Hyperreaction luteinalis is a rare but important diagnostic mimic of the ovarian malignancy that can occur in an ectopic pregnancy. Ovarian preservation should be the goal of young woman when malignancy is not confirmed intraoperatively. The final diagnosis is sometimes made not by imaging but by the surgeon's vigilance and the pathologist's confirmations. Thank you.
Okay.
Yes, ma'am.
Hello? Your presentation is
Yes, ma'am.
over?
Yes, ma'am.
Okay. So how have you diagnosed perioperatively? Is it it is hyperprolactinemia, is not ectopic?
Ma'am, on
Am I audible?
yes, ma'am. Absolutely.
Okay.
Ma'am, on intraoperative finding, there is suspicion of the ruptured ectopic ovarian pregnancy. Then we send the sample on the histopathology laboratory. Then the confirmatory diagnosis made by histopath laboratory only.
Okay. So perioperatively you are not knowing, no?
Sorry, ma'am. Per abdominal.
You were aware about the hyperprolactinemia during perioperatively? Hello.
Yes, ma'am.
Postoperative, you come to know, no? That this is not ectopic, it is hyperprolactinemia.
Yeah, yes, ma'am. Only on
Okay.
postoperatively.
Okay. What is theca lutein cyst?
Yes, ma'am. Theca lutein cyst is, ma'am, when the normal in a, I mean, is a benign cyst in the ovary.
Hmm. So, why, doctor? Under the influence of which hormone? And how will you manage the
It's a self-limiting, and we can top up.
hello?
You-
I'm not able to hear you.
Theca lutein cyst is a benign cyst in pregnancy. That is mostly it can resolve by its own.
Mm.
Or we can add analgesic and antibiotic.
Yes. Okay. We are coming across in H-mole pregnancy. Okay. After evacuation of H-mole post-operatively, fecal urinary is accidental findings sometimes.
Okay, ma'am.
Mm.
Okay.
Okay. Any question from other?
Okay.
Thank you, ma'am. Yes, ma'am.
Dr. Siddhi,
Thank you, sir.
thank you very
Thank you,
much.
sir.
Judges, we would like to welcome Dr. Padsha, sir. He has just joined in the session. He was a bit busy. Okay, Dr. Padsha, you have to invite Dr. Subha today.
So our next presenter is Somika Devi. Somika, are you there?
Good afternoon, sir. Yes, sir.
Yes. You can share.
Yes, sir. I'm trying.
So, madam, we are thankful. Dr. Sangeeta, madam, and Dr. Mona, madam, we are really thankful on behalf of Sogok that you have spared your time and you are sharing your experience as a judge and you are evaluating all the paper and posters.
Yes. Thank you, sir.
Sir, is my screen visible?
Yes, visible can, yeah.
Okay.
Yeah. So you are sharing, are you sharing from your mobile?
Yes, sir.
I was sharing, okay. So Mona madam, is it
Not,
visible to you, madam?
not properly visible.
Uh, can you rotate your phone?
Oh. Yes, sir.
Somika, try
Yes,
to
sir.
rotate your phone. Perhaps it will show better. Rotate your
Yes.
phone. नहीं, आपने ना करना।
The cursor beside that.
Just mobile rotation. So if you keep it transverse, perhaps the fonts will be much bigger.
So it's not happening. I'm sorry.
It's okay. Yeah, if
It's
possible, little bit zoom little bit.
Go
Yeah,
ahead.
yeah. Go ahead.
Yes, it is visible now.
Good afternoon to every teacher here. My name is Somika Devi. I'm junior resident, second year, Obs Gynae department in Santosh Medical College. Uh, I'm presenting a poster presentation of torsion of para-ovarian cyst and secondary torsion of fallopian tube, a rare acute abdomen case. Introduction: para-ovarian cyst account for approximately 10% of adnexal masses, and para-ovarian cysts arise from the tissues of the broad ligament, predominantly from mesothelium covering the peritoneum, but also from paramesonephric and rarely mesonephric remnants. Most of the time, they remain small and asymptomatic, but sometimes they grow large in size and can undergo complications like infection, hemorrhage, and torsion cause acute pain. For diagnostic purposes, ultrasound can help in detecting adnexal masses and ovarian cyst accidents such as hemorrhage, but the mere presence of blood flow on Doppler ultrasound of the ovaries does not completely rule out ovarian torsion. My case is about a 17-year-old unmarried female came to casualty with complaint of sudden pain in lower abdomen, more in right lower quadrant since 2 days. There was history of intermittent fever, burning micturition, and constipation since 5 days. Her menstrual history was normal with regular cycle. Her menstrual cycle was a week before presentation. She gave history of cyst diagnosed by ultrasound about 2 months back, and she visited some another private emergency department with similar complaints of lower abdominal pain. Got admitted there and had some pain relief medications. On general examination, patient was vitally stable. Per abdominal examination, tenderness on deep palpation in hypogastric region. No rebound tenderness was seen. No guarding or rigidity was seen. Gut sounds were audible. On admission, UPT was negative. Routine blood tests were within normal limits. She was symptomatically treated with analgesics and antacids and antiemetics. Ultrasound was done next day in view of persistent mild tenderness, which showed uterus is anteverted, normal in size, shape, and position. ET was 3.9 mm. Right ovary appeared enlarged in size, about 8 into 4 centimeter, with large cyst measuring 4.8 into 3.7 centimeter, impacted in pouch of Douglas with free fluid in pouch of Douglas, having internal ecogenic debris with and peripheral plays small ovarian lesions. So, partial ovarian torsion with hemorrhage uh, slash infection in polycystic ovarian disease. This was suspected. Vascularity is relatively well preserved in periphery and in broad ligament. Intra finding was torsion of tube, two loops with cyst noted. On detorsion, it was noted that the cystic structure with was right para-ovarian cyst of around 8 into 5 centimeter size with secondary torsion of right fallopian tube, which was gangrenous. Uterus, bilateral ovaries, and fallopian tube was completely normal. Hello, sir.
Hello.
The conclusion was with wide range of differential diagnosis for pelvic pain and non-specific clinical presentation, it is often becomes a diagnostic challenge to diagnose these conditions before surgery. And early diagnosis and early intervention can maximize the tubal salvage and can even prevent complications like necrosis, gangrene, rupture of fallopian tube. Laparoscopy is the gold standard in diagnosing and managing paraovarian cysts and their associated complications.
Hello.
हाँ जी मैम. Yes, ma'am.
Your presentation is over? Okay.
Yes, ma'am.
Okay. Peroperative finding?
Sir, ma'am?
Peroperative finding?
Ma'am, peroperative finding was torsion of tube, two loops with cyst was noted, and the right tube, which after detorsion it was gangrenous. So tubectomy was also self-injectomy was done.
Self-injectomy. Okay.
Yes, ma'am. With cystectomy with self-injectomy was performed.
So you will apply clamp after untwisting or as it is? You will apply clamp in Y.
I'm sorry, ma'am. I didn't get your question. Sorry.
If you want to remove this whole mass, you have to apply this clamp, okay?
Yes,
So
ma'am.
you will apply clamp after untwisting this mass, or you will apply mass of clamp as it is twisted.
No, ma'am.
Understand?
Yes, ma'am. After detorsion, first we do detorsion, and
then you will apply
then we'll
the
see the
clamp.
condition of fallopian tube. If it is if it can't be saved, then
If okay. So we will do detorsion and then you will apply clamp. In your
yes,
case, it is gangrenous. No? Mass is gangrenous.
yes, ma'am.
Okay. Okay, no more question from my side.
Sangeeta madam, question from your side. Sangeeta madam. Okay, not audible. Ma'am, try to unmute. Yes. Ma'am, now am I visible? I'm audible and
Yes, you are audible.
yes. Madam, any questions from your side?
No, not required.
Okay. So
Next,
shall we proceed for the next?
next one, yeah.
Somika, thank you very much.
Thank
It
you,
was
sir.
nice. Yeah.
Thank you, sir.
So next presenter, Ashwini Kulat, Dr. Ashwini Kulat. Ashwini, we are sharing your slide from our side. Ashwini, can you see it? Dr. Ashwini? Post કર્યું છે? Yes. Dr. Ashwini, try to unmute.
Yes, sir.
Yeah. Okay. Can you the slides are all visible to you, right?
Yes, sir.
Yeah. So you can start.
Sir, my slide is not visible.
Oh, we have shared. We are sharing again.
Yes.
Is it visible now?
Yes, sir. Good afternoon, sir and ma'am. Myself, Dr. Ashwini. I'm junior resident from Department of OBGY, Dr. Vasantrao Pawar Medical College and Hospital, Nashik, Maharashtra. This is my poster presentation. The highlight is the silent scar, uterine scar dehiscence following vaginal birth after cesarean, a diagnostic challenge. Introduction is as TOLAC, a trial of labor after cesarean enables vaginal birth in an appropriately selected woman after cesarean delivery. The scar dehiscence is incomplete separation of previous uterine scar with intact serosa. It may remain clinically occult even after apparent successful VBAC. Background scar dehiscence differ from complete uterine rupture because the serosal layer remain intact. Clinical presentation may be subtle, persistent lower abdominal pain, unexplained tachycardia, fall in hemoglobin, minimal or absent vaginal bleeding. A successful VBAC may create false reassurance. Persistent unexplained symptoms should trigger reassessment and targeted imaging. Why this case matters? A diagnostic trap. Successful vaginal delivery does not exclude scar pathology. Clinical message, early suspicious plus timely imaging plus appropriate intervention may prevent severe maternal morbidity. Slide second, please. Next slide, please. Next slide. Yes. No, sir. Previous. Yes. My case presentation is a 27-year-old gravida to Paravan living one at 38 plus 5 weeks with one previous LSCS 6 years earlier for fetal distress. Now she is a singleton cephalic pregnancy, counseled for a trial of labor after cesarean, spontaneous labor, low dose oxytocin augmentation was done, reassurance during postpartum, reassurance for intrapartum monitoring was given, vaginal delivery of 3.1 kg live male baby. Initially stable postpartum. At 2.5 hours after postpartum, the patient was complaining of abdominal pain. Her pulse rate was 110 by 110. per minute, relative hemodynamic stability, no significant vaginal bleeding. Patient was admitted at around 8 a.m. when she was in active labor around 5 centimeter dilated. Labor was progressed. She was fully dilated around 12. And after her postpartum, after 2.5 hours, there was persistent tachycardia and persistent lower abdominal pain disproportionate to the postpartum period. We did her USG, and USG was suggestive of scar defect, but was not 100% sure. There was some USG signs. So we decided to explore and confirm. After exploration, we found that there was a dehiscence. Investigation was performed. Her HB was 9.6, WBC count were 12,000. USG was showing anterior roll uterine segment thinning with suspected defect, bulging and minimal free fluid. Persistent symptoms despite relative hemodynamic stability. Why was it silent? No dramatic hemodynamic collapse, no major external bleeding. Vaginal birth had been successful. Symptoms could mimic routine postpartum discomfort. Key clue, persistent unexplained pain with tachycardia. Next slide, please. Operative findings and management. Exploration demonstrated thin lower uterine segment. There was a myometrial defect, intact serosal layer, no active major bleeding. Diagnosis was uterine scar dehiscence, defect repaired in 2 layers. Recovery was uneventful. Discharge stable. Patient was discharged as she was stable on post-op day 4. Key learning points are dehiscence may occur despite apparent successful VBAC. Persistent postpartum pain or unexplained tachycardia warrants reassessment. Absence of major bleeding or shock does not exclude scar pathology. Ultrasound is a useful first-line investigation. Timely diagnosis and may prevent progression and severe hemorrhage. Future pregnancy requires individualized counseling and delivery planning. Conclusion: uterine scar dehiscence can be clinically silent after vaginal birth after section, and apparent successful vaginal delivery should not lower suspicious when postpartum symptoms persist. Recognition of subtle warning signs, timely imaging, and appropriate intervention are central to maternal safety. Thank you. Now, take-home message is a successful VBAC does not always mean an intact scar.
So, what are the criteria to select the patient for VBAC?
Now, the criteria for selection of VBAC are there. Good afternoon, ma'am. The criteria for selection of VBAC are as there should be a previous lower segment cesarean section. There should not be a classical incision. There should be a singleton pregnancy. The interconceptional period should be at least more than 2.5 years. There should be a presentation should be of vertex, and baby weight should not be more than 4 kgs.
More than 4 kg. 3.5 kg. We can go for VBAC.
Mostly we don't go, ma'am, but according to the guidelines, it says 4 kg.
Yeah. Any previous cesarean section indication matter for selection of patient?
Yes, ma'am. That should be indication as there is non-recurrent indication. If there is a if the some section has been performed for like fetal distress or things, then we can proceed. But if there is CPD or etc., then we should not proceed for cesarean section.
VBAC, not for okay. How will you manage a very small scar dehiscence?
I will go for XLAP and yes, ma'am.
1 to 1.5 centimeter scar dehiscence is there.
Yes,
You are
ma'am.
knowing.
I will wait and observe if patient is hemodynamically stable. I won't do anything. I will just observe. But if I found that my patient is deteriorating, then I will go for XLAP and I will repair the defect.
But if you are going for conservative management, what will you do?
I will monitor her vitals, but mostly, ma'am, I won't take risk and I will go for XLAP.
No, conservative management is there. Okay, so one is vital monitoring. Any other thing?
Vitals and
You are
ma'am,
worried
I will see for falling trend of HB whether there is a.
Yeah. So,
I will
anything
do her
else? You are
CBC
worried
monitoring
for-
and I will see whether there is intrapartum means if there is any blood loss. If there is a decreasing trend of HB. I will
So
see
one
on
that
USG. I will
vitals
look
are
if the defect is increasing or whether it is as it is. I
If
will go for imaging modalities.
If patient is vitally stable, it is rule out that hemodynamically stable, then hemorrhage is not there. Okay.
Yes, ma'am.
But what other things you are worried for? We are worried for infection, no? So what you will
Yes,
do?
ma'am. Yes, ma'am. Endometriosis and
Not
endometritis, sorry.
Uh, so, so conservative with the help of higher antibiotics.
Yes, ma'am.
Okay. Okay. Okay.
Mona madam?
Yes, from my side it's over.
Okay. Shall we proceed for the next candidate, madam?
Yes, yes.
Okay.
Sure.
So thank you, Ashwini. We are happy that you are sharing from Nasik. So
Yes, sir. From Nashik,
we have
Maharashtra.
participation. Yeah, we have participation from many of the nearby state also. Yes.
Yes,
Yeah.
ma'am.
Disha Patel. Right. So next presenter, Disha Patel.
Disha Patel, we have already taken, no?
Yeah. Okay.
Yeah.
Then
Now
yeah.
is the
Dharmi Joshi.
Dharmi Joshi, yeah.
Yes, sir.
Okay. Dharmi, will you share? Or
Yes,
you
sir.
need
Yes, sir.
help from our side? Yeah. આપણે silent થઈ જઈએ.
Sir, I'm not able to share my screen. Hello.
Have you sent your
Yes, sir. Yes, sir. I
presentation
have
to
sent.
us?
Yes, sir.
Just give me 2 minutes. आपके पास आयुष है presentation? हमने पास ऐसे कुछ नहीं. हाँ. Hello. So Dharmi, is it possible that you wait for 10 minutes? Meanwhile, we are shifting to the another candidate, and you
Yes, sir.
send me to poster to me. Is it possible?
Yes, sir. Yes, sir.
So we are moving to next candidate, Manju Shah Salam. Dr. Manju Shah. Dr. Manju Shah. Yeah. Can you share your presentation?
Yes, sir.
Yeah, please share. So, judges, we are going with Dr. Manju Shah, and we are coming back to Dharmi Joshi once we are
Okay.
ready with the presentation on our laptop.
Okay.
Sign करें.
Okay. Thank you.
Yes, Manjusha, it is visible. You can proceed.
Okay, sir. Good evening, everybody. My name is Dr. Manjusha Salam, first year resident, Government Medical College, Bhavnagar. My guide, Dr. Mayur Gandhi sir and Dr. Naisha ma'am. I am going to present my case, mucinous cystadenoma, poster on mucinous cystadenoma. Introduction. Ovarian tumors are among the most common gynecological neoplasms encountered in clinical practice, ranging from simple functional cysts to complex epithelial tumors. Mucinous cystadenomas are benign epithelial ovarian tumors arising from surface epithelium, typically unilateral, multiloculated, and cystic in nature. Mucinous cystadenoma account for 10 to 15% of all ovarian tumors, representing approximately 80% of all primary mucinous ovarian neoplasm and 20 to 25% of all benign ovarian tumors. They are notable for their capacity to attain an enormous size, at times mimicking massive ascites, a gravid uterus, or an advanced abdominal malignancy on clinical examination. Distinguishing a benign mucinous tumor from its borderline or malignant counterpart is clinically important, giving the overlapping presentation and differing implications for management. Aim and objective: to present a case of large left ovarian mucinous cystadenoma in a multiparous woman, highlighting its clinical presentation, diagnostic workup, and role of tumor markers and imaging in differentiating it from a malignant or serous ovarian tumor. Objective: to describe the clinical presentation and examination finding of large adnexal mass in a woman with previous caesarean sections, to review the role of tumor markers CA125 carcinoembryonic antigen, CA199 alpha fetoprotein beta HCG in the preoperative evaluation of an adnexal mass, to correlate USG and CECT imaging findings in localizing and characterizing the lesion, to emphasize timely and accurate diagnosis for appropriate surgical planning and counseling. Background. Disease profile: ovarian cystadenomas are most common benign ovarian neoplasm. They are usually unilateral and multiloculated and can grow to massive size, among the largest tumors reported in humans. Early lesions are often asymptomatic. Symptoms such as abdominal distension, pain, and pressure effects emerge as the mass enlarges. Markers and imaging. CA125 is usually normal or only mildly raised in mucinous tumors, unlike in serous or epithelial ovarian malignancy, where it is more often elevated. Carcinoembryonic antigen and CA199 are more frequently elevated in mucinous tumors and support the mucinous subtype when interpreted alongside CA125. USG and CECT are essential for characterizing a multiloculated cystic mass with septation and for surgical planning. Histopathological confirmation after excision remains essential, giving the risk of borderline or malignant transformation. Case summary. Patient and history: a 45 years old female, para 3 life 3, previous caesarean section. Complained of lower abdominal pain and distension since 6 months. Per abdominal examination, scar of CS present, scar of tubal ligation present, abdomen uniformly distended up to epigastrium. On per vaginal examination, lower border of mass felt, fullness in all fornices. Imaging: USG 20 into 12 centimeter cystic pelvic lesions with internal septations and echoes extending to the epigastrium, suggestive of mucinous cystadenoma. Pap smear reports were negative. CECT thorax and abdomen, large 18 into 20 into 45 centimeter, well-defined multiloculated cystic abdominopelvic mass, likely left adnexal ovarian with thin enhancing septations and mass effect compressing bowel loops, uterus and urinary bladder. Tumor markers. CA125 was within normal limit, alpha fetoprotein normal, carcinoembryonic antigen was markedly elevated, CA199 was within normal limit. Normal CA125 with markedly elevated carcinoembryonic antigen, a marker pattern that favors a mucinous over a serous ovarian tumor. Plan of management was primary staging laparotomy was done with frozen section, left adnexal mass 15 into 30 centimeter mass removed. Frozen section showed benign mucinous cystadenoma. Histopathological reports where shows multiloculated cystic lining by a single layer of columnar mucinous epithelium. No malignant features seen. Conclusion. Large mucinous cystadenomas, though benign, can mimic malignant or advanced abdominal pathology purely because of their size and mass effect, as seen in this patient, whose distension extended up to the epigastrium. Correlating tumor marker profile with imaging findings aids in preoperatively differentiating a benign mucinous tumor from a malignant mucinous tumor or pseudomyxoma peritonei. Complete surgical excision with histopathological confirmation remains the definitive step to rule out borderline or malignant change, regardless of reassuring marker and imaging profile. The high index of suspicion and multidisciplinary approach are essential when managing large adnexal masses, particularly in women with surgically altered abdomen from previous cesarean sections. Thank you, sir.
Yes.
Mona madam and Sangeeta madam.
Yes. Your per abdomen finding is up to mass is up to epigastrium.
Epigastrium.
Okay. Epigastrium. Okay. It's over. Anything you want to add?
No, no.
When when, when you are examining any mass, per
Yes,
abdomen and per vaginal group, okay, what things you will have to see? From that, by clinical aspect, we can come to know whether it is benign or malignant. What are these things that you have to see clinically? One is size, okay, size of the mass. Anything else? Am I audible? Hello.
Dr.
Hello.
Manjusha, switch off your video because there is some lag in your internet. Okay. Due to some reason, she has been logged out. She will again do it. Yeah, she is back. Manjusha, Dr. Manjusha. Yes. Turn on your mic.
Question.
Yes, sir.
Huh. What other than size, what other things you will see when you are examining any mass?
Ma'am, mobility.
Yes. Mobility.
Mobility of the mass.
Then,
Consistency.
yes. So which consistency favors benign and which for malignant?
For malignant, it is firm.
Yes. And for benign?
Benign mass will be mostly soft and mobile, and malignant will be adhered, firm consistency.
One thing you have said, this is consistency. Other thing, size. And then any other thing? Mobility. Then
Mobility.
shape will
Yes,
be
ma'am.
shape, border.
Shape. Yes, ma'am. Shape and border.
Mm.
Yes,
What is
ma'am.
the significance? What is the significance? Border. Border of
Yes, ma'am.
hello.
Hello. Huh, ma'am.
What is Meigs syndrome? Okay. What other question is Meigs syndrome? Meigs syndrome. Okay. How will you manage this patient post-operatively?
Post-operatively,
Histopatho is suggestive of benign tumor. Okay.
yes, ma'am.
How will you advise this patient at the
Ma'am,
time of discharge?
post-operative at the time of discharge. Follow up after follow up every month, and will keep patient on antibiotics and
You are worried for what in future? Okay. Okay. From my side, it's all. No more questions. Okay. You can take
Madam,
next one.
can we move?
Now,
Can we move on?
take another can now. Next one. If Sangeeta madam is not here.
Okay. Because we are already late, madam, that's why. Okay,
Yeah,
thank
yeah.
you, Manjusha.
Okay, thank you, sir.
So Dharmi Joshi, Dharmi,
Yes,
we are
sir.
sharing your slide from here, our side. Sangeeta madam, yes, sorry. Sangeeta madam, you are there. Any question from your side, madam? Madam, you are not audible. Okay, madam. We are going ahead. Okay. चल असं आहे वाईट कितना बाकी चाहिए છેલ્લા ચાર એક બાકી છે હજુ નીચે સાહેબ પેલા બાકી છે હેમંત સાહેબ આવે છે ને પાછા એટલે આપણા નીચે વાળા સાહેબ શું યસ હેલો ધર્મી
Yes, sir, I'm here.
નહીં ધર્મી તમે રાજવીનું ખોલ્યું ધર્મીનું જોયું હતું પેલું હમણાં મેં ક્લિયરમાં જોયું હતું ના કૃપાલીનું છે અશ્વિની સાચી
Yes, sir. First one.
Yes. Okay. Sure. Yes, Dharmi, go ahead. Dharmi, go ahead.
Sir, my poster is not visible yet.
Sorry. Is it visible now?
No, sir.
Go to it. છેલ્લી ઘડી ક્યાં આવે છે પેલા ખાલી પેલું ફોલ્ડર ખોલો અને પછી કરો બોલો ધર્મી હા બસ પરફેક્ટ Is it visible now?
No, sir.
Something હોતો નતો ના ત્યાં દેખાયું હોય તમને ક્યાં દેખાય છે હવે કરો ખોલી કાઢો ને પછી કરો ખોલી કાઢો ઓકે હવે એને કરો શેર આપણે જે કર્યું તે કરો શેર Thank you. નવું કામ બરોબર હા શું થાય છે શું એટલે થતું ન હોય કે પછી ચિંતા બરોબર થાય છે
Wait a second, I'll share. I'll share. No worries. Wait a second.
It has started. From our side, it has started. Devendra bhai.
Yes, sir. Oh, visible.
Okay.
Good evening, everyone. Myself, Dr. Dharmi Joshi, second year resident from Pramukh Swami Medical College. Today, I am presenting a case of acute fatty liver of pregnancy and how emergency delivery and multidisciplinary management can lead to positive outcome for both neonate as well as mother. Under the guidance of my HOD, Dr. Nitin Raithatta, Dr. Smruti Vaishnav, and Dr. Sangeeta Pandey. So, gestational liver disorder affect about 3% of pregnant population. Out of this, acute fatal liver of pregnancy appears to be the most frequent etiological factor, accounting for 4%. It is a rare pregnancy-specific life-threatening condition. It is caused by toxic infiltration of hepatocytes by small fat droplets, also called microvascular fat. AFLP as a term was first described by Tarnier in as early as 1857. The risk factors associated with AFLP include first pregnancy, that is primigravida, multifetal pregnancy, a male fetus, and a low body mass index. The onset of disease is usually between 30 to 38th week of gestation, but it can also present in some cases in early postpartum period. The presentation ranges from non-specific symptoms like nausea, vomiting, reduced appetite, fatigue, abdominal pain and distension to some of the severe signs like elevated liver enzymes, hyperbilirubinemia, hypoglycemia, coagulopathy, and as severe as renal dysfunction and encephalopathy. Sir, next slide, please. My case is of a 27 years old priming gravida presented with 9 months of amenorrhea and complaints like nausea, vomiting associated with epigastric pain and loss of appetite for last 2 days. There were no complaints of generalized itching or diarrhea. On presentation, she was confused, not very well oriented, icteric, pale, and had grade 1 pedal edema. Vitally, sorry, sir. So, second slide, please. Vitally, patient was stable and obstetric examination revealed a single live fetus with transverse lie and not in labor. Laboratory investigation was sent, which were suggestive of hypoglycemia, hyperbilirubinemia, elevated liver enzymes, and acute kidney injury. She was planned for an emergency cesarean section, but in preoperative period, patient was transfused with 4 FFPs. She delivered a healthy 2.6 kg male fetus. In postoperative period, patient was shifted to ICU in intubated state for further management and stabilization. During her ICU stay, she received multidisciplinary treatment, including obstetrician, intensivist, nephrologist, hepatologist, and broad spectrum antibiotics. Discussion. AFLP is a diagnosis of exclusion, supported by Swansea criteria. Swansea criteria consist of 15 clinical, pathological, and radiological findings, out of which presence of 6 or more criteria in the absence of other diagnosis is consistent with AFLP. My patient fulfilled 8 criteria out of 15. AFLP is generally linked to a compensated defect in fatty acid utilization, which manifests in late pregnancy because mother is more dependent on fatty acid metabolism for energy in third trimester of pregnancy. Pathogenesis of AFLP is linked to defect in beta oxidation and an enzyme LCAT in fetus. However, it results in phenotypically as maternal liver disease. So, last slide, please. Hello. So, last slide, please. Hello. Hello. Sir, can you show next slide, please? Optimization of both maternal and fetal prognosis rest upon few points like early recognition, early delivery, supportive care, and in postpartum period, multidisciplinary approach. The cornerstone of management is an emergent delivery of the fetus, preferably by cesarean section, because we have earlier reports that induction of labor and vaginal delivery has led to poorer outcome, which are stillbirth or neonatal asphyxia for neonate, as well as acute fatty liver, leading to acute liver failure and renal failure for mother. The best practice guidelines suggest that if there is more than 7 positive Swansea criteria, the patient should be advised intensive care, and along with that, a multidisciplinary team approach for her liver management, and if required, in case of severe hepatic impairment, a transplant center referral should be considered. So, last slide, please. The role of placenta in pathogenesis of AFLP has been studied and proved as recovery is seen in most mother after delivery of the fetus as well as placenta. My patient recovered on the fifth post-operative day and she was shifted to ward on the same day. So conclusion, my case report highlights the importance of clinical awareness, rapid diagnosis coupled with prompt management in dealing with such potentially life-threatening condition, which has implications on mother in this as well as future conceptions. Thank you, ma'am. Sir, I have concluded my presentation.
Mona madam. Sangeeta madam, over to you, madam. Sangeeta madam. Checking. Mona madam. Sangeeta madam, you are not on audio. Madam, mic. Sangeeta madam, mic. Unmute, madam. Yes, now it is unmute. It's not audible, madam. अच्छा बस स्क्रीन में आवड़त नहीं होता तो बराबर છે તા આપણે લગી એમનો અવાજ કેમ નથી આવતો
Hello.
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 Yes, ma'am.
Am I audible?
Yes, ma'am.
Okay. How termination of pregnancy helps in prognosis of fatty liver?
Ma'am, I read that placenta allows the non-oxidized fatty acids from fetus to pass on to the mother. And deposits in liver, in hepatic cells, and leads to acute fatty liver. So after the termination, as both placenta and fetus are delivered, she will progressively
Improve.
Yes, ma'am.
What are the grading of fatty livers? Grading.
Sorry, ma'am, I will read about it.
Okay. In your case, hello.
Yes, ma'am.
What was the SG liver function test?
Ma'am, both bilirubin was raised. Total bilirubin was 7.8, and direct bilirubin was also raised. And SGPT and SGOT both were raised, but SGPT was significantly raised, above 78.
What is the effect of pregnancy on fatty liver?
In third trimester, mainly pregnant mother depends on fatty acids for energy, so it worsens fatty liver.
But how? What is the mechanism? What happens? Estrogen and progesterone, what they will do? I want mechanism. How
Pregnancy is a state of mainly progesterone dominant. Pregnancy is mainly progesterone dominant state. So estrogen is the hormone responsible for HDL mechanism in the body, good lipid. So progesterone will lead to deposition of more cholesterol and triglyceride and other fatty acids.
Okay. Next candidate we can take.
Thank you, ma'am.
Okay.
So, Dr. Dharmi?
Yes, sir.
So there was one question, as you are from the same institute as Sangeeta madam. I will
Sir.
ask one question that when it is with the acute fatty liver of pregnancy, what will be the outcome with diabetes insipidus and other association? Because this patient might, is it possible that they might land up
Yes,
in
sir.
diabetes insipidus?
Yes, sir. She might present with polydipsia and polyphagia, and can lead to diabetes insipidus and renal injury both.
Okay, so she might have multiple organ failure like picture,
Yes, sir.
and she might have long-term sequelae, right?
Yes, sir.
Yes, good.
Thank you, sir.
So we are moving to the next candidate. Hello. Yeah. સૌ તો હું આગળમાં જોઉં છું અને પછી તમારું લઈ લઉં છું. ડોક્ટર કૃપાલી, તમને હું મોકલું છું. ડોક્ટર કૃપાલી.
Yes.
Yes. મને હોલ બી નું જોઈશે. હો મને હોલ બી નું શેર કરો ને લોગિન આપણે બચે ને કઈ તો કંટ્રી. Yes, Krupal, you can share your course
Yes.
now.
Is it visible?
Yes, it is visible. Go ahead.
Good evening, everyone, respected judges and fellow colleagues. My topic is on a giant benign serous cystadenoma in a postmenopausal woman.
Krupal, your slide is not shared. Your presentation is not visible.
Okay, let me try and
Share screen. Your co-host, you will be able to do it.
Is it visible now?
Yeah.
Yeah.
Just make it full screen.
Yes, it is visible. Go ahead.
Yeah. Okay, good.
Good evening, everyone. My topic is on a giant benign serous cystadenoma in a postmenopausal woman. I am presenting this case under guidance of Dr. Mayur Gandhi, sir, HOD Associate Professor, and Dr. Naisha Goyali, Assistant Professor, Government Medical College, Bhavnagar. Giant ovarian cysts are uncommon but may occupy the entire abdomen and mimic ascites or other intra-abdominal masses. Serous cyst adenoma is a benign epithelial ovarian neoplasm, usually unilateral and slow growing. Very large lesions may produce pressure symptoms and major operative challenges. In postmenopausal women, malignancy must be excluded systematically even when tumor markers are low. The aims and objective are to present the clinical evaluation and surgical management of a giant left adnexal mass, to highlight the combined role of examination, tumor markers, ultrasonography, CECT, and frozen section, to demonstrate safe en bloc excision and staging when malignancy cannot be excluded preoperatively, and to correlate the operative and gross pathological findings with final histopathological reports. Any postmenopausal adnexal mass warrants systematic assessment for malignancy. Tumor markers support risk stratification, but must be interpreted with morphology and clinical findings. Large adnexal masses distort anatomy and increases risk of secondary organ injury, especially of bowel, bladder, and ureters. Frozen section can guide the extent of surgery when diagnosis remains uncertain. A 50-year-old woman presented in our OPD, para 5 life 5 menopause since 13 years, with chief complaints of abdominal pain and progressive abdominal distension since 15 days. She was a known case of type 2 diabetes mellitus for 2 years and was on tablet metformin 500 mg and tablet teneligliptin 20 mg. She had a history of tubal ligation 30 years back. On clinical examination, on per abdomen examination, the abdomen was uniformly distended, mass was reaching up to Xiphi sternum, and mobility was restricted due to the large size of the abdomen. On per speculum examination, there was nothing found in cervix and vagina. On per vaginal and per rectal examination, the lower borders of the mass were fed. The pouch of Douglas was smooth and cervix was clinically normal. Tumor markers were sent and evaluated, in which CA125 beta HCG, LDH, and CA199 were all normal and within the normal ranges. On US diagnostic workup, and in ultrasonography, large, well-defined cystic lower pelvic mass, probably arising from the left adnexa, was given, with the size approximating between 23 into 17 into 26 centimeters. Ovarian neoplastic etiology was considered and CECT was advised. In CECT abdomen and pelvis, a giant intraperitoneal abdominopelvic cystic lesion was given, approximating size approximating of 27 into 20 into 17 centimeter, likely arising from left adnexa and or ovary. Malignancy could not be excluded on imaging. So planned management was given, primary staging laparotomy under general anesthesia with intraoperative frozen section and definitive surgery according to findings was planned. This was the CECT plate from the case record. During surgery, the intra finding was given here. Left adnexal mass 27 into 20 into 17 centimeter gross. Smooth surface was present out on the outer part attached to the fallopian tube, which was removed intraoperatively. Frozen section was done, from which brownish fluid and multiloculated cyst was found, and no firm areas or papillary excrescence were given. On histopathology final report, benign serous cyst adenoma was the conclusion from histopath department. Total abdominal hysterectomy plus right side oophorectomy was done. Pelvic, bladder, para-aortic, pouch of Douglas, and peritoneal biopsies were sent to the lab, which turned out to be negative. And ascitic fluid was sent for cytology, which also turned out to be negative. Key take-home messages: giant ovarian cysts in postmenopausal women require malignancy-oriented evaluation, even when tumor markers are low. Tumor markers are supportive, not definitive. Imaging morphology, clinical findings, intra-op assessment remains central. Frozen section is useful to decide the extent of surgery when preoperative diagnosis is uncertain. This case demonstrates a rare giant benign serous cyst adenoma in a postmenopausal woman presenting as a massive abdominopelvic cystic lesion. Systemic evaluation of markers, USG, CECT, and staging laparotomy with frozen section and final histopathological examination helped ensure safe management and exclusion of malignancy. For very large adnexal masses, surgical planning should maintain oncologic safety while avoiding unnecessary over-treatment once benign disease is confirmed. Safest approach is systemic evaluation, intact removal, frozen section guidance, and final histological confirmation. Preoperatively, we did markers plus USG CECT plus postmenopausal risk assessment. Intraoperatively, we did intact end block removal, staging biopsies, and frozen section. Postoperatively, final histopathological examination was done to give that confirmation that the mass was benign and nothing more. Thank you.
Yes, you have said
Yes.
we should remove intact mass. Okay.
Yes, ma'am.
So how will you do that for possibility of removal of intact mass should be increased? What are the things you will do for operative?
Preoperatively, we'll go with the investigations and we'll look into the size, the margins, the extent of the tumor or mass, which we are looking for, that till which margins it is extending in the body, whether it is adherent or involving any other organs like bladder or bowel or anything. We'll look into the margins preoperatively. Intraoperatively, we'll try to dissect and see for the margins of the tumor, that if it is adherent to the surrounding organs or it is the margins are recognizable, then it is easy to remove and block. The tumor is easily removed.
One thing is that you will assess pre-operatively.
Yes.
Perfectly. Okay. Any other thing you can do to remove intact mass? Why you want to remove intact mass?
to avoid any spillage of if at all the tumor is malignant, there's this risk of spilling over the tumor cells into the cavity or into the abdominal organ. So we'll have to ensure that the tumor is removed in block.
We should consider every mass malignant.
Malignant.
Before it stems. Okay. Before it stems benign, we should consider every mass malignant.
Malignant mass, yes.
So other thing is incision. Incision should be enough.
Adequate size incision to
adequate size incision is required. Okay. Okay.
Sangeeta madam? Any question? Sangeeta madam?
She is there or not?
Yes,
I
Sangeeta madam.
think
Voice is, yes. Oh,
Sangeeta madam is not there, I think. I have not.
yes, yes.
She is there.
Yes. Madam, Sangeeta madam's voice is not coming. Yes, madam is there. So, madam's question is, after you have done the sulfingophorectomy, she will have menopause, right? And when she comes with that, will you consider hormone replacement therapy? And particularly, what will you give for HRT? What will you give for hot flushes and all? Yes, yes, ma'am. Yes.
The patient has
Sorry,
this
if it is hormone,
Will you
will you
consider
consider
her for
hormonal therapy
HRD?
for this?
Yes, yes. Will you consider her for HRD? She was age was your patient, age of your patient was
50-year-old female, 50-year-old.
50
Yes.
year. If she comes to you after 5 years with the postmenopausal symptoms, will you consider her for HRT?
For left side ovarian, left side ovary is still preserved. I would say will not go for HRT because there's this risk of there's this risk of hormonal
Only if she
induced tumor. So
if
they
she comes with the symptoms of hot flushes, will you consider? Because you might increase the risk on the other side, or you might not.
the risk will be higher than the benefit. So I'll try not to give HRT treatment to that patient.
So
Temporary problem of you have gone through for the total abdominal bilateral oophorectomy, no? So there is no problem of other side, but we are
left-sided ovary is preserved.
Left side ovary you have preserved in your
Yeah,
case.
only right-sided oophorectomy was done. Left-sided ovary was kept in
Preserved.
situ. Yes.
So madam's question was, will you add fuel or will you not add fuel, or you will add intermediate only symptomatic control fuel, HRT for short term or no HRT?
Give your view. Give. Hello.
Krupali?
She is not there.
Yeah, internet, yeah, internet also.
Next candidate.
Yes, yes. Dr. Rajvi? Rajvi, you can share.
Yes, sir. Hello.
Yes.
Hello, ma'am. Hello, sir. Myself, Dr. Raju Nagaria. Am I audible?
Yes, yes, you are audible.
Today my case presentation is dual postpartum emergencies, Praise syndrome with retained product of conception. A 28-year-old multipara presented 12 days after an uncomplicated vaginal delivery with refractory worst headache of her life, scotoma, and generalized tonic-clonic seizure. She had received a loading dose of magnesium sulfate at a peripheral center before referral. On admission, her blood pressure was 105 mmHg. Neurological stabilization was achieved with intravenous magnesium sulfate and intravenous labetalol. Then we have conducted MRI brain and MRA demonstrated features consisted with press and early changes for RCVS. Concurrent evaluation for postpartum endometritis and RPOC revealed a bulky uterus with 2.5 by 1.5 centimeter ecogenic intrauterine mass on transvaginal ultrasound. Following 48 hours of broad spectrum antibiotics, gentamicin and clindamycin, and hemodynamic stabilization, ultrasound guided suction evacuation was performed, retrieving 15 gram of organized placental tissue. Prophylactic methyl alcometrin was administered. Post procedure, follow-up ultrasound confirmation, complete evacuation. Patient remained neurologically and hemodynamically stable, was transitioned on oral antihypertensive therapy, and was discharged without complications. During treatment, we have also done physician reference and ophthal reference. Physician reference advice was that start Levipil. So we have also started levetiracetam 500 mg, 101. And on ophthal reference, there is no sign of papilledema noted. When the patient came with a loading dose on outside periphery center, and inside in our Certi hospital, we have given 6 maintenance doses of magnesium sulfate, 4 hourly, 6 doses.
Yes, yes, go ahead.
Yes, ma'am.
Mm.
My case presentation is over, ma'am.
Presentation is over. Okay.
Sorry,
How will you
from
monitor?
our side, the slide could not be shared. Some technical issue is there.
Okay.
That's why.
One minute, ma'am.
That's okay.
If you have physical paper, you can go ahead.
Okay.
Any question?
Okay. How will you monitor magnesium sulfate?
Ma'am,
Rajvi?
before giving the magnesium, yes, ma'am. Before giving the magnesium sulfate, we go for 3 things: vitals, and then knee jerk. First, we monitor, then go for respiratory rate, and then urine output. Because magnesium sulfate causes knee jerk reflex loss, respiratory depression, and decreased urine output means renal injury. So these 3 things first we monitor, then pulse, BP, urine out, pulse, BP, SpO2, all
Okay,
other
suppose
things, vitals are
magnesium,
also monitored.
suppose knee jerk is absent. What you will do?
Ma'am,
Knee jerk is absent, urine output is less. What you will do?
loading dose, ma'am, we can give, but no, maintenance dose we are not giving.
While you
Skip
are
karte
monitoring the magnesium sulfate, you come to know that the magnesium toxicity is there. Okay, what you will do?
Ma'am,
Magnesium
when
toxicity is well diagnosed. Now what you will do?
ma'am, we can give calcium gluconase and antidote.
Then, okay. To counter this magnesium sulfate, you will give calcium gluconate.
Calcium gluconate.
Okay. And then other thing.
Diuretics, ma'am, furosemide.
But then You have to switch over to other anticonvulsant. You will not stop magnesium sulfate. You will give calcium
Ma'am, we
gluconate,
can,
but you will not stop magnesium sulfate.
ma'am, we can give phenytoin as an alternative.
Okay. What are the regimes to give magnesium sulfate?
Sorry, ma'am.
Hard and
Ma'am,
prescribed regime.
Pichard regiment we can give. First is loading dose, and second is maintenance dose. For loading dose is 14 gram, and of IV, and maintenance dose is 5 gram IM on alternate buttocks.
Okay. Well, you have done suction evacuation for retained product. Okay.
Yes, ma'am.
In your case. What are the likely complications?
Of suction evacuation?
Mm-hmm.
First, ma'am, uterine perforation is common during retained product of conception suction evacuation. Bleeding, infection, septicemia.
What is secondary PPH?
Secondary PPH means hemorrhage, bleeding occurs after 24 hours of delivery.
So in your case, it is after 20. You have done retain
After
suction evacuation
24 hours.
after.
Yes, ma'am. After 12th day of 12th postpartum day.
So how will you prevent PPH? Secondary PPH, especially.
Secondary PPH. Ma'am, first we can give uterotonics like oxytocin, methyl ergometrin, carboprost, misoprostol.
Okay. Okay.
EMDs.
Okay. From my side, it's over. Any other question from any?
Yes. Yes. Yes, sir. Yes. Okay. Yes. Question from Sangeeta madam. Said, can you tell me the serum value of magnesium sulfate? What is the ideal requirement or the base minimum level? What is required for the effect? And at what level the knee jerk will disappear?
So 4 to 7 is therapeutic range. 4.
And cut off at what level the knee jerk will go?
Sir, knee jerk will go at the level of more than 9.6 milligram per deciliter or more than 4 millimole per liter. And respiratory arrest depression occurs when more than 12 milligram per deciliter dose is there.
Okay. So do we measure it any times in any institute? Technically, do we measure it?
We decide by clinically after knee jerk.
So we usually do not measure it. We go by the clinical parameters. Secondly, madam has asked, okay, if it is a partial accreta, focal accreta, when you are doing DNE, you said there was RPOC. There were some bits of product were left.
Yes, sir.
Can it be accreta? How will you manage?
Yes, sir. It can cause secondary postpartum hemorrhage.
In your case, you said there is a RPOC, right?
Yes, sir.
So possible it was accreta.
Possibility of accreta. Yes, sir. There is possibility of accreta.
Focal accreta.
Focal accreta. Yes, sir. There is possibility of a focal accreta.
Management.
So methotrexate we can give.
Okay. Fine. I think so. Madam must have taken your answer. Madam, should we go further for next
No,
candidate,
no.
last candidate. Okay.
Last candidate?
So
Okay.
yeah, thank you.
Hmm.
So last candidate, Dr. Samriddhi.
Everyone is there.
Dr. Samriddhi, you are already made co-host. You can share. Are you there?
We have taken everyone, no? No one left.
Samriddhi, Dr. Samriddhi. Oh, sorry. Okay.
Oh, eight out of 8 candidates we have taken.
Yes, in my list there was one Dr. Samriddhi and she has already logged in also. Have we taken
No,
it,
no.
madam?
In my list, Dr. Samriddhi is not there. 8 is there. 8s are there. And we have taken all 8.
Okay.
It's
Let me
over.
just
I
follow
think
once.
it's over.
I also feel so because in my list Dr. Samriddhi is there and she has also logged in, but she is not responding.
In your list, candidates are 8 or 9?
Nine, madam.
Okay. In
9.
my list, 8.
But perhaps she is not in contact. Somehow she
Okay.
is not. We are not able to
Uh,
contact her, and we have also messaged her, but no response.
mm,
So perhaps we
okay.
can end the session, madam.
We can
And it
conclude.
was,
Mm.
Sangeeta madam, it was really nice. Mona madam, it was really nice to have you as a judge. The candidates must be proud that you are having a professor or teacher like you.
Okay. Thank you. Welcome.
Thank you,
Okay.
madam, and
Thank you.
thank you to all the participants also.
Thank you.
So we will have valedictory function short in Hall A in short while. So please join in Hall A, madam.
Okay. Sure.
Yes. Thank you. Thank you, madam. Thank you.
Thank you. Thank you.
Yeah.